All right, good morning, everyone. It is 8:03 a.m. on March 27th, 2026. This is the meeting of the Texas Medical Board. Go ahead and call the full board meeting to order. And I'm going to just read the mission and then we'll have roll call. Our mission is to protect and enhance the public's health, safety, and welfare by establishing and maintaining standards of excellence used in regulating the practice of medicine and ensuring quality health care for the citizens of Texas through licensure, discipline, and education. With that, we'll go ahead and have roll call.
Dr. Zaffron,
Present.
Dr. Farmer,
I'm here.
Mr. Kokonos, Mrs. Barnes,
Present.
Dr. Bhatia,
Present.
Mr. Crane,
Present.
Dr. Deloche,
Present.
Mrs. Del Rosal,
Present.
Dr. DeStefano,
Present.
Dr. Green,
Present.
Mrs. Harrod,
I'm here.
Dr. Jones, Dr. Martinez,
Here.
Mrs. Morgan,
Here.
Dr. Naidu,
Yeah.
Dr. Quinones,
Present.
Dr. Tibbles,
Here.
Mrs. Troncoso,
Present.
Dr. Vanderwide.
Yes, sir.
I count 16 out of 19. I guess we will try to annotate on the record when Mr. Kokonos, Dr. Jones, and Dr. Tibbles are able to join us.
All right, great. Thank you.
Tibbles is here.
Yeah, I'm here.
Oh, sorry. I didn't think I heard you. All right, good. So I think we have 17 out of 19.
Okay, thank you. All right, first agenda item is board member report. The only thing that I'm going to mention with that is that a message from the president was sent out to all of our licensees, I believe last week. One of the things that we wanted to inform all of our licensees is much more of the process around how we are trying to streamline a lot of our investigations that come before the board. As all of you know, we are a complaint-driven agency. We receive a fair amount of complaints every year. And the idea was to streamline that process as best as possible. But one of the things that I just wanted to emphasize probably more than anything else is that there will be questions that will be asked of our licensees when investigations come in. And I just encourage our licensees to answer those questions as best as possible, because in many instances with that may actually avoid us going into a full investigation. Without that answer, though, or without that kind of context, the board really in many instances will not have any choice but to go to a full investigation, assuming that it's something that is jurisdictional to the board. There's a lot of good information on there, especially about some of the legislative stuff that passed the last session and the rules that have been implemented since then or are being implemented since then around those. And a lot of the things that were also passed at the last board meeting that, again, those rules going through the implementation process. One of them, of course, is the new licensing process that also was, again, passed at the last board meeting. I believe that has gone into effect in mid-February. So that those applications are on the website. I'm not sure yet if we've gotten applications coming through, but as this is a new type of structure, it'll be a little bit of a learn in progress type of thing. But a lot of that information and FAQs are on the website. There should be hopefully as much information as possible on there to help those who may be eligible go through the process. The other thing that I would just mention, number one, is CE Broker, which is an item that the legislature has asked us to make sure that there's a continuous process of auditing or tracking CMEs. That has gone live, but on a voluntary basis, but that will be mandatory starting September moving forward. It is a free it's a free tool. Obviously, there's a premium tool that is attached to it, but the basic tool is free. It's just a matter of making sure that our licensees upload their CMEs onto the tool, and the board has the ability to track that on an ongoing basis. I emphasize once again that that is something that the legislature passed, and it was mandated on the board to implement that. So that again is something that will start in September. I believe those are the primary things that are going to be happening fairly soon. All right, with that, we'll go ahead on to agenda item number 3, which is consideration of possible action regarding dispositions below minimum guidelines. There are none there. Consideration and approval of mediated settlement agreed orders. There are none there. Agenda item number 5. These are consideration and possible action for remedial plans. Under there are several sub entities. I will ask initially first if there's any recusals on agenda item number 5 or extractions on agenda item number 5. Seeing none, is there a motion on agenda item number 5, which is consideration and possible action for remedial plans?
Quinones, motion to accept the consideration and action for remedial plans as outlined.
All right, motion by Dr. Motion by Dr. Quinones and seconded by Dr. Bhatia. Is there any further discussion? All those in favor, please say aye.
Aye.
All those opposed? Agenda item passes. For number 6, just for those of you who just to make sure that it's clear, agenda item number 12 was consideration approval of determination of default. That item, there has been an agreement on that one, so that item has moved to agenda item number 6. So when I ask for extractions or recusals on that, just please note that that item is on there if anyone wants to extract or recuse themselves from that one specific item. So with that, consideration and possible action for agreed orders. Are there any extractions or are there any recusals on this agenda item? Seeing none, I will go ahead and take a motion on agenda item number 6.
Quinones, accept the motion to accept the consideration and actions for agreed orders as outlined in agenda item 6.
All right, is there a second?
Second, Barnes.
Okay, I think there's a second by Ms. Barnes in there somewhere. Is there any further discussion? All those in favor, please say aye.
Aye.
All those opposed? All right, agenda item number 6 passes. Number 7, consideration and approval of modification request termination request orders. There are 7 items there. Are there any extractions or recusals from agenda item number 7? Seeing none, is there a motion on agenda item number 7?
Move to accept the MRTR orders as listed.
Second, Barnes.
Is there? And it's seconded by Ms. Barnes. Is there any further discussion? All those in favor, please say aye.
Aye.
All those opposed? Agenda item passes. Number 8, consideration and approval of modification request, termination request of non-public rehabilitation orders. There are none there. 9, consideration and approval of cease and desist orders. There are none there. Number 10, consideration and approval of revised, vacated, or amended orders. There are none there. 11, consideration and approval of consent orders. There's one agenda item there. There's one item there. Is there any recusals or extractions on agenda item number 11? Seeing none, is there a motion on agenda item number 11?
Motion to approve agenda item 11.
Second.
Which is, okay, which is consideration and approval of consent orders. So that was by Ms. Morgan and seconded by Dr. DeStefano. Is there any further discussion? Seeing none, all those in favor, please say aye.
Aye.
All those opposed? Agenda item 11 passes. As I mentioned earlier, 12 was incorporated into 6, so that item has already passed. Agenda item number 13, those are the consideration approval for proposal for decision. That is not going to be until 9:15. So I will skip that item and we will return back to it at the appropriate time. With that, I'm going to go to agenda item number 14, our executive director report. Mr. Carlson.
Yeah, thank you, Dr. Safran. Good morning, board members. So you did get a fairly in-depth financial report yesterday. So we won't go through all of that today, but we'll hit the highlights for you. And so I'll turn it over to Joey, who can give you a brief rundown on where we stand with the budget. And then we can also just hit a couple of the highlights on where we are for our legislative appropriations request. We'll see what questions you have for us. Go ahead, Joey.
Thank you, Brent. Good morning, board members. So as I mentioned yesterday, we're still operating in the red a little bit, but overall we should collect sufficient revenues to get us through the end of the fiscal year. We also had a lot of discussion on our approach for the legislative appropriations request. So we will be taking that guidance and moving forward for the next board meeting. A lot of data gathering to support our request going into session this coming up January. And overall, we're projecting maybe to ask for an additional $10 million each fiscal year starting in 2028, 2029. Half of that's for salaries, half of that will be for IT-related projects and just operational costs that we need to support for the agency to continue meeting its mission. Other than that, I can hand it back to you, Brent.
Yeah, thank you, Joey. Again, I know you guys got a pretty in-depth one yesterday. And again, just to highlight for our legislative appropriations request, as Joey said, about half what we're looking for is for operational cost increases. That's just due to the cost of inflation as things get more expensive each year, even if we're using the same software or buying replacement laptops and servers and things of that nature. But also the other half of it approximately is for requested salary increases. Joey gave you, again, a lot of details of how we've done this analysis of how we compare to other state agencies. But another thing I wanted to really make sure that we focus on is, even if, we do want to get to at least the midpoint of where other state agencies are, but even if we can't do that, we need to at least have it where people are not making less money each year. And so inflation has been high over the last few years. Since about 2017, we're at about 35% inflation since individual salaries at that time. And so while we have made a lot of progress with many of our positions doing an analysis, there are a few where the positions have not even seen a 35% increase since 2017. So technically those positions are getting paid less than they were back then. So that is something that we are going to really focus on for this 2027 session. The 2026 internal audit plan. Joe, did you want to hit any highlights yet on the audit that you had, or you want to save that for a future meeting?
I can briefly go over that as well. So the comptrollers did a financial audit that started back in October, and hopefully by next week we will be meeting with that team again to wrap up and start drafting a report to go out. Just a couple quick notes on that. The big key takeaways for that were travel was a big item for there were a lot of findings that they didn't kind of like how we were operating. So I know a lot of y'all have been involved in that new process and procedure. So we were addressing that. The other one was the uses of our credit cards and how we were going about doing that. So we've made some changes to that. And just some other administrative items that they kind of didn't like how we were operating. So we will get some feedback from them and then just kind of change to stay in compliance in the manner that they feel that we need to be moving forward in that direction. So once that draft is finalized or the report is issued, I can push that out to everyone for review.
Okay, thank you. And then in here, I believe, do we need a vote to accept the internal audit plan for 2026?
That also, I believe we need to do. So for our internal audit, we are going to target the physician health program that is statutorily required. So we just need a vote and approval on that from the board members to continue with that process moving into 2026.
And again, this is, you guys are familiar with this. This comes up every year. There is at least a portion of the agency that has the internal audit done. And statutorily, every 3 years, we're supposed to do this for the Texas Physician Health Program. And it's their turn. That's come up again. So It's a requirement, but we still need the board's approval of the internal audit plan.
All right, so I will take that as a directive for us to make, is there a motion to accept the internal audit plan?
Motion to accept the internal audit plan, Barnes.
I'll second.
Seconded by
Everybody.
Dr. Deloche, I think.
Thank you.
All right, all those in favor, is there any further discussion? All those in favor, please say aye.
Aye.
All those opposed? All right, motion passes. Mr. Carlton?
Yep. And here in just a second, we will have a presentation from our partners at CPEP. Ms. Alyssa Johnson is going to be doing that. But while she's, I guess, getting ready to present, I will cover briefly. You did mention House Bill 2038 and changes that have happened since the last legislative session. Beginning in February, we did start accepting applications for individuals looking for the provisional license pathway that are internationally trained medical graduates and those that have a license in another country. And then also those that are looking for the physician graduate, again, those individuals that have graduated from medical school but have not completed a U.S. residency requirement. We have started accepting applications for those. As of the last count, when I looked, where we're approximately about 30 total of between both of those license types. So it is still pretty new. We are going through the process of going through those applications. I think the very first person that applied actually was probably a better fit for a full license than the provisional license. And so it is a bit of making sure we're getting the right information out to individuals that they're applying for the one that is best suited for their educational and training history. But we are accepting them, and I want to say we've got about 30 or so between the two new types. None of them have been issued as of yet. Okay, we will move to CPEP now. Mrs. Johnson, are you ready?
I am ready. Can you hear me okay?
Yes, we can. Good morning.
Okay, perfect. Good morning. And is it possible for Alicia to share my presentation? I don't have the ability to share
Yes,
with the
ma'am.
link. Thank you. All right, while that's happening, I'm going to go ahead and get started and just introduce myself. I'm Alicia Johnson. I am the Chief Executive Officer at CPEP. I have been with the organization since 2014, and I recently took over the CEO duties from our longtime CEO, Beth Korinick. Some of you may have met Beth over the years or know Beth. She retired in December 2025. So thank you so much for giving me the opportunity to present to you all today. I certainly appreciate it. Next slide, please. Okay, great. So for those of you who may not be familiar or know about CPEP, CPEP is a nonprofit organization. We were founded in 1990 to help clinicians, regulators, and health system objectively address two primary areas, one being performance concerns with clinical competence, and the other being performance concerns with professionalism. We are very much committed to patient safety in our organization. Our programs and our seminars are really designed to improve quality of care, and we work with just about 800 clinicians on an annual basis. Next slide, please. So just to stress to you all in the work that you do from a regulatory standpoint, CPEP is an organization that exists to support the work that you all do through two primary programs that we offer. We have professionalism seminars. These are highly robust, very effective intervention pathways that are really designed to remediate problematic behavior and decision-making. And then the other way that we support the work that you all do are through our clinical skills competence assessment programs, which provide an objective opinion and very detailed information about a clinician's ability to practice safely. And one thing that I want to stress is that we are always here as a resource. We are here to provide consulting. If the board is ever dealing with a situation or a challenging case and they want to consult with members of our staff or myself, we welcome that, and we are always here to support you. Next slide, please. So we work with participants that originate from all over the United States, and we have actually worked with participants who have originated from all of the state medical boards. This slide really depicts the use of CPEP programs from a Texas-specific standpoint, and the data that you see represented here is really representative of health systems and clinics. So you can see that the most utilized programs from a CPEP perspective are our medical record keeping seminar, our probe ethics and boundaries seminar, and our clinical skills assessment program. Next slide, please. So if we drill down a little bit farther, and I actually focus on Texas Medical Board referrals, specifically, you can see that historically speaking, usage of CPEP programs by the board is pretty small. So I do appreciate the opportunity to get the word out about our program, and I'm really hoping that in the future we can change that. Next slide, please. So let's talk a little bit about our professionalism seminars. This slide depicts the different types of seminars that we currently offer. The ones that you see circled in red are the ones that are most commonly utilized by regulators. And I'll talk a little bit at a very high level about a couple of seminars in just a second, but I wanted to just present the hallmarks or the common characteristics of all of our seminars. So our seminars are all designed for the adult learner. They're conducted virtually currently, but they are not passive CME. They are highly interactive. They're taught by highly qualified healthcare professionals who are experts in their representative fields. We have multiple faculty who participate in each seminar that we offer. All of our seminars are small group format. We cap and limit class size, if you will. Typically, we do not allow more than 16 participants in any given seminar, with one exception, and that exception is our medical record keeping seminar. And we typically cap enrollment in that particular seminar at about 25. Our seminars involve active learning, the development of action plans, written assignments, essays that are really designed to help clinicians and our participants apply what they learn to their actual practice and facilitate change over time. Next slide, please. So one of the two seminars that I'm going to highlight today is our PROBE program. This is our Ethics, Professionalism, and Boundaries program. It is our most highly utilized program. We give this particular program 28 times a year in the United States and in Canada. It is a 2.5-day pass-fail educational intervention specific to ethics for clinicians who are under discipline, and the discipline is typically related to such things as misrepresentation, lying, omitting information, credentials deception, unlicensed practice. We see things like billing issues, criminal fraud related to billing. We have folks in this program that are having clinical issues around medical errors, substandard patient care, poor prescribing, poor record keeping, inappropriate use of the electronic medical record. And then we also see a fair amount of clinicians with boundary violations, sexual misconduct issues, drug diversion, privacy and respect issues. So in this course, the clinicians are asked to analyze the specific ethical infraction that brought them to the course. Our faculty spend a lot of time teaching them about the various ethical frameworks And then the participants are asked to apply what they've learned in the course to their particular ethical misstep or infraction. And they do this through class discussions, through written assignments, and through a final essay. And as I mentioned, this class is pass-fail. A pass-fail grade is assigned at the conclusion of the seminar. Next slide, please. The other seminar that I want to highlight very, very quickly with you all is our medical record keeping seminar. This is an 8-hour seminar, and the seminar really focuses on principles and the fundamentals of good documentation. And I'm not going to go through the seminar specifically with you, but one of the hallmark activities in the seminar is that anyone who registers in this seminar is given the opportunity to submit several progress notes from their practice for our faculty members to review prior to the seminar. And this is at no charge, and our faculty members will spend time looking at those progress notes. They will identify strengths and weaknesses in the progress note and give participants an opportunity to with suggestions for improvement, things to do differently in the future. The other piece of this program that we find very effective, there is a 6-month follow-up longitudinal coaching program that accompanies this program, where participants get feedback on their progress notes and their documentation and their patient charts at 2 months, 4 months, and 6 months. This is really focused on sustained improvement over time, and at the end of the follow-up program, a pass-fail grade is assigned. Next slide, please. The other significant area of programming from CPEP's perspective are our clinical skills assessment programs. And under the umbrella of assessments, we offer a number of different programs. All of the programs that you see here, and especially those, again, that are circled in red, are the ones that regulators use most commonly, but there are some underlying commonalities for all of these different programming programs, in that they are all designed to evaluate a clinician's underlying medical knowledge, clinical judgment, documentation, and hands-on technical skills, if that is something that is appropriate for their specialty. And all of these assessment programs provide the regulator an objective opinion on whether a clinician is safe to practice. The majority of the assessments that we do these days are conducted remotely, with 2 exceptions. If there is a requirement by the referring organization or the regulator that the assessment occur in person, that is something we can absolutely do. And the other exception is that if there is a hands-on demonstration of a procedural skill, that does require travel to Denver to engage in an in-person simulation. And I wanted to just spend a little time. I heard here recently, and I actually had a call a few weeks ago with Scott Freshour at the board about the Texas legislation related to international medical graduates and internationally trained physicians. And I wanted to give you just a little highlight of CPEP's work with that particular clinical population. There was a clinical readiness program that was established through the Colorado legislature in 2022. And the intent of that particular program is to help international medical graduates, internationally trained physicians living in Colorado to enhance their clinical knowledge and their skills, and to demonstrate readiness to successfully enter a Colorado primary care residency. So CPEP has been involved with that program, and we were actually asked to do a pre and post program assessment to guide the training of this particular cohort of clinicians. And I'm not going to go through all of the specifics of the program and or how we evaluated the skills and abilities and knowledge of these individuals, but there were some things that we learned that were surprising to us that may be relevant to you all as regulators. So since 2024, we have 3 cohorts that have completed this pre and post assessment program. 12 clinicians accompanied, basically participated and were a part of that cohort. And here are some surprising things. What we learned is that the time out of practice for these individuals was far longer than we anticipated. It ranged between 7 and 17 years. The time in actual clinical practice was actually much shorter than we expected. It ranged between 2 and 5 years. And at the time that we did the initial pre-evaluations for each of these cohorts, none of these clinicians demonstrated readiness to enter a residency program, and none of them had the skills, abilities to practice independently. So wanted to share that experience with you. I think our experience really supports the recommendations and the guidance that is out there regarding the use of assessments during any kind of supervisory period for these particular clinicians. And I think it also supports the value in having an assessment to support medical boards in their licensing process. Next slide, please. And lastly, I just wanted to share this brochure with you all. This is our most comprehensive brochure. It does include all of our programs organized by problems and issues that you all as regulators may face. It gives you a listing of the particular program that might be most appropriate to address that particular problem. And then on the next slide, it provides a description of the program. It provides cost to you all. And if CME is available for the program, that is listed as well. Next slide. And that is what I was just describing. And then finally, I have included my contact information on the final slide of this presentation. If you have any further questions, you're welcome to contact me directly. I'm happy to consult and or address any issues that you may be facing. And with that, I'll go ahead and take any questions.
Johnson, thank you. Oh, go ahead.
Crane. I have a quick question. Several of your program, well, your entire program is focused on physicians, but I think out of the 444 hospitals, a lot of the CEOs would like to take some of these programs. It would help evaluate the physicians on their staff when problems come to them. I don't know. What do you think, Ms. Johnson?
So I would say that's not typically our audience or our I guess the individuals that we serve. However, we are starting to develop programs that are specific to clinical leaders in health systems, in hospital systems, that would be educational in nature to try to help educate that particular group of individuals, those leaders who are supervising other clinicians, and give them the skills and abilities to do those types of things. I would say, though, in the short term, if there are concerns about performance or concerns about professionalism, we just welcome a call. Call us. We will educate that leader on what we believe would be most appropriate for the situation they're dealing with. And I will stress, we are not self-serving. So it's not a call to get you to enroll in a CPEP program. It's a call to help you have all the information necessary to make those types of decisions and decide what's best for the situation. And we have a lot of connections and resources. If we're not the right person to help, we will recommend someone who is. Does that answer your question?
Well, pretty well. I'll contact you personally, though.
Please do. Please do. My contact information is definitely in the slide deck.
Okay, thank you.
Any other questions from the audience?
I had a quick question. So in review of the Colorado program that you discussed, you mentioned that they'd been out of practice for 7 to 17 years, but had 2 to 5 years of experience. What time frame does it take to be able to get those clinicians ready to be actually be able to practice, or is that part of your task?
So we are actually not the entity that is doing the education and training of these individuals. That is being done by Denver Health. What CPEP's work is to do a pre-assessment and a post-assessment during that education and training program. And right now that program is running about 9 months over at Denver Health.
And do you see that I mean, obviously they don't pass if they don't get there, but of the people that are going through the program, are the majority of them able to achieve the necessary credentials or abilities in 9 months?
So essentially, yes, we see demonstrated improvement, and I would be happy to share the specifics about that. So where they tested from a pre-assessment standpoint versus post-assessment, and how they progressed on that spectrum of performance and how they achieved. Essentially, the goal is readiness for residency. It's actually not readiness for independent practice. I do want to stress that. But yes, so far, our understanding of sort of the outcomes is that the first 2 cohorts, those clinicians all secured primary care residencies. And so that really is the success for this particular effort.
Thank you.
Sure.
Yeah, thank you. That was an excellent presentation. One thing that I do want to bring up, I spoke a little bit about House Bill 2038 and how the implementation of these provisional licenses are moving forward and have gone into effect in February. It's a little bit of a complex bit of legislation and rulemaking around it because, of course, one of the things that we have to be very mindful of is making sure that that as we look at these provisional licensees, that it's that we're going through a process to evaluate their competency in the declared specialty that they are coming in through. And one of the things that we had highlighted as we talked about House Bill 2038 is that if you come from a residency program that is accredited by ACGMEI, which is in a certain number of countries and a certain number of residency programs or graduate medical education programs overseas, that would be sufficient to look at that program as being appropriately vetted for competency. And I believe it was having finished within the past 2 years. So if they've been out of practice or not been practicing for more than 2 years, or they are not from an ACGMEI program, we have been looking at other alternatives to evaluate competency. Some of it may be other organizations other than ACGMEI that will come before the board and who have a process to show us that evaluates competency. But one of the things that we mentioned, at least, is that if you're coming from a GME program that doesn't have that vetting, that we will ask the licensees to go through some other type of competency evaluation. And the one program that we had talked about very specifically was K-STAR.
Sure.
But there are other programs out there that we are looking at that may meet that process and that standard. And this is one of them. CPEP is. We're, I believe, still going through the process of evaluating and making sure that they meet those standards. And I think, they've gotten off to a very good start. And that's why you're partially hearing some of their presentation today, is to kind of give you a little bit of a flavor and idea of what they have to offer. PACE is the other one that's out there that also does an assessment of competency for those who are, again, declaring a certain specialty and are looking to go through the provisional licensure program. And obviously, there may be others that we will be evaluating. The idea, of course, is to make sure that there are many options out there, but the vetting of the process of those options gives us the comfort level, especially as we're looking and making sure that we're protecting our patients in the state of Texas, that as we put these licensees through the first provisional license, that they've gone through that appropriate vetting. So this is one of those first stages of the entry point. Obviously they have to have had ECVMG certification that involves USMLE Step 1, having passed USMLE Step 2, proficiency in the English language. It vets their medical school training. That's the ECVMG certification. The second part, of course, is the evaluation of the GME program, which is this. And if they don't meet that standard, then it's the competency evaluation, which would involve entities like PACE, CPEP, and KSTAR, and maybe many others. And then, of course, there's a whole other process once they get into that provisional license of how we evaluate them to go through the first 2 years in an ACGME accredited facility, the second 2 years or the second provisional license in a critical access area, and then the potential to come back to the board and be evaluated for the possibility of an unrestricted license. So again, these are things that you may be seeing in each board meeting as we are presenting you with some of the different entities that may be part of that process. And this is one of them. So again, thank you for coming here and talking to us, giving an opportunity for the board members to ask questions. I wanted to just kind of give that 30,000-foot flavor just to kind of give everybody an understanding and a perspective of, number one, your great presentation, but number two, what this is also part of in the larger picture, and give the board members an opportunity to, reflect on that. If they want to ask questions around that also, they kind of know where this is all coming from. So thank you.
My pleasure.
Yeah, and just briefly, I know we got a couple more questions, but just briefly to expand on what Dr. Zafran was saying, for those that may be listening that aren't as familiar with 2038 and kind of how we got here, the reason that CPEP, PACE, KSTAR, and those type of organizations are so important is because these individuals, they do have a full medical license in another country, but they have not done the traditional medical residency here in the United States. And so there are just not enough medical residencies that exist to keep up with the pace of demand for new physicians as our population grows. And so in the past, these individuals would have had to apply for a U.S.-based residency and would have been competing directly with other U.S.-trained medical graduates and other individuals. And so this is a pathway to get them up to the standard that we need here in the United States for practicing medicine, and to ensure they're at that standard without necessarily having to compete with other U.S. medical graduates, or for them to repeat training that they've already accomplished in another country. So again, thank you to CPEP, KSTAR, and PACE for being willing to partner with us to go through these assessments as we process these applications. All right, the next one is Dr. Green.
Brent or Dr. Zafran, do you know yet at what juncture the PACE and the CPEP will be implemented in that process for the incoming international medical doctors?
Yes. So, and Grace, if she's on, she can also speak to it. I was director of licensure as processing these. The idea is to go through and make sure that we've kind of gone through all of the the preliminary checks, that we've received all the documentation that they need for the application. Want to do that evaluation to see what they turn in for what training they did, to see if, like Dr. Zafran said, if it's an ACGMEI program. We want to make sure that people are kind of vetted far enough in the process that it looks like, okay, at least on paper, you have a good chance of getting to the end of getting the license. We don't want individuals to go and just start doing these evaluations on their own. Because there is a financial cost to it. It's not free, and it is going to be something that the applicant has to pay for. And so we want to make sure that they look like they're going to be able to get through before they take a pricey, but needed evaluation, and then not be eligible for some other reason. So staff will notify them kind of, hey, you've met these requirements, and now we're going to need an assessment from you, and they can start that process.
And for example, in ophthalmology, there are not yet any ACGMEI programs. That's a necessary first step, though, right? That has to be where they came from.
So remember, the ACGMEI evaluates the residency program in, I believe they're in 14 countries right now. So those GME programs may probably do involve ophthalmology also. So if they come from an ACGMEI program and have been practicing within the last 2 years from one of those programs, then obviously a lot of this would go through the licensure committee, but these would have been properly vetted at least. So again, it's the ACGMI vetted programs in those countries, in those specific residency programs. Anybody that's not been vetted through an ACGMI program, or there, like I said, there may be others that come to us and say, hey, we can do what ACGMI is doing. And just like we're doing with CPEP and PACE and others, we can evaluate that, make sure that their process is appropriate, and that may expand those number of programs that we feel have been appropriately vetted. But if they have not been vetted through that process, or they have not been practicing for a certain number of years in medicine, then and are not they have to be licensed at least, then or have been licensed, then they would go through these processes over here. Hopefully that answers that.
Dr. Quinones?
Yes, thank you, Ms. Johnson. That was an excellent presentation. I sit on DPRC, the Disciplinary Process Review Committee for the board. I was just curious, do y'all make any accommodations or arrangements for possibly a representative of the board or a member of DPRC to sit in and monitor one of these programs? For example, the Boundaries program, or the or even the medical records program. Is there any? Do y'all make any accommodations for a member to come in and see and sit for the whole program and see what it's like? I mean, if I'm going to create an agreed order to one of my respondents or to one of my licensees and tell them that they've got to take this course as part of their agreed order, I'd like to at least know what it's like, or feel comfortable with it.
So absolutely. I would say absolutely with a caveat. We are happy for observers to come and participate in our courses. However, I would say it depends on who is in the course and who is participating from a participant standpoint. We don't want a regulator participating with a licensee, and sometimes that is a concern. So I would say that we are happy to share all of our course materials. We are happy to share. We have very extensive syllabi for these courses that are very detailed. We're happy to set up a discussion with our faculty and our medical director to go through it. So some courses allow that participation depending on who's in it. The PRO program is one of those programs where we actually do not allow any kind of observation from an outside entity. This is a highly charged, very emotional course, and the presence of a regulator or maybe somebody from a referring organization just disrupts the dynamics. We are really wanting people to have an aha moment, to develop some insight, to really get a sense of what they did and to be able to express it, to take accountability for it, and do that in an environment where they feel comfortable. But that said, we can create some alternative ways to expose interested parties to the material. That is something we're very willing to do.
Thank you.
All right, board members, any other questions for Mrs. Johnson?
Yes, Dr. Naidu. I just wanted to ask the doctors who went through ACGMI in the other countries, they come. How about the visa status on these people? They need to be citizens or they need to have a green card holders, but it would not apply for H-1B visa or anything like that, right?
So the legislation is very clear that there has to be an offer of employment. And as part of that, there also has to be appropriate ability to work in the United States. So, obviously there are many folks out there who are green card holders, who are citizens, who also may have finished their graduate medical education overseas. There are people here in the United States already who are H-1B visa holders. who could also apply through the process. As I had mentioned earlier, if they have not been practicing within the last 2 years, there's a competence process that would have to be evaluated for those. And other than that, they would have to apply or be sponsored for an H-1B visa or an appropriate work visa. I understand that there are dynamics around that. That's not something that we have control over. But regardless, there has to be an offer of employment, which means that they have to have the ability to legally work here in the United States.
I think the hospitals will take advantage on these things because a plastic surgeon who has got trained about 6 or 7 years in this country, a plastic surgeon, ACGMI in Poland or India, and they will come here, they fit with all the provisions, what you said. A hospital can employ them for 100,000 directly, competing with a guy who has about 7 years in this country residency with 500,000 loan. I think that could be a little unfair. I know we have to address the physician deficiency in Texas, but how these hospitals are going to take advantage of these people. We already have hospitals cannot appoint the doctors, but they go the different route, like ProCare or MCare or whatever they appoint. They have the ways to appoint these physicians. How do we do that? They're directly, for example, they're directly going to compete with anesthesiologists who have been here for a long time. And the guy comes in for 2 years, ACGMI from some other country can compete with the anesthesiologists here. And the hospital will employ like 3 or 4 before I think it's directly competing with the people who really went through long residency with taking loans and all that. And I just don't know how it's going to work out. How the
Dr. Naidu,
are going to take advantage.
These things were very heavily discussed and debated when the legislature, passed this law. I just, make sure that we emphasize that we are not the ones who passed this law. We are implementing the law, but these are things that were heavily debated and discussed. When we talk about GME program equivalence, that equivalence includes the number of years. So if you're looking at a program here in the United States, whether it's for, if it's for anesthesiology, if it takes 4 years to go through an anesthesiology residency program, you can't have a program in another country that says, oh, we can do it in 2 years. That by definition would not meet the qualification of equivalence. That's number one. Number two, this bill was passed specifically to address a physician shortage problem. All right. And the reason that the provisional licenses are restricted in the way they are is that it's supposed to target areas that have those physician shortages. So if you are looking at the first provisional license, again, that's from a safety standpoint restricted to ACGME accredited facilities. We already have people who have FTLs, faculty temporary license, already practicing in those entities or those structures. That's been in existence for a long time. That's not going to change. The second provisional license specifically has to be in a critical access area. A hospital cannot take one of these individuals and keep them there for 10 years, as you're suggesting, with some kind of taking advantage of them financially, because again, it's a 2-year provisional license, and it's the board that will make a determination if the competency to proceed on to the second provisional license is there. So there is not this holding hostage in a hospital type setting, paying substandard amounts or whatever that might be. Also, the law did direct, I believe, if I read it correctly, insurance companies to pay or reimburse appropriately for those physicians who are licensed under this in those hospital settings. The idea of making sure that there's an equivalence is something that a lot of time was spent on, and making sure that equivalence was there. Let me just remind everyone that Texas is the 19th state to have passed this. So number one, we're not the only ones doing this. And again, it's primarily because of a physician shortage that is nationwide. We have more physicians that are retiring than we have graduating from GME programs. And there simply is not enough GME programs out there to meet the demand of what is needed with our aging population. So, if we reach a point 10 years from now where, that dynamic has shifted, obviously the legislature created this law, the legislature can change this law. But what I will tell you is that there were a lot of legislators who had a lot of concerns that with us being the 19th state to pass this, that, with our physician shortage, that other states who have already passed this would be addressing their shortage in a way that would disadvantage us and not allow us to make sure that we're having qualified individuals practice in areas where we is something that is absolutely hardwired in the law. This is not a way to go and do a residency for less number of years or in a way that that doesn't meet the standards of a program that would have been over here. And that first 2 years in an ACGME accredited facility is designed to make sure that there's a second layer of vetting before they go to that critical access area where they are needed, and eventually before they go and they have an unrestricted license in that type of setting. So.
Well, it's already been done in England, Canada, and all the other countries. But we don't want to have a two-tier system. The people who are trained here, the people trained outside. And we have given institutional license to the big universities already with the highly qualified people. That's a different thing. But we are giving licenses to the other people. We don't want to have a two-tier system. That's what that responsibility lands on us, how we are going to put the regulations. Don't you think?
Well, that's why we spent several years. Number one, the legislature has debated this for several years to make sure that the standards were put in place, and the standards that the legislature passed were significantly more stringent than what was originally proposed and what, frankly, some other states already have. And the whole vetting process that we're talking about, whether it's a GME program that has been evaluated and vetted appropriately, that has that level of equivalence, or whether it's going through a competency process through programs that we're evaluating here, CPEP, PACE, K-STAR, and maybe some others, and then going through a process where you're going through these provisional licenses, and then eventually an unrestricted license after they've gone through all that, that certainly doesn't imply a two-tier type of license, because the vetting is supposed to go to the point where you've already made sure that these folks have been vetted before they even get a provisional license here, and before they're able to get an unrestricted license, that they've showed the competency to actually have that unrestricted license. So quite a bit of vetting has gone into this. Like I said, we are the 19th state, and I can guarantee you we are not going to be the last state to have passed this, but there is a physician shortage reality that is out there. And until that dynamic changes, this is going to be something that moves forward. Our job, again, is to implement what the legislature has passed. And we are doing so in a manner to make sure that these licensees who are applying have met all the standards that we would feel comfortable with in making sure that our patients who are going to be seen by these physicians are appropriately protected. The physician graduate program is another type of structure where U.S. medical graduates who have not matched have an opportunity in a supervised setting to be able to help and assist physicians in providing care and providing service. Again, from the standpoint of we want to make sure that folks who have invested their time in graduating from medical school here in the United States, as well as gone through that whole process but have not been able to match, that they are still going to have a pathway to be able to provide care and provide service. This is the dynamic and this is the reality that we're in. Our job as a regulatory agency is to be able to implement what has been passed by the legislature in a way that keeps our patients safe.
Are they going to increase the residency programs in this country parallelly?
That's a federal decision. You know, that's not our decision over here. We can only implement what we've been asked to implement. When the government decides to fund more GME programs to address that issue, and I am confident if they increase it to an amount that makes a lot of these other things necessary, you know, then maybe these laws will be changed. But that's not something that we have any control over. I think the idea of GME funding has been something that has been looked at for decades. You know, obviously, as you know, we have a financial crunch at the federal level. I know that there are private institutions that are funding GME programs outside of government funding. So that's something that is continuing to grow. And I know that a lot of physicians have been advocating for increase in GME funding. So that's not something that we can do. I know that it's been advocated for. I know that it's continuing to be pushed. But until then, we still have a shortage. And we have been asked by the legislature to implement a process to make sure our patients have access in a safe manner, which is what we're doing here.
Thank you.
All right. Do any other board members have questions for Ms. Johnson? Well, thank you again for being here and for partnering with us as you have for the years with disciplinary issues, but now in doing the assessments for our HB 2038 applicants.
Absolutely. Thank you so much.
Thank you.
Great. Thank you, Mr. Carlton. Our agenda item number 13, as I mentioned earlier, will go in effect at 9:15. So I'm going to continue on. We have about 10 minutes till we get there. I'll be continuing to go down the agenda until we get there. So Dr. Shinava, if you have your medical director report.
Good morning, Honorable Chairman, Mr. Clayton, board members, and my colleagues. What I would like to bring to your attention is that we have been looking at expert panelists, and we have made some headway. We do have a shortage in the pediatric section, and if any one of you could help us out with that, we'd really appreciate it. It's basically pediatric neurology, pediatric endocrines, pediatric rheumatology on those lines. I think that's pretty much from the expert panel side. Rest, I think there's nothing else to report, sir. Thank you.
Thanks. And just let me emphasize again that the expert panelist process is something that is absolutely critical. And I've mentioned this in many instances. It is our licensed physicians in the state of Texas who are board certified who are able to serve as our expert panelists. It's not our board members. It is not board staff. It is our licensed board certified physicians in the state of Texas. This is the opportunity for our licensed physicians to be engaged in that process. You know, you are the ones who are establishing what is the standard of care. You know, we are actually statutorily restricted to opining on the standard of care once an expert panelist has actually opined on that. So our licensed physicians in the state have a huge impact in defining and determining what that is. It's a voluntary process. You know, if you reach out to the board and ask to be a part of that panel, they obviously go through the vetting process. We have looked at increasing what the reimbursement is for our expert panelists, but I would encourage our licensed physicians who are board certified to look at, you know, serving the state in that capacity and being part of that process of, like I said, defining what the standard of care is in your specialty. So.
I do want to just note for the record, sorry, real quick, that Mr. Kokonos is here. He joined us around 8:40 or so, and Dr. Jones is here also. We have not taken any votes since they've joined us, so it hasn't impacted the count, but we do have everyone present.
Thank you, Mr. Carlton. Go ahead, Dr. Shinava, go ahead.
Honorable Chairman, I'd like to keep you informed, sir. We at the board, we have been discussing it, and we are looking at the compact states also, as and when required, to get in some expert panelists. And Mr. Clayton and Mr. Palazzola have been working very hard on that to help us get the due process. Thank you kindly.
Great. And this is particularly around areas where we have been having a hard time finding expert panelists in certain subspecialties, or are we talking about just in general as far as folks being able to apply into the expert panel process?
Absolutely. So this is pertaining just to the areas where we have a need for specialists and subspecialties. Like in some areas, like you're well aware of, there's a lot of interlap among the physicians and the colleagues in the area. So we're trying to look in where, these are high niche specialties at the tertiary centers. Thank you kindly.
Thank you, Dr. Shanava. All right, with that, we'll go to the public information update. Ms. Sloan.
Morning, Dr. Zafran. Hi, board members. Nice to see you all. The main item I want to cover today is the continuing education tracking requirement that Dr. Zafran mentioned in his opening remarks. But I primarily want to review agency outreach plans as it relates to this requirement. This is the public information update after all. As a reminder, it will be a hard stop at renewal if we cannot verify 100% CE compliance for a licensee through the established CE broker account. So the stakes are kind of high for practitioners here. So it's critical that we do what we can to build awareness. As part of that effort, renewal notices for all licensees have been updated to include information on the requirement. Licensees do receive both a hard copy and email notices 60 to 90 days out from their expiration date. Additionally, information, including FAQs and informational videos, are available on the website. There's a giant rotating banner on the homepage alerting folks to this requirement. Soon, we will be announcing dates for webinars that will be co-hosted by TMB staff and CE Broker to help further familiarize people with the platform. There will be a series of webinars between May and September of this year, and then more into the future until everyone has gone through a renewal cycle where CE Broker has to be utilized. Each licensee will receive direct communication from the board via email about the webinars. And of course, we're going to post the dates, times, registration links, etc. for those events on the website, social media, and wherever else we can. In the meantime, my team has already started sending communications to the various professional associations in the state for the different license types to make sure they know about the requirement. As part of our communications to them, we have provided templates for newsletter write-ups, social media posts, email communications that they can use to help educate their members, should they choose to do so. Our goal was to make it as effortless as possible for them to engage in outreach themselves. As we get closer to each license expiration month, we will send targeted communications to those licensees who are coming up for renewal to remind them again of the requirement. In theory, by the time the first wave of folks renews at the end of November under this new requirement, between formal renewal notices, webinar invitations, and other direct emails, they will have received no less than 5 direct communications in about a 6 to 7 month period, reminding them of the requirement. And of course, this doesn't count instances where folks receive our newsletters, which also feature and also feature content on mandatory CE tracking or the folks who follow us on social media because we're posting about it on Facebook. Keep in mind, we didn't receive any special appropriations to implement or educate our licensees on this. So you're not going to see billboards or TV ads or hear radio
Ms. Sloan,
spots.
Ms. Sloan, excuse
Yes.
me a second.
Yes, sir.
Dr. Zafran, I'm having a problem hearing her. If you could, or if everybody else is okay, then I'm okay. But I just am having a lot of trouble knowing what you're saying. If you could move your microphone or something.
Yeah. Don't know.
Thank you.
Okay, I will just try to get a little bit closer and see if that helps with the microphone. Is that helping, Mr. Kokonos?
Yeah, we can hear you. It's slightly muffled, but I can hear you.
Okay, I'll try to speak up a little bit. We are a little limited on what we can put out there in terms of the methods that we can use. So we're really counting on licensees reading the direct communications that we send to them, and we're hopeful that associations will also assist with outreach. And of course, anything that you can do as board members to help spread the word is always appreciated. Along those lines, if you have any specific ideas for outreach, please touch base with me. We're open to any and all suggestions. The last thing I do want to touch on is the TMB Bulletin. The most recent edition came out this month. At the request of the members of this board, it featured a very comprehensive president's message from Dr. Zafran about the new tools we're using in our enforcement process, like the warning letters and the letters of concern. Hopefully this is going to help folks understand the purpose and the value of those new tools a little bit better. This particular issue was full of useful information for our licensee community. So I would encourage you to check it out if you haven't already, and encourage you to encourage everyone you know to sign up to receive the bulletin. We are very thoughtful about the content and the publication cadence of it, so as to kind of provide the stakeholders with meaningful information that's not just spam. It's a really great way to stay up to date on the most important things happening here at the board and impacting our licensees. I think I'm gonna look at my notes. That is all I have for you guys today. But if you have any questions, I'm happy to take those, and any suggestions you may have.
Thank you, Tori. You do quite a bit for us. Appreciate all the input. Does any of the board members have any questions at all?
It's not maybe a question, but I've definitely had a lot of doctors expressing tremendous anxiety about CE Broker.
Yes.
And a lot of doctors espousing the conspiracy theory that somehow CE Broker is making trillions of dollars off of us. This, of course, I take them back to, this is a legislative directive. We have to do it. It's not an option. And, it's not the medical board coming to Jack with you. It's just something that, it's kind of like the fingerprinting. I just tell them, like, so many other fields already had to be fingerprinted, through the FBI for, through the national databases, like police, for example. And so don't freak out. It's going to be okay. But I'm glad that you're getting an early start on it, Tori, with all the communications. But I got a text yesterday during the med board meeting from a licensee who was like, asking questions. So I'm doing my best to squelch those conspiracy theories as well.
I appreciate your efforts. We are definitely already getting inquiries through like the call center and the registrations inbox. And of course, I'm getting them through the comms inbox. As we get those, we're trying to tailor FAQs on the website to kind of combat some of those things that are coming out. Of course, not everybody navigates to our website, but we are trying to do that. So yeah, anything that you hear out there that you think would be helpful for us to kind of push out in terms of messaging that you're like hearing a lot of, please let me know.
Yeah, thanks, Tori. One of the things that I think is important, as Dr. Green mentioned, is that we have a duty to implement the law, and this was part of a legislative directive. Now, with that, I have gotten some concerns that the process of uploading CMEs to CE Broker is a little bit more cumbersome than, say, for example, what CE Broker may be doing in other states. Obviously there is the free version, which, nobody's mandating the licensees to pay for a paid version. But that there may be opportunities for how these things are uploaded. When we get concerns or complaints or ideas or suggestions from our licensees, I know that we are communicating that with CE Broker, and we want to make sure, at least for the free version, that we are getting the kind of, or our licensees are getting the same kind of service as they would be expecting to get in any other state, no less. So that's something that I've asked our staff over here to make sure that they're being held accountable to that. I know in the paid version that there's a mechanism to where if you're uploading CME for multiple different states that you're licensed in, that you can do that one time as opposed to having to do it individual times. I've heard concerns about, having CMEs that are bulked in together, that there's a requirement to do each CME course individually or uploaded individually as opposed to in bulk. So again, these are questions that we are asking CE Broker. And I know that the associations, specifically TMA, Texas Medical Association, like they had done for their members a process to help the fingerprinting process be implemented. That was something that TMA did separately with the vendor. And the associations have an opportunity also to communicate directly with CE Broker to see if they have ways where they may want to help facilitate the process for their members. So long as the law is being applied the way that we're being asked to implement it, where CE Broker has the CME data and that we're able to see it on a continuous basis, then, all these different types of mechanisms of, being able to provide value for their members by making it easier, helping facilitate it is, obviously that's okay. But like I said, from our standpoint, we're going to try to make sure that with the free version that they're at least getting the appropriate minimum ability to, be able to upload those CMEs in a way that's not cumbersome. Like I said, we've been trialing it, I guess, for the past year, but the mandatory component of it, Tori, goes into effect in September of 2026. And this is what Tori's talking about, of making sure that the licensees are aware that as they approach September, that they have to have these things in place, have an account opened with CE Broker. It's free, like I said, unless you want to pay more for it. And then start that process so that for licensees who are going to be renewing their license September 1 moving forward, that process and that has to already be in place. So again, like the fingerprinting, as we get closer to the implementation side of things, it's going to get probably a little bit more clunky, but we're going to try to work with everybody as best we can and try to make sure that it's as smooth as possible. All right. With that, sorry, go ahead.
And everyone being our licensees, all of our licensees are encouraged to set up an account and start using this as soon as possible. Like, please do not wait until the week before the deadline to renew, and then you try setting up an account and you're not familiar with it or something. Like, I can't stress enough. Start working with it now and get familiar with it. Dr. Deloche, and then Dr. Green again.
Yes, this is Dr. Deloche. Ms. Sloan, I apologize. I haven't read the frequently asked questions, but is with the TMB webinars, does that apply for any CME, since we're talking about CME, for watching the seminars?
No, it would not. That would not count for like CME credit for your hours, Dr. Deloche.
Tori, the only thing that does apply for CME is our other CME that is mandated that the TMB was asked to put together. Correct?
Oh, yes, of course.
I just want to make sure that they're aware that is different.
Of course, that's different. The webinars are primarily just to kind of help people understand how to create an account, how to navigate the platform, ask questions at that time. We're hoping to split kind of physicians up from some of the other license types, just so we don't have like a mass of people and it's manageable. But yeah, it's just informational. It won't be for any sort of credit.
Thank you.
Of course.
Agree.
And on that mention that Dr. Zafran did of TMA meeting is happening in a couple weeks in Corpus, and so the CE Broker people are going to have a booth there. Like, it sounds like an interactive booth that's going to help people like log on and do stuff in real time. So I hope the CE Broker people have their football helmets and their protective gear, because they're going to probably get mobbed. But so that's helpful. And then, do we know how many doctors, Tori, have signed up for CE Broker yet?
I knew this question was going to come, and I don't have the latest data on it. It is a very, very small amount. Like,
I've done it.
If you're here, if you happen to know, I don't know what the latest number is. That's a data point we have to get from CE Broker themselves, and we haven't gotten the recent one lately. But it's a fraction. So we got a long ways to go.
Last time I looked, it was only a few thousand.
There you go.
Yeah, I know Brent has been warning about this, but I suspect that August 20th, there's going to be a mad rush. And I just would encourage everybody, as Brent said, better get it done now and not wait until the last minute when your license may be up for renewal September 1st. That's probably not the right time to do that, but we'll obviously be continuing with our messaging and encouraging everybody to at least go through the process and just kind of get it set up. Any other questions? All right. Thank you, Ms. Sloan. All right. So it's 9:21 right now. I'm going to go back to agenda item number 13, which is consideration approval of proposal for decision. Our first item on there is Dr. James Lee Landero, the OSOA docket number 503-24-2047. Brent, I'm going to hand this off to you to manage the process.
Thank you, Dr. Zafran. So for board members, you are very familiar with this process, but for anyone else that's watching that hasn't seen this before, normally we would not say the name of one of our licensees going through something, but this is a complaint that's reached the point where there has been a public filing with the State Office of Administrative Hearings, so saying the name is okay. These are cases that have gone through the informal settlement conference and were not able to reach a settlement at that point. Like I said, they went to the State Office of Administrative Hearings, legal proceedings ensued, and now there's been a decision that has been rendered by the administrative law judge presiding over those hearings. And now we have a proposal for a decision. There's two of them that the board is going to hear today. They contain the conclusions of facts and law. And so we will go through each one. Each side is going to get 10 minutes to present. The state always goes first in these proceedings and can reserve time if they would like to, if they have any of their 10 minutes remaining. And so do we have Dr. Landero present online with us or
Yes, sir, I'm here.
counsel? Okay, great. Are you ready to proceed?
I can. Did you want the
Well,
board to
just
go
make
first?
just make sure
because
you're
I'm
ready
not-
to go. And so we're going to get going here. And again,
Let's make sure that his counsel is present if that's what he wants also.
so I'm asking, do you have counsel with you today?
I am self-represented.
Okay, all right, that's fine. All right, again, we'll look into our conclusions of facts. So go ahead.
All right.
Sure.
Good
So-
morning. All right. Good morning, everyone. My name is Shane Neldner with the Litigation Division. I'm here to present the Administrative Law Judge's proposal for decision in the matter of the license of James Landero. I'd like to reserve whatever time I have left following this presentation for rebuttal. The findings of fact and conclusions of law I will be discussing are the ALJs. They are not board staffs. Those are not open for debate. We aren't here to relitigate or to question the ALJ's results of the SOA process. That record is closed, and the board doesn't accept written briefs, new evidence, or any other arguments for consideration of a final order. Instead, we're here to talk about that and whatever ordering provisions, if any, we decide would be appropriate in this case. Now, this case involves claims against respondent regarding his treatment of a female patient who was 97 years old at the time, and evidence suggested that she was suffering from dementia of some kind. On October 13th, 2022, the patient, accompanied by her daughter, witness 1 is what we're calling her, visited respondent with a chief complaint of skin lesions. Witness 1 remained in the room during the entire office visit and observed all interactions between respondent and the patient. Now, there are several issues here. There was a question of whether or not the respondent took the patient history of the patient. Respondent testified that he took an updated patient history of the patient. The medical records from October 13th, 2022 includes a patient history. Witness 1 testified that respondent took no patient history for the patient and stated that upon entering, respondent immediately began performing the shave biopsy. The Honorable ALJ found that that the board staff failed to prove that respondent failed to obtain patient's medical history before performing a shave biopsy on the patient. Another question was whether or not there was an exam of the patient. Respondent testified that he performed a physical exam of the patient. The medical record from October 13th, 2022 states that an exam was taken and describes the extent of the exam. Witness 1, the daughter of the patient, testified that respondent took no exam and that upon entering, respondent immediately began performing the shave biopsy. The Honorable ALJ found that staff failed to prove that respondent failed to perform a patient exam before performing the shave biopsy on the patient. There was a question of informed consent. Shave biopsy is a List B procedure requiring a physician to obtain verbal consent before performing the procedure, but no written consent is required. 5 years before the procedure, in December of 2017, patient signed a consent form that stated the risks and benefits involved in biopsy treatments and gave respondent permission to perform, the patient gave permission to perform those treatments. The ALJ found that the patient's 2017 written signed consent form standing alone was not sufficient for another shave biopsy in 2022. Respondent's medical record from October 13th, 2022 states that written consent was obtained and risks were reviewed. Respondent's testimony that he does a verbal review of the procedure is consistent, this is what the ALJ said, with the patient's medical record because it reflects that he had on file a written consent and risks were reviewed. Witness 1 denied that any risks were reviewed and that respondent never asked the patient whether she consented to the procedure. The Honorable ALJ found that a doctor may sometimes rely on implied consent under certain circumstances, but it is unclear in the record when a doctor can rely on implied informed consent in lieu of verbal consent for a shave biopsy. The ALJ also found that neither patient nor witness 1 stopped the biopsies, and the ALJ found that board staff failed to prove that the respondent failed to obtain informed consent from the patient prior to performing the shave biopsy. There was also an allegation that there was a failure to notify the patient of basal carcinoma. So on October 19th, the results of that shave biopsy came back and it indicated a diagnosis of basal cell carcinoma. The Honorable ALJ found that a standard of care requires 3 attempts to notify a patient about the diagnosis in person or by phone, and if that fails, to send a certified letter. But the Honorable ALJ did find that the board staff failed to prove that respondent failed to meet the standard of care in notifying patient about her cancer diagnosis after the shave biopsy because the ALJ found a verbal notification was successful. Lastly, medical records. The patient's medical records failed to include any telephone notes or documentation showing that the patient was notified of the cancer diagnosis. The Honorable ALJ found that staff proved that respondent failed to maintain adequate medical records for patient that were accurate. Respondent failed to properly document his records or his efforts to notify patient of positive results for the shave biopsy in his medical record, and the ALJ found that respondent may be sanctioned for his failure to maintain adequate medical records under 22 Text Admin Code 165.1. That was the rule that was in effect at the time of this interaction. And the Honorable ALJ found no aggravating or mitigating factors applied here. So it's for this reason that board staff recommends the final order that has been presented to you. 12 hours of CME, 8 hours in the topic of medical record keeping, and 4 hours in the topic of patient communication. I reserve the remainder of my time for rebuttal. Thank you.
All right, thank you. You have just under 4 minutes remaining. We'll go to Dr. Landero.
Good morning, board members. I do not seek to re-argue the entire case. I mean, I submitted a statement last week just to clarify, because what the ruling ultimately came down to is whether the logs that were submitted that included the biopsy results, the telephone number called, and the results conveyed, as well as the fact that she was scheduled for Mohs surgery for this spot, were submitted to the board. And the findings were basically that they questioned whether these logs were part of the medical record. So I submitted them again last week just to show these were printed from Modernizing Technology, which is the EMR that I used at the time. And I was hoping that there's someone, a doctor present, that could attest to the fact that these are indeed printed from that from that software that included digital records that are time-stamped to show that not only was the patient contacted and results were obviously conveyed as the judge did find, but that these are part of the medical record. I think that it ultimately came down to a classification issue more than anything, whether these records are part of the medical record or not. And I just wanted to portray the fact that these are these are pulled directly from my electronic medical records by Modernizing Technology that show the specific lesion, the specific patient, the phone number used, and so forth, and therefore should not be excluded as part of the record.
Okay. You have any other comments? You have about 8.5 minutes left.
Well, I just wanted to reiterate that I disagree with the classification. If the documentation generated directly from the electronic medical record is tied to the patient, is tied to the lesion, and is tied to the diagnosis, and tied to the scheduled treatment plan, is not treated as part of the patient's chart, then that basically elevates the classification over the substance. The patient witness indeed admitted that her mother was scheduled for surgery. We also submitted a note from the cardiologist agreeing to stoppage of the blood thinner prior to having the Mohs surgery done. And we also submitted evidence showing that they canceled this surgery. So the initial complaint was about whether we notified the patient at all. In her own complaint, she admitted that she knew that she was scheduled for surgery, that we had called her, and she knew about this. So it's actually written in her own complaint. So that was never really in question, whether she was actually contacted and she was aware of the facts and that the patient was indeed scheduled for excision. As far as whether we obtained consent and so forth, I think that was exhausted in the case as well, because not only did we have written consent, and the expert witness for the board admitted that written consent for shave biopsies do not expire, and that verbal consents are enough to carry out a procedure that she had done 6 or 7 times in the past, and also that implied consent also applied in this case because she came to the office for that lesion. She had the biopsy done many times before, and she did not object to the biopsy being done after risks and so forth were explained to her. So really, the only finding that the board found was whether these logs should be part of the documentation. So I just wanted to one more time reiterate that the only error that they showed that could be used as discipline is whether these logs that I submitted were part of the medical record. So I submitted a copy of them one more time as a statement. I'm not sure if these were reviewed or not. I understand that this is not a part to review those things, but I just wanted to show that the logs were supplied to opposing counsel. They were presented to the court, and they were electronic medical records that are timestamped from the EMR called Modernizing Technology, showing that those results were given to the patient, that she was scheduled for surgery, and therefore the possibility of disciplinary action based on that should not be considered by the board. It should not be adopted by the board. And if anything, it should be some remedial concept. I've been practicing medicine for 13 years in Texas. I've never had any issues with any disciplinary actions. And I believe that the glitch that came from this is just the fact that Modernizing Technology puts the communication logs in a separate part of the medical record, which is why I think that the court took it as it not being part of the medical record, but it just happens to be stored in a different spot when this happened. And I can attest to the fact that they did change that a few months ago. They included them into the actual charting itself. So I think that was the confusion from the court. But these are not external notes. These are part of the medical record.
Okay,
so
thank you.
That the board not adopt the disciplinary action against me.
All right. Thank you, Dr. Landero. I'm sure the board may have some questions for you, but we'll go back to Mr. Nelson, and you have about 4 minutes.
Yes, sir. Board staff has concerns over the majority of this case and disagrees, of course, with some of the findings, but that is not our place here today to question what the ALJ found in the PFD. The ALJ did find respondent failed to maintain adequate medical records regarding the positive shave results. Board staff takes issue with the idea of implied informed consent under a circumstance like that. But I'm not arguing that here today. It's not my place to argue that the ALJ was wrong, because the ALJ wrote what the ALJ wrote in the PFD. And so board staff would ask that the board adopt the proposal for decision and issue an order commensurate with those findings. Thank you.
All right, thank you. Just quickly before I turn over to board members for questions, Dr. Landero mentioned that he had submitted some additional information. Was that information already, as far as you know, already reviewed during the proceedings and incorporated into the findings of fact and conclusions of law?
Yes, sir. That's my understanding. There was a letter with some explanation that would have been, I guess, in lieu of a statement, but that wasn't included in the record. But I believe everything else was. Nothing new.
Okay, turn it over to board members.
All right, so you've heard from both sides. This is an opportunity for the board members to ask any questions of either board staff or of Dr. Landero. Is there any questions? I think Dr. Green.
Yes, thank you. Dr. Landero, which EMR does your company have?
Modernizing Technology. It's also known as EMMA.
Oh, I think you froze for a second. What
It's
is it called?
Can you hear me now?
Yes.
It's
Yes.
modernizing.
Is it Emma? Yeah.
Yes, ma'am. Modernizing
Yeah.
Technology, otherwise known as EMMA.
Yeah, that's one that's used by a lot of dermatologists, and it's very similar to the one that a lot of ophthalmologists use, which is called Nextech. And it is, I don't know if this is how yours is or was, but mine is kind of like a mashup of two different softwares. They just stuck them together, and so all the communications are in one section of the software, which seems like it's part of the medical record, right? Because it's right there, but it's totally separate from like the HPI, the chief complaint.
Exactly.
Is that how yours is? Yeah.
Exactly.
That's,
Yes, ma'am.
that's
that was-
making me anxious now about mine because mine is still that way. There's no way to
Right.
put communications in with the clinical data.
Right. So you have to pull them from the communications log, but it's still part of the medical record. It's just not kept in the same area as you mentioned. Yes, ma'am.
Thank you.
Okay, any other questions from board members?
Yeah, this is Dr. Vanderwide. And I have a question for Shane. I'm curious, are we here because we didn't receive the phone logs, or are we here because the phone logs are somehow not considered to be part of the medical record? I mean, distill this case for me, if you would.
Yes, Your Honor. Or yes, sir. We're here because there was an allegation of a failure to obtain adequate informed consent, a failure to take a patient history, failure to perform an exam, and failure.
I don't want necessarily a summation of the allegations again. I'm on, after we got through all of that, it boiled down to what?
Yeah. Ultimately, it boiled down to the fact that those phone logs were produced during the hearing on the merits itself, and they were not included in the medical record, including any notation in the medical record that the patient had received a notification that there was a positive cancer result. Okay, now they may have been in phone records that Dr. Landero submitted over board staff's objections at the hearing on the merits, but they were not included in the medical record. But for requesting those phone logs, looking at the medical records, you could not tell that there had been any contact made.
Yes,
so,
sir. And has he since cured that? Have we been given that information that determined that, yes, indeed, that was taken care of? And now it's just a matter of, do we consider that medical record or do we not consider that medical record?
Well, the Honorable ALJ found that the contact had been made, but that there was not adequate medical record keeping of that contact in the medical records. So board staff would argue that the fact that contact had been made, although included in the telephone records, it should have been noted in the medical records themselves, contact was made. And the test results were conveyed to the patient. That's what didn't happen. And ALJ found that to be a violation. And board staff would agree to that part.
Thank you. And Dr. Landero, you're saying that as far as you were concerned, these were part and parcel. There was my phone record is on the same screen as my clinical notes. And as far as I was concerned, my phone records are my medical records.
Well, yes, sir. And additionally, I think part of the issue is that Mr. Neltner was not part of the case when my deposition was taken. So these logs were provided to the previous counsel. And when he took over the case, apparently he did not receive these. So that is part of the reason why this became an issue more of a classification, because the judge found that contact was made, that the surgery was scheduled, that she knew about the results. The only thought that they thought could be seen is that adequate medical records were not taken because these logs were apparently not counted as part of the record. And as I mentioned earlier, it's really just a matter of because they're kept in a different section of the EMR itself, and this is an EMR universal issue. So it's not because the patient didn't know, it's not that they found an infraction with informed consent or the medical exam and all the other things. It's only whether this medical record should be counted as part of the medical record with these logs. And these logs are clearly showing that contact was made and they're time-stamped electronically by Emma. And they were provided to opposing counsel and to the court. So additionally, when it was found that they did not have these. So it's not because they were never given to them.
Understood. Thank you.
Yes, sir.
Dr. Green, let me ask you a question. You're not on trial, so just so if you were asked to provide records to another physician, would those logs that is in that separate bucket be part of what you provide to that other provider who's requesting records?
We never have. We never have done that. I have, I think that the only scenario where I would do that sort of, it would be like an extra step I might take is if there's something really remarkable about the phone log. Like if it's a patient that called the office every day, you know, something really remarkable about the phone log might spur me to forward that to another physician, but I never have.
But if the physician asked and said that, I need more information, I need this bit of information, it's something that you have and that you'd be able to provide, I'm presuming?
Yes. Yes.
Okay. Yeah. I mean, it sounds to me like this is a technology problem as opposed to a medical record problem where things are housed in two different areas. I guess the most important thing from my standpoint is it's available, it's there, and I would just want to make sure that patients are aware that if they requested their records or if a provider is asking for records just from a completeness standpoint, that they would be aware to ask for it if need be. But to be honest with you, I mean, it just seems like the majority of the allegations that we had put forth, the significant part of it, were actually found not to be relevant by the ALJ. So I have concerns about, and again, this is my personal opinion, but I just have concerns about moving heavily forward on probably the most minor part of all the allegations that we had. I mean, I think there was clearly a violation there, but it sounds like we're probably, a lot of us are culpable of it. So this may be something that could be an educational component of, that there's an awareness made that software may have different, maybe housed in different areas where the medical record is and so forth. So anyway, any other questions, or we can always kind of just deliberate. Dr. Quinones?
Yes, I just want to make a comment that kind of dovetails into your comment, Dr. Zafran, and that is that as a primary care physician, when I have a patient that has to move to another office or another provider and they request records, we provide clinical records and progress notes, lab results, imaging results. I can't recall ever sending a copy of my encounters log, which would entail telephone encounters and documentation of notices by telephone. I guess if somebody asked for that specifically, I could provide it very easily, but it's not generally considered part of the clinical record unless it's requested. That's just my personal opinion.
All right. Any other questions? Because if anybody would like to make a motion, we are open to that also at this point.
And I'm going to.
Yeah, I was going to say, Mr. Freshour is going to give you the options. There's the final order that is proposed by staff, but there is obviously also alternative orders where you can modify what the final order is, or all the way up to dismissal. So, Mr. Freshour, I'll let you go ahead and lay that out.
Whatever the motion is, you would want to adopt the findings of fact and conclusions of law. But as Dr. Zafran just said, you could adopt what's been proposed by staff. You could offer less CMEs. You could go as far as dismissing it, based on your discussion here and a concern over what is or is not a clinical record. So those options are all available to you. But the key is you have to adopt the findings of fact and conclusions of law. But what you decide to do from a sanction standpoint or not do is entirely up to you as a committee. And it's perfectly permissible because you have that discretion, because that authority rests solely in you as to how to finally dispose of a case based on the findings of fact and conclusions of law.
All right. So if there's not any further discussion, I am going to entertain a motion from someone.
I would like to move to adopt the findings of fact and conclusions of law and dismiss.
Dr. Green has made a motion. Is there a second?
Second, Dr. Quinones.
I think it's been seconded by both Dr. Quinones and Dr. Vanderwide and Dr. Martinez. Is there any further discussion? All those in favor, please say aye.
Aye.
Aye. All those opposed? All right, motion passes. This case is dismissed. Thank you, Dr. Lindero. Good luck to you.
Thank you very much. Thank you very much for your time.
All right, this moves us to the second PFD, which is Dr. Lucky Connor Reed. This is SOA case 503-24-23310. Mr. Carlton.
Okay, same process for this one involving Dr. Reed. Do we have counsel for Dr. Reed present?
Yes, this is Rodney Montez. I'm present. Dr. Reed will not be attending today.
Okay, that is all right. Well, you saw the last one. And again, for everyone watching, we'll do the same thing. The board staff will go first with 10 minutes, and they may reserve any remaining time. You may proceed.
Good morning, board members. This case involves concerns about impairment from an injury that interferes with the ability to practice medicine safely. Dr. Reed is a maternal fetal medicine specialist. He sustained a traumatic brain injury in 2018. He was serving in the Army, and he fell from a balcony and had a pretty serious head injury and broke some bones. In the months that followed, he underwent extensive hospitalization, rehabilitation for the physical injuries, as well as some of the neuro injuries that he sustained. He received several neuropsychological evaluations in that initial recovery period. Over the last almost 8 years, Dr. Reed has undergone specialized evaluations by experts in their fields, and these conclusions have consistently demonstrated that neurocognitive impairment still exists. This is not an isolated finding by a single practitioner. I want to emphasize that. And briefly, I would just like to go through these evaluations to show that this has been consistent. In 2019, about a year after his injury, he underwent a psychological evaluation, and the finding was mild neurocognitive disorder due to TBI. Later that year, 2019, he underwent another neuropsychological evaluation. That evaluation found that the findings were consistent with the first one. It also found that this was a significant TBI and was highly likely to have lasting impact on Dr. Reed's cognitive functioning. In 2023, Dr. Reed underwent a neurological evaluation. The findings were marked impairment. In 2025, Dr. Reed underwent a fitness for duty evaluation administered through K-STAR. And if you're familiar with with the fitness for duty evaluations and with K-STAR, it's administered by several specialties over 1 or 2 or maybe even 3 days. Different types of exams and tests are performed. And the outcome from the fitness for duty evaluation was significant neuropsychological impairment and a finding that he is not currently fit to practice medicine. There were 3 recommendations made in the fitness for duty evaluation. The first one was that Dr. Reed should undergo a full neuropsychological evaluation with a PhD level neuropsychologist, that Dr. Reed should remain under the care of his specialists, and that there may be a path forward. There may be a path forward with the possibility that he can be considered for practice in the future, with 3 specific limitations: that Dr. Reed would not perform obstetric or gynecological procedures, so no surgeries, no deliveries. 2, that Dr. Reed would not perform locum tenens work because of the nature of locum tenens practice being short-term and not as much supervision, and just the whole way that practice is structured. And then 3, that there be no unsupervised practice or interaction with patients. So those were the 3 recommendations, and then the 3 restrictions should there be a possibility in the future that he could practice. This past November, we went to a hearing on the merits. It was in person, and board staff put on our case. We used Dr. Katie McQueen as our expert. If you're familiar, Dr. McQueen is the former medical director of Texas Physician Health Program. Dr. McQueen's expert opinion, her interpretation of the records, the conclusions of the practitioners who evaluated Dr. Reed in person. She also watched the hearing on the merits. All of that information formed her opinion, and she gave a rebuttal testimony that Dr. Reed, unfortunately, is not currently fit to practice medicine and execute his duties in an unsupervised manner. Now, there's no, board staff is not debating or refuting that there have not been patient complaints that we have record of. There have not been reported complaints or injuries to patients who Dr. Reed has seen or treated in locums work that he's been engaged in since this accident. However, that is not that harm does not have to happen for the board to take action. And Dr. McQueen spoke to this at the hearing on the merits, and she said, quote, "It would be very dangerous for the board or myself to assume that the absence of a mistake or error was sufficient to say that someone is not impaired." The ALJ issued a proposal for decision. Respondent filed exceptions. Board staff responded. The judge did issue an exceptions letter, changing a little bit of language in one of the findings. That has been reflected in the draft final order that I have provided. I would like to draw your attention to just a few of the findings of fact and a few of the conclusions of law that have been determined by the judge. Finding of fact 30, respondent has not undergone the most recently recommended comprehensive neuropsychological evaluation. This is what was recommended by K-STAR. Number 31, respondent continued to practice medicine despite recommendations that his practice occur within structured and supervised settings. Number 32, Respondent intends to continue practicing medicine. And 35, respondent's neurocognitive deficits create patient safety risk if he practices without appropriate restrictions or oversight. A couple of conclusions of law I'd like to draw your attention to. Number 8, the judge found that respondent's ongoing neurocognitive impairment resulting from his traumatic brain injury is functionally relevant to safe medical practice. Number 9, respondent is currently unable to practice medicine with reasonable skill and safety without significant restrictions and structured oversight. And number 13, there was a finding of an aggravating factor, which was increased potential for harm to the public that may be considered. In light of these concerns, members of the board staff has recommendations for action. The ordering provisions in the draft final order that we have prepared are based on the sanction guidelines that are publicly available in the rules. We have recommended suspension for the time being until such time as respondent requests, and I've got it all laid out in the draft I've sent you, until he can give evidence of successful completion of the full evaluation as recommended by KSTAR, evidence of improvement and resolution of ongoing neurologic impairment, evidence of ongoing neurocognitive and psychiatric care and monitoring, and evidence of medical competence and fitness for duty to practice as a physician. We also recommend a public referral to Texas PHP. And I realize I'm running out of time. Board staff recommends that the board adopt the findings of fact and conclusions of law as included in the ALJ's proposal for decision. And just a couple of final words. The absence of reported harm or complaints is not proof of fitness to practice medicine safely. What we do have, and what the proposal for decision finds, is that Dr. Reed's injury has impaired cognitive functioning to a level that may interfere with his ability to practice medicine safely. Considering the board's mission and charge to ensure that the Texas public is protected by regulating the practice of medicine,
Okay.
we do recommend
Your
these
time.
actions. Okay.
All right. Mr. Montez?
Yes, thank you. Thank you, board. Thank you, Ms. Massey. Dr. Reed is not feeling well and will not be here today. Just a few things I'd like to note. Obviously, this is a negative PFD for Dr. Reed. I want to point out to the board a few things. First, Dr. Reed's service in the Army. He has storied career. I mean, he had a great career prior to the accident. Really no fault of his own and what happened to him. But that being said, there are indicators both in the KSTAR reporting and in the ALJ's findings that Dr. Reed could practice medicine under certain situations. I think this whole case from the beginning had to do with what the board, through the informal process, was proposing for Dr. Reed to be and how restricted he was going to be. Part of his practice since the injury, it was a kind of a domino effect. He lost hospital privileges. He hadn't practiced for a number of for a year or more, and therefore it was very difficult for him to get those hospital privileges without other requirements that would entail in a normal physician's practice. This was after the Army. He did get a full-time position in California, and after that was working locum tenens pretty regularly. Obviously, this was difficult to maintain once the complaint was listed on his profile. Once his case was set for hearing. and in a lot of ways, really, Dr. Reed was just attempting to continue on with the locum tenens practice that he was doing before. As the findings of fact in the PFD show, there have been no patient complaints. There have been no employer complaints about Dr. Reed's. Essentially, what he does is ultrasounds for pregnancies. He does not practice obstetrics or gynecology. So, with that being said, Dr. Reed would have liked to have been here today. He fought to the end, and frankly, was just not up to hearing about all these deficiencies, obviously, that have occurred since the traumatic brain injury. So that being said, I have nothing else to add other than asking the board to consider some sort of limited practice so that he may continue to work and provide for his family, and which has otherwise been a very stressful time for him and his family, without having a complete suspension with the requirements that frankly are going to be very difficult to obtain and to perform. This final order that's being proposed will effectively probably render him revoked, as the requirements for him to come back are very high requirements. So thank you, panel, and I have nothing further to add.
Thank you. So I have a question. What part of the proposed order, remember this is a proposed order now, this is not what, we're still in the process of deliberating. What part of this proposed order do you think is too cumbersome or too high of a burden to overcome without having to compromise possible patient safety?
Sure. I mean, from as we were trying to negotiate some kind of settlement here, in the informal process, any kind of suspension where he's required to come back with, and I would point to 1B, evidence of improvement and resolution of ongoing neurologic impairment. I don't know how a board panel, an ISC panel, is ever going to be satisfied with that kind of.
Well, do you think that 1A would probably go a very long way in helping satisfy that? I mean, if you got at least at a minimum a successful completion of a full neuropsychological evaluation conducted by a PhD level neuropsychologist, which again, my understanding is the evaluations that we have in front of us right now actually indicate impairment. So we don't even have that. So, I understand there's concern about, maybe B, C, and D being objective, but I think most panel members would probably be looking at A to make a decision as to whether B, C, or D are appropriate. So are you suggesting that A is too cumbersome of a process to evaluate competence or ability to practice?
I think from the record, Dr. Reed had evaluations performed after the accident. So we don't know if they would be redundant, but I think to answer your question, on a basic level, it was always monetary. It was a monetary consideration because how expensive these evaluations are, and how even though he's a veteran and covered by the VA, nobody at the VA would allow for such a evaluation to be performed under his coverage, right? So
yeah. No, I mean, no, look, I mean, as somebody who's a veteran who served the country Obviously we have the highest regard for that service. And, unfortunately, he had an injury, a traumatic brain injury that, he had no control over. And that's not his fault. However, what we're charged with as a board is to make sure that in spite of all that, that his ability to manage and treat patients is something that that does not, put patients at harm. I understand that he hasn't had any specific complaints and so forth, but we're still looking at objective evaluations over here that raise concerns about competence and his ability to perform these basic functions. And again, this is something that we're going to deliberate. I'm just, you talked about too high of a hurdle to overcome. And, other than the requirement to have a competence evaluation by a PhD level neuropsychologist, some of the other orders about, a formal referral to the PHP and so forth. I mean, there's no cost to that one because that's covered by our PHP program. So I'm just wondering, other than that initial evaluation by a professional to establish competence to manage and treat patients, which I think, in my opinion, is crucial, what other than that would be too high of a bar to for him to overcome to safely potentially manage and treat patients in the state of Texas?
Sure. Yeah, no, I hear you. I understand what you're saying. I think again, the any kind of full neuropsychological evaluation at this point, after so many years after his injury, would not provide any additional information, I don't think. But I mean, that's just my opinion, right? So obviously, I think what I'm here to do today, and it's unfortunate that he can't be here, but to answer your questions specifically, but is all I would like is for the board to consider a limited practice so that he can provide for his family. If part of that restriction on his practice, other than suspension, if there's a requirement that he do a full neuropsychological evaluation, then so be it. But I think the concern is his overall ability to make a living at this point.
Okay, Mr. Kokonos, you're on mute, Mr. Kokonos.
I'm sorry. Is he still in the Army?
No, sir. He was honorably discharged, I think.
And
back in, yeah.
I was told that in the beginning that he had a head injury and some broken bones. What broken bones did he have? And
sure. I mean, he had a number of puncture. I mean, it was a fall from a 2-story balcony, the back of his house, which was by a creek with a lot of rocks underneath. So, I can't tell you for sure how many broken bones he had, but yeah, he had various injuries.
I wasn't aware that the locums is unsupervised, Dr. Zafran. He was in it. It's not supervised.
My understanding is that it's not. No.
Okay, and he was working in the locums system, and he didn't have any patient harms or any patient complaints. So he was functioning well in that system. And for a lot of reasons, because they're not every day, but he only wants to do part-time, why couldn't he stay in the locums?
That's something that we could deliberate afterwards, Mr. Kokonos, but that's an open question.
Okay. And why did he go into PHP?
Well, I mean, from my review of the record, he was referred to the PHP. Actually, I'm not really clear on that. I'm not sure if it was the Army that did that or not. I don't know where these
I don't think
PHP
it would be the
referrals.
Army.
No, so I'll let staff answer that question for you, Mr. Kokonos.
Normally, oh, go ahead. If you, I think what we're looking at here is if you're talking about the order that was proposed by Ms. Massey for staff, they would send him or ask if you approve the order as written. And again, as Dr. Zafran said, it's open for deliberation. That would be to observe him because there's a known mental component because of the traumatic brain injury, and the PHP would be the monitoring mechanism by which they could keep up with that, along with some other things I think that Ms. Massey put in the order. But I don't believe, is he in PHP now, Ms. Massey?
No, he was referred
Okay.
previously. I believe it was about 1.5 or 2 years ago.
Yep.
And he declined to participate.
Okay.
And so he is not.
Okay.
And if I may, a couple of other questions, Mr. Kokonos, that you had asked. He was medically retired from the Army.
Okay.
Following, it was about I believe it was about 1 year after the injury. And there was another question that you asked, about locums work. One of the things that Dr. McQueen, our expert, testified about was, so a locums need arises, as you may know, when a clinic or a practice is short-staffed and they need to replace that practitioner. So the supervision aspect of your question is an issue because if there's a locum tenens posting that Dr. Reed applies for and is selected for, it's because there maybe the maternal fetal medicine physician is on vacation or on maternity leave or something, and they don't have one. And so Dr. Reed or another locum tenens physician would come in and fill that role, meaning there's not a supervisor kind of dynamic most of the time, because that's the whole reason why they need that position filled. Does that answer your question, sir?
Thank you. No more questions, Dr.
All right.
Zafran.
Thank you, Mr. Kokonos. Dr. Green?
So, Mr. Montes, if he was in fact medically retired, not medically separated from the military, he should have TRICARE for life, which could potentially pay for his neuropsych evaluation. Has he explored that possibility?
Yes, and that was a point of frustration because he has regular care. I mean, he's got a neurologist, he's got a psychiatrist through the VA, but the VA has to approve such kind of testing, and as you know, if the neurologist doesn't refer him to a neuropsychologist for such a testing because there's no need for one since it's been so long since he's been stable for so long, it just won't get approved.
So it won't get approved for a VA choice to go to the economy to have the VA pay, but he should have TRICARE for life, which is a separate funding stream that he could use to get this testing. Anyway, I just think there's a way around this.
Dr. Green, sorry, Mr. Montes.
Oh, I'm just saying, that I've been talking with Dr. Reed for a couple of years now, and I have asked him repeatedly if there was any other way to go about it, and he's indicated that there's none. So that's all I know.
Dr. Green, if I may address your question. This came up in the hearing on the merits, and Dr. Reed testified that he is not approved for additional neuropsychological testing because he has already undergone. He underwent 2 in 2019, and then, I mean, I suppose that those 2 in 2019 were the extent that TRICARE was going to cover.
Thank you.
There's not anything stopping him from just getting a private, just paying out of pocket to do it.
Except I understand it's very expensive.
Well,
Yes.
financial cost.
But the last evaluations that we have showed concerns about the ability to practice. So that's what we're stuck with right now. So
Yes, Dr. Zafran, and that's exactly board staff's position. What we do have are these evaluations, 2 in 2019, 1 in 2023, 1 in 2025, and this is what they say.
okay, Dr. DeStefano.
Thank you, Dr. Zafran. Thank you, Mr. Montez, for being here. Can I just clarify, the doctors that he's seeing now for this condition, did they give him letters saying he would be okay to practice, or they had any concerns? And the other question would be exactly, kind of clarify again, what exactly is he doing right now? Is it just ultrasound?
Yes, correct. That's all he's been doing. As far as his practice, yes. And then as far as letters, we did submit in the record a letter from his neurologist indicating no concerns, and another letter from a few years ago from Dr. Zweigler clearing him for return to work.
Yeah, but my understanding though is that he's just doing ultrasounds, but technically he can do anything he wants to though, right?
At presently, yes. Now, he has, since the beginning, has indicated to the board, again through the informal process, that he would only be wanting to do ultrasounds as he's been doing since the injury.
Are these ultrasounds for the hospital or for a private practice?
I believe the locums that he was doing was for private practices.
Any other questions? All right, with that, I am going to go ahead and move this into deliberation. Before you, you've heard the testimony from board staff and from the respondent's attorney. You have a proposed final order from staff. Obviously, as we mentioned with the earlier proposal for decision, the adoption of the findings of fact from the administrative law judge is something that you know that's something that we have to adopt. But as far as sanctions, you have before you what is proposed by staff. It can go from that all the way to doing nothing at all. So I'm going to open it up for deliberations to have a conversation just between the board members as to any thoughts, questions, concerns. I am looking over here for any raised hands. I don't see any. I guess the question, sorry, who, Mr. Kosa? Sorry, go ahead.
Sorry. So I'm in reading the kind of determinations, if I'm missing this, I apologize. But he went for a K-STAR evaluation in 2025 for fitness for duty, and the evaluation, I'm going to read this off. The evaluation identified significant neurological impairment, including deficits in attention, memory, executive functioning, insight, and judgment, and noted concerns regarding organization, documentation, and attention to detail. And K-STAR evaluators diagnosed a major neurocognitive disorder and recommended practice restrictions. And it addressed avoiding obstetric and gynecologic procedures, locum tenens practice, and practice within structured team-oriented environments. So I guess for those of you, the physicians in the room, if we talk about him wanting to be restricted to radiology, where maybe you're not having patient interaction, I can see where that might be some sort of an opportunity for him to continue practice. And yet when I read these things about deficits in attention, memory, and, attention to detail, I don't know the structure in a radiology practice to understand how it still might provide that oversight for protection.
So I don't think that this is much a radiology practice as much as it is an interpretation of an ultrasound for obstetric patients practice. And, when we have a K-STAR evaluation, which is something that we use typically for competence, These are pretty specific recommendations, and it involves specifically locums. It involves specifically, management of obstetric patients, which interpretation of an ultrasound really is part of management of an obstetric practice. And if there's any kind of inability in a locums type of situation, or even in a practice setting, to timely interpret an ultrasound, I mean, that can have grave consequences also. If there's a misinterpretation of an ultrasound, that can have grave consequences also. My other concern is, and I think this was alluded to earlier, and we all know this, is that just because a complaint has not been presented to us of concerns does not mean that there has not been concerns out there. All that means is that we haven't gotten to the level of getting a complaint yet. My concern is that if these are a lot of ifs here, and this is again just my opinion, but if something were to happen that would create patient harm, we have in front of us recommendations, objective recommendations from multiple sources having concerns about fitness to practice. I think before us are recommendations saying, look, if that changes, whether it's now, although he just had recent testing, or a year from now, or 2 years from now, there at least is a pathway to reentry. So, I think there's something to be said about the recommendations that are currently there, and a pathway if something changes, and I certainly hope it does. Again, we have an Army veteran, somebody who served our country, but unfortunately had a traumatic brain injury. That doesn't mean that something may change, and that that the circumstances become different and allow the board, if we adopt the recommendations, to make a different judgment. But I personally just have a really hard time looking at the recommendations right now from an objective source, and actually from multiple objective sources, and just not at least having him go through a pathway that assures patient safety moving forward. Dr. Green.
Yes, Ms. Troncoso, I was going to add that MFM, the fellowship, 3-year fellowship he did after his OB-GYN residency, allows the doctor to specialize in high-risk pregnancies, which are very details of the ultrasound are literally the huge part of what they do. And so, and in the locums capacity, especially, there's no one else there. There's not someone he can call to say, like, hey, can you come check me? And if you need someone to check him, then what's happening? So details are literally a humongous part of the MFM physician's job with respect to the ultrasound specifically.
All right, I believe Dr. Farmer.
Is there any more discussion, or are you entertaining
It's up to
motions
you.
at this
You
time?
anybody is welcome to present a motion at any time they so wish.
Okay, I will do that. I move that the board adopt the findings of fact and conclusions of law of the administrative law judge in the proposal for decision, and approve the suggested final order filed in this matter by board staff.
So motion's been made by Dr. Farmer. Is there a second?
I second.
Barnes.
Second, Rosso.
Okay, Mr. Rosso has a second. Is there any further discussion on the motion? Seeing none, all those in favor, please say aye.
Aye.
All those opposed?
Aye.
All those opposed? All right,
Aye.
motion passes. Thank you.
Was that a nay? I nayed, Morgan.
That was just a delay. So
Wait, no. Sorry. Ms. Morgan, just want to make clear. Did you vote against?
I was opposed, yes.
Okay.
Okay.
Was anybody else against? Was anybody abstaining? Okay, so we have 18 for, 1 against.
And no abstentions. Okay, thank you. All right. I know these are all difficult. These are decisions that we all have to make. It's never easy, but that's why we have a deliberative process. I am going to just quickly go through these so that we can get to the rules. There's one item that we're going to have to go through before we get to the rules that unfortunately is going to involve an executive session. But we'll get to that in a second. Number 17 is report physician assistant liaison. There's none there. I'm going to skip 18, 19 reports and automatic orders. There are none there. Number 20, consideration approval of orders to show cause. There are none there. With that, we're going to go to 18, consideration and possible action regarding pending litigation. This is going to be our general counsel, Mr. Freshour. And I believe with that, we are going to need to go into executive session for advice of counsel.
Yeah, before we do that, I do want to give a report. There was one motion for rehearing on a case filed at SOA that you denied as a board, and that now is potentially able to go to state district court on a substantial evidence appeal. Other pending litigation that's going on are just routine substantial evidence cases. There are a couple of exceptions, and those exceptions do require some advice from myself and my staff. So again, Dr. Zafran, as you ask, I would recommend we go to executive session now to discuss pending litigation.
Thanks, Mr. Freshour. I made a motion. Is there a second?
Second.
Second, Green.
All right. Any objections? All right. With that, so the board is going to close this meeting to the public and continue an executive session for the following reasons: private consultation and advice of counsel concerning pending or contemplated litigation, settlement offers, and or legal matters subject to the attorney-client privilege under the authority of the Open Meetings Act, Section 551.071 Government Code. Deliberations concerning personnel matters under the authority of the Open Meetings Act, Section 551.07 Government Code. While in executive session, the board will not take any action, make any decision, or vote with regard to any matter that may be considered or discussed. A certified agenda of any executive session will be made. I am now closing this meeting at 10:28 a.m., March 27th, 2026.
All right, very good. You need to leave. You'll be called back in, but this, okay, no worries. We're going to get back to you. Okay. No. Right. And
While in executive session, the board has not taken any action, made any decisions, or voted with regard to any matter that may be considered or discussed. And there is a certified agenda of the executive session that will be made. All right. So the other than the consent agenda, the other main item on the agenda that we need to discuss is going to be our proposed rule on ketamine. Here we go. Let's see. Chapter 173, Office-Based Anesthesia Services. Subchapter B, concerning IV ketamine therapy standards, 173.6 through 173.14. As many of you know, proposed rule was passed for consideration back in the December meeting for public comment. We've had public comment or opportunities for public comment between that last December meeting and actually, I think up until yesterday. The opportunity today right now is for us to, number one, hear from those who would like to testify on the matter. And then after that, and Scott and Brent will go into a little bit more detail about this, but there will be deliberation by the board on how to move forward. I know that we have gotten some input from key stakeholders, which has allowed the board to propose some minor changes in the language that I don't think we consider to be substantive. Hence, therefore, wouldn't require us to send the proposed rule out for public comment again. What is going to be intended out of this, as I had mentioned before, is for those who want to testify to be able to do so. It's 3 minutes per individual who wants to testify. We're going to give preference to those who are here physically, and I believe we might have some legislators who are also wanting to testify. I'm going to check to make sure that if any is there, I will also give them priority, and then after that, we will go down the list. Are there any legislators on right now? But with that, Scott, do you want to go ahead and at least start the process, and I'll kind of check on here?
Yeah. Well, and what I'm going to do is I'm just going to give a very high-level overview. I'm not going to go into much detail or anything. But what we have to date was we received about a total of 216 comments. Quite a few of those were form comments submitted, which is not unusual from, groups or individuals that are similar situated. Had about 170 individuals that commented and several organizations. We've got a breakdown again. I'm not going to go into that because we want to get into the rule, but there's two things. I'm going to first cover the two minor changes we've made, and then I'm going to give a summary of what we're really, for lack of a better term, is kind of the 3 or 4 big issues that seem to be the common theme throughout the commenters the comments we have received. So one of the things we received some input on, and this included a number of groups, including some of the nursing associations brought to our attention. I think it was in 173.10, it said that the physician, the APRN, or the physician assistant must ensure, and then they laid out some standards. And of course, the concern was it sounded like we were asking the nurses to somewhat comply with some of the standards that would be set for the clinics. What my staff looked at and what we determined was we should use the same language we used in the actual office-based anesthesia rule, saying the physician must ensure these things are done, and not putting it directly on the APRN or the PA, because that's how the office-based anesthesia rules work, and that is really what we're attempting to do there. So the version that we have right now that's posted for today's meeting does have that change in there. Again, I know that the nursing groups had pointed some of that out, so along with others, but we did change that. The second issue that came up was there was a requirement that you must have a CO2 end tidal monitor for patient monitoring post-care. We received a consensus letter from the Anesthesia Society, as well as a ASKP3, which is a group of practitioners advocating for the ketamine therapy, composed of physicians. They agreed to let's make that as needed or as necessary instead of a mandatory piece of equipment. It just needs to be potentially available. So we made those 2 changes. As to the comments in general, there was, as I said, a theme, and I'm going to hit on those very highly. I'm not going to explore it in detail or break it down. I'm not even going to, name which group kind of fell here, which fell there. Excuse me. So the big issues, and we heard this literally from a large majority of commenters. There's a concern over the no in-home administration of the ketamine therapy. And again, one of the points I think Dr. Zafran will be clarifying is, again, this is for, intramuscular IV and only certain forms of ketamine. It's not the oral, it's not the nasal form. So again, just when some of the commenters, we just want folks to be aware of that, okay? Now, I'm not going to go into, but a lot of people were concerned with that particular aspect, and there were several different rationales given. I think we'll hear those from the commenters. The second big theme, or maybe the first, depends on how you look at the comments because they were all very common, was there was a great deal of concern from practitioners of all types, nurses, physician assistants, some behavioral health folks, just a whole bunch of folks were very, very concerned over the physician being in person at the facility during administration. There are claims like this is going to be costly, it's going to limit access to care. So we're aware of those are the big issues. We're going to hear them today. I'm just laying it out so you as the stakeholders and the board members understand we know what the issues are today. So we haven't ignored, we've read really, really closely. So we know what's going on out there and what folks are thinking. The other big area was under supervision and delegation. There was a great deal of concern that the physician assistants and the advanced registered nurse practitioners could not necessarily have the supervision and delegation authority to actually order the ketamine therapies. And again, I think the stakeholders and Dr. Zafran and the board will probably be addressing that along with their stakeholders. But again, the way the rule is set up, the physician will order the ketamine therapy once you've established a doctor-patient relationship and appropriate diagnosis. The practitioners, as long as it's within their scope of practice, like a nurse, an APRN, or a PA, they can administer the therapy. So again, that is specific in there. The ordering part, I think, is what caused some, for lack of a better term, consternation among our commenters. So those were the big 3 areas that we saw coming through. There were some comments that because of the in-person requirement, there may be some telemedicine implications. And I know we've got some telemedicine providers that submitted comments. So again, this is not to say we are making a comment one way or the other, but we acknowledge that those were the primary concerns we saw from the commenters. With that, Dr. Zafran or Ms. Carlton, I'll turn it back to y'all.
Okay, I am going to go ahead and open this up for public comment. I'm going to give, just from a standpoint of legislative privilege, before I start, Dr. Quinones, do you have a question?
Yes, I do, specifically for Scott. Scott, the plan is outlined as specific for psychotropic, for use of psychotropic ketamine therapy. It is not for pain management therapy. Is that correct?
Right. Pain management therapy is treated differently under our pain management rules. This again was for the what is commonly known out there, and we've defined it appropriately, but kind of the low dose ketamine therapy for PTSD, for medication resistant depression, and some of the psychiatric off-label uses that we're beginning to see quite frequently. But it's not for pain, and
that's
the indication that the rule is focusing in on.
Yeah, I just want to make sure that we can, let's hold a lot of what we want to say also for deliberations later on, Manny, for the board members. So I'm going to go ahead and I see that Dr. Oliverson, one of our legislators, is on. If there's any other legislators that are on that would like to speak, please raise your hand also. But I'm going to go ahead and give the floor to Dr. Oliverson.
Thank you, Dr. Zafran. Thank you, board members. Appreciate the opportunity to spend a little time with you. For those of you, I think most of you probably don't know this, although I know, Scott, you know this, but long before I was a lawmaker, I was actually at the board in the old hobby building, meeting with y'all, working with y'all on Chapter 192 of the medical board rules regarding office-based anesthesia. So I know that section of code really, really well. I've spent a lot of time working on it through the years. I do think it's really important. I think it's really, really important to just always keep in the back of your mind that prior to the creation of that section of the Medical Practice Act, there was a string of pretty high profile, pretty serious, unfortunate outcomes involving anesthesia and providers' offices, including deaths of children and other things. And so that's what prompted this. And I think that always needs to be the focus. And I want to commend the board for continuing to take that very seriously. I'll keep my comments brief, but I do just want to point out ketamine is a powerful anesthetic agent. That is what it is. It is also a drug that has a high potential for abuse. It is a controlled substance. It is available on the black market. It is sold on the street. People do abuse it. I don't think that it's wise for folks to be giving it to themselves at home. It sort of conjures up images of Michael Jackson and other situations where people have inadvertently given themselves a medication that has adverse reactions. I would also point out that as we're talking about a medication that has both an anesthetic and a psychotropic effect, the difference between sedation and anesthesia is simply a matter of dosage and concentration. Errors do happen. And so if you're at home by yourself, if you are not in a medically supervised environment, you could potentially give yourself a lethal injection. I know that's not what anybody wants. I know that's not what we're trying to do here. But I do think that the rules that you've crafted are narrow in purpose and scope. I do think that they appropriately balance the need for low-dose ketamine, but also simultaneously protect the public from possible harms. I mean, at the end of the day, I think we just have to recognize that nobody wants somebody to inadvertently and accidentally overdose on a medication that has known anesthetic properties and can be used to induce unconsciousness. And with that, I just want to commend you for the work that you're doing. I know it takes a lot of time away from your practices, from your jobs, from your families, but we desperately need you. And so I'm grateful for your service. Thank you very much, Mr. Chairman.
Thank you, Dr. Oliverson, and thank you for your service also in the legislature. Really appreciate you taking some time and coming and speaking with us. Do we have any other legislators online that would like to speak? Please raise your hand if you do. Okay, I don't see any right now, but if I do later on, just let me know and we can always divert to that. I'm going to start off with those who are actually here, physically here in the room, just to kind of give them deference since they are here. Did we have a list of those who want to testify from here?
I don't recall us getting a specific list for sign up, but that's okay. If you guys kind of have worked it out of who should go first or whatever, we're fine.
Okay. Are you testifying also?
Yeah.
Okay.
Yeah.
Well, you were here early, so why don't
And the gentleman in the blue suit and the young lady here were first, and then I think y'all showed up, right, folks? Oh, okay.
All right. So why don't you go ahead and you can come up to the mic over here and just press on that button. And, if it's green, then we all hear you. And you can see the timer behind you, that 3-minute timer. So
just go ahead and state your name and you may begin whenever you're ready.
I'm Annabelle Morris. I'm a LPC associate. So I work in behavioral health doing ketamine assisted psychotherapy. This rule, specifically 173.9, would greatly impact the work that I'm doing right now. The clinic that I work at, we do IV ketamine assisted psychotherapy. So because we're able to use the IV, we can control the dose at a low enough level that I can be talking to the client throughout the entire experience. So I'm working with people who are very suicidal, often have had at least 1 to 2 attempts already. So my concern in this rule is just kind of losing access to this, and the way that we've been doing things would result in potentially like clients immediately completing suicide or having loss of this care that is life-saving for them at this point. other options that they would go to potentially would be ordering it telehealth and be doing it in a more unsupervised environment without medical staff there. Currently, we have nurses and a therapist in the room with them the entire time. And so there is a lot of safety. There's a lot of control that the person who is experiencing this experience has as well. And when you're kind of doing oral administration or the esketamine, you don't have that control over the titration and the level. And when we're working with trauma and psychotropic things, you can be actually kind of reliving the experiences that you've had. But if you're able to be connected and have support with someone through the experience and feel like I have medical people there who are monitoring me, and we agree with many of the things that are in here of kind of, we do need more safety. We do need more regulation. Does the method of administration, such as the IV, really change so much from kind of these oral administrations as well? And many people are unemployed while they do this treatment, or kind of in a depressive cycle where they can't be employed. So cost and access to care is super important. And so kind of having more barriers of a physician on site would kind of add more barriers to people who are stuck in these cycles of kind of depression and poverty from being able to access a life-saving treatment that somatically helps you. So kind of helps process trauma in the body, and then also helps you kind of work through things in an incredible pace. I do talk therapy with clients as well. I work with suicidal clients in many different aspects, but this is the most effective treatment, and it is important to be supervised by a therapist during it, in my opinion. And so I do want more safety as well. I just don't know if kind of bringing in this would create that or a barrier. So
Great, thank you.
Just for clarification, so you say you agree with a lot of what's in the rule. Is it just the physician on site? Is that the only thing?
yes, and kind of having a determination of the administration being, like the IV administration being different than kind of the oral
So
administration.
that's an order from a physician as to whether it's IV or IM or so forth. So who are you suggesting would make that determination?
Well, we do all IV on site, and so we need access to be able to do low dose IV. So what we're doing, and I'm kind of on the therapist side, so I just am like, I need access to be able to work with clients in this
But
way.
who's making the diagnosis and making the determination to order the ketamine?
Yes, we have medical staff on site, I believe, a nurse practitioner, and a doctor who is supervising everything, but the doctor is not physically on site. So we do assessments before with both.
Who's making the evaluation though? Is it the nurse practitioner or is it the physician that's making the evaluation, the diagnosis, and the determination of what to use?
We're collaborating as a treatment team. Kind of, since it's a mental health thing, where I am diagnosing kind of what if we're working with depression, PTSD, things like that. So we're creating a diagnosis through that. And then we're working with the medical staff to make sure they do a medical intake. We're working closely with the doctor to make sure there's no complications.
Do you guys check the PMP, for example, to make sure that there's, to know what other medications are being used?
Yes, we do we get lists of every medication you've ever taken, and then the current ones that you're on, and we go through each one and what you would need to change about the day of administration, or kind of what is safe, because some are not safe to discontinue, and then we're really looking closely to make sure.
I guess when we say we, so again, I'm kind of going back to the original question I asked, who's making the determination of what medications to stop, or potentially are there medications that are being taken that can have an additive sedative effect if taken together, and whether that might require extra caution as to how the patient's being monitored?
Yeah, no, we are always thinking about that. Yes, sorry. And I am on the therapist side. I know we have the nurse practitioner who goes through a medical intake with them. And then we have a nurse on site who's talking to them the morning of to make sure that kind of what we had discussed in the medical intake is actually happening and being implemented, as well as I'm sitting down and talking with them before to ensure that kind of there's nothing happening that, like, physically for them in terms of slurred speech or kind of anything where there could be something I could tell that it wouldn't have been reported.
Okay, great. Thank you so much.
I'm sorry, this is Dr. Cunningham. Just, I'm her medical director. I'm having a hard time in my Teams interface trying to get my hand raised, but just to let you know, Ryan is our psychiatric nurse practitioner that evaluates these in person or via televisits. We do review all their medications. With each intake, we also do an EKG. Each of those first infusions I view through a remote telemetry. So I look at their real-time oxygenation status, their 3-lead EKG during all of those, and I'm viewing those for the first infusion. If there is any issues, obviously we have robust protocols for 911 calling, certainly have ALS capability with a defibrillator in our clinic. So those things are available. I did submit an additional finding talking about emergency medicine stance about the various levels of ketamine, if that was referenced for this over. Sorry for the interruption.
Okay. You said that you monitor oxygenation. How do you monitor oxygenation?
We have a finger plethysmography that does that, as well as the continuous telemetry during their monitoring. So it's a device that they wear continuously during that. The nurse with ACLS training is in the room with the patient the entire time. And we always stay below the dissociation threshold over our duration of therapy, typically 45 minutes to 60 minutes, always below the 1 milligram per kilogram over that entire hour. So we never, as our therapist has said there, our patients are conversant during the entire session. If they ever become non-conversant or from a communication perspective, meaning they're not interacting to the questions or prompting, we would slow down the infusion to ensure that. That is purely, they remain really at an ASA 1, possibly, or sorry, their level of sedation is very rarely into the procedural sedation level. Over.
Okay, and I'm sorry, I know that I just want to make sure that I have a little bit of help getting this answer. So you said that if there's any issue that you'd be calling 911 or that they're ACLS certified, let's say it's a morbidly obese patient who is on risperidol and, other psychotropic medications, and, they're taking the ketamine infusion right now, and all of a sudden, they start obstructing, desaturating on you, and now you have a situation where they have stopped breathing. What is your process as to what you would do at that point?
So I would say, and over our 4,000 infusions so far, that is any airway compromise has not occurred even remotely. And part of this is staying at that dose.
No, I understand. I mean, of course, that's great. And I'm glad that nothing's happened. And you guys probably have a process that works great. I'm just asking, what if it happened? What would you do?
So that's, they would stop the infusion at that point. They would use simple airway maneuvers to place oxygenation on the patient and then call 911. And
what kind of airway maneuvers?
So you're talking about placement of a nasopharyngeal airway, placement of a non-rebreather on the patient, and talking about certainly should they require bag valve mask during that. That is a component of ACLS training that's present. So these would be basic airway manipulation maneuvers, jaw thrust, as well as NPA placement. If they do require an OPA, that's certainly a part of it. But being where we're located, response should be within a very brief period of time. But those are, if you look at from this dosing threshold, it would be in a considered anxiolysis from an emergency department perspective. And so for this dosing range, we don't even take them fully through an airway assessment. We obviously keep that in mind in the emergency department. Here, there's an assessment of any prior obstructive sleep apnea, any prior issues with either anesthetic administration or prior reactions that we review, as well as that full interaction of medications that I go through before the order is written for each of these patients. Over.
Okay. All right. I've got a lot of hands raised, so I just want to move through the process. Just wanted to ask those questions real quick. So thank you very much.
Thank you.
I think it's Dr. Abouleish, I believe.
Good morning. My name is Amr Abouleish. I'm a pediatric anesthesiologist. Thank you for the opportunity to provide testimony on parenteral ketamine therapy. Parenteral administration is the administration of drugs by injection, including intravenous, intramuscular, and subcutaneous routes. For this testimony, I'm going to use the word injectable rather than keep trying to say parenteral. I'm a board-certified anesthesiologist. I'm a tenured professor of anesthesiology with over 30 years of clinical experience with injectable ketamine in both anesthetic and sedation dosing. I'm speaking today on behalf of the Texas Society of Anesthesiologists, TSA, in support of the Texas Medical Board's proposed rules on injectable ketamine administration. These rules appropriately recognize that injectable ketamine, even at low doses, carries real risk and requires preparation, dosing, and monitoring by trained healthcare professionals. It is not a medication that can be safely self-administered. For this reason, TSA strongly supports the requirement injectable ketamine is only administered in a clinical setting with appropriate monitoring and a physician being physically present on site. TSA also strongly opposes at-home injectable ketamine administration without an in-person supervision, particularly models that rely on a patient to self-dose medication shipped directly to their homes. This approach raises serious safety, ethical, and professional concerns, and I do not believe it represents a responsible standard of care. In many ways, this model is even more concerning than the pill mill practices seen during the opioid crisis. We are not discussing oral medications. We are discussing a potent injectable anesthetic agent with no reversible agent in the event of an overdose. In the hospital, ketamine is treated as a controlled substance with strict accountability for every milligram. It is difficult to reconcile that standard with the idea of distributing parenteral ketamine directly to patients without appropriate safeguards. The TSA and I are sympathetic to patients seeking ketamine therapy. These individuals are often facing significant mental challenges and are searching for relief. My testimony today is not about efficacy, it's about patient safety. These patients are vulnerable. Without appropriate safeguards, they may be at risk for manipulation or exploitation, particularly in care models where financial incentives may outweigh patient protection. We must balance access with safety. The Texas Medical Board's proposed rules do exactly that, protecting patients while preserving appropriate access to safety. The TSA, the Texas Society of Anesthesiologists, supports the board's proposed rules on parenteral or injectable ketamine therapy. Thank you.
Thank you. I believe Dr. Plaganoff.
Good afternoon. My name is Dr. Debbie.
Yes, it is.
Okay, I can't see from here. It's
Is it? Okay.
perfectly situated. I couldn't see the logo.
Gotcha. My name is Dr. Debbie Plaganoff. I am a board certified anesthesiologist for 32 years now. I'm currently in office-based anesthesia practice, and I give ketamine parenterally on a daily basis for my patients. I administer ketamine, both IM and IV, so intramuscular injections and IV injections. And what I would say about on a daily basis, I see different effects from ketamine on most every patient. There are dosages that we start with, but anesthesia is a titratable specialty. So this is an anesthetic drug. It's a very potent anesthetic drug. It has ranges, as we've heard, of anxiolysis, but all the way up to general anesthesia. And given a certain patient circumstance, that may be my goal on any given day, to achieve general anesthesia. And it's very easy to do so with a single injection of ketamine. So what I would say about that particular circumstance of administering this drug parentally at home, there is no way to absolutely know what's going to happen to any given patient in their home receiving IV or IM ketamine. It's impossible to predict whether that patient will maintain their own airway, be able to breathe, not breathe, have their heart rate change, their blood pressure, their oxygenation levels. Dr. Zafran mentioned a morbidly obese patient and what might happen with an injection of ketamine to his airway. I can tell you on any given day, I am supporting physically myself with my own hands airways of patients that have ketamine. I'm monitoring the oxygenation level, I'm changing things, I'm titrating. So there's no reversal. Once we give an injection of ketamine, we know that it's not like fentanyl. It's not like a narcotic where you can give Narcan and back out of that. You have to realize that once you get to a certain level of sedation, backing up is much more difficult, and the only way to really handle that situation is physical on-hand support by a trained professional that understands airway management and practices airway management on a routine basis. Hence the reason why physicians need to be involved. We know that there have already been serious incidents with people having ketamine sent to their homes and using ketamine in their homes. Recently, there have been deaths in homes due to that. We don't want another opioid crisis on our hands with a new drug, now ketamine, just switching from one thing to the next. So we at the TSA and personally encourage adoption of the rules as written by the Texas Medical Board.
All right. Thank you so much, Dr. Plagenhoff. While I have the two of you here, I just want to ask a quick question. I know that dosing comes up quite often, and for the public, that may not seem like a very straightforward thing. Now, we talked about morbidly obese patients. We also talked about the potential for other medications, especially psychotropic medications, having some kind of impact. How easy is it to predict a dose that may actually tip somebody over from being awake to anxiolysis to general anesthesia? Is it predictable to the point where you can catch it ahead of time? If you stop the IV infusion, how long would it take for the impact or the effect of that medication to now not reverse itself, but wear out of the system so that you actually do have an airway? Just help us understand what that looks like, because I know that dosing comes up quite often in this conversation.
So for me, once you've reached a certain level of sedation in a patient, especially with a drug with a long half-life, a long-acting drug, anesthesia is a continuum. So you are already into the next level of sedation. We go from mild sedation to moderate sedation to deep sedation, general anesthesia. Once you're over the line of that, there is no set timeline to where you will be able to have that certain patient metabolize that medication or drug and come into the lower level of sedation again. That's an individual situation based on that patient's metabolism, the function of that patient's body, their body composition, their reserve. It's unpredictable.
Okay. So if I can answer, I mean, when I teach my residents and we talk about sedation, moderate sedation, which patient is talking or responds to verbal versus general anesthesia, I always tell them, I give them this analogy. You're up by a cliff. General anesthesia is easy because you got a parachute, you jump off the cliff and that's your goal, and you have a parachute and you can do it safely. Sedation, you don't have a parachute and you're trying to walk right along that cliff without going over. And it's actually harder to do a sedation for a procedure oftentimes to get them at that right level without going too far. So it's a challenge. Now, you ask what the dose is. It depends. That's the problem. It depends. You can give 1 per kilo IV as a dose, and some patients will go full general anesthesia. Some patients will talk to you, and you have to titrate it. The problem with ketamine is it's non-reversal. In early my career, it was one of the few drugs we could use for a variety of procedures like wake fiber optic, and it was very difficult to use because if you got too much, you were in trouble. And now we have other agents that are much easier and reversible that you can reverse. Ketamine scares me because you can't reverse it. I talk specifically about at-home therapy, but I also am worried about in clinic, not having physician present, because although what was described sounds like a very good clinic, a physician who's trying to appropriately give good patient safety, but that's not all clinics, and that's what worries me.
Let me ask one last question because I think this is important. I know we've got a lot of people who are waiting to testify. As many of you remember, there was an incident in a hydration clinic where a patient died. And that involved giving a medication that typically normally would be harmless. It happened to be potassium. Harmless if you give it by mouth, harmless if you give it in a correct dose, harmless if you give it slowly, etc. That one was particularly done by, I think it was an unlicensed person, but the dose was given quickly, and the patient had a sentinel event and died. There was no time for 911 at that point. Speak to me a little bit about the concentration of ketamine and what barriers are there to errors in mixing it properly and how it would be given, and if that incorrect dose is given, what that would look like potentially. Because I think I saw something along the lines of the concentrations are typically something like 100 milligrams per cc is what I had seen. Obviously, that would be diluted out. We all know that errors happen, medication errors, mixing, stuff like that. What would that look like, and what potentially could happen in a scenario like that?
So in our hospital, they provide, when we use our sub-anesthetic ketamine as a multimodal pain, we no longer get 100 milligrams per mil. The pharmacy has pre-loaded the syringes for us so that we don't make a dilution error. It comes as 10 milligrams per mil. It worries me 100 milligrams per mil. That's what I use for intramuscular injection for a patient that's uncooperative. Let's say a 200 kilo, mentally has cognitive issues. That's what I use to give an intramuscular injection. When I go to dilute it, we find that dilutions can cause problems, and you have to double check, triple check it, and make sure you don't have problems with it. That's a high. I can see easily you have a dilution issue if you're not get proper. If you're expecting a patient at home to do it, it would be impossible. In the clinic, they should have proper procedures to make sure it doesn't happen. In our hospital, the pharmacy does it under a hood, and they bring to us already diluted, so we don't make a dilution error. If you give 10 times the dose, you're going to get general anesthesia. Patient, you may lose their airway, you may have problems with the airway, you may have hemodynamic problems. I'm not here to talk about efficacy. I'm here to talk about patient safety. It worries me. But I think the rules that are proposed give that balance. Continue to have access, but also keep the patient safe.
So for me, I'm in the office and I'm using 100 milligrams per cc bottles of ketamine every day, and I'm working with a small TB syringe where I'm measuring out to the 0.05 cc limits with my eyes. Down to every little tick line, and I'm a physician of 32 years. That is a very easy thing to miscalculate in the wrong hands, and to just overdose. And I heard some discussion about easy airway maneuvers, simple airway maneuvers. In many patients, airway maneuvers of any type, when an airway becomes obstructed, when an airway is lost, that basically means we're having to take over the breathing for that patient. And that is not what we would consider easy. Many times, you can use your oral airways like the gentleman, the physician was saying. You can place oxygen on, you can use a nasal airway, you can try to bag them, but even for people who do this every day, and that is our specialty, that sometimes is a very, very challenging situation that we don't want to get into. And with ketamine, within the span of about 2 minutes, you can be there.
Great. Thank you so much. Very helpful. Is there anybody here physically that wants to testify? All right. I saw that actually one person dropped off and came back on, so I'm going to go to him first, and then I'll go down the list again. So I believe Randall Clark, are you on?
Yes, Dr. Zafran, how are you?
Yes, sir. How are you?
Good.
Great. You have our undivided attention for 3 minutes.
Thank you. Good morning. My name is Randall Clark. I am currently the chair of the board of directors of the Anesthesia Quality Institute. I'm a past president of the American Society of Anesthesiologists and a pediatric cardiac anesthesiologist in Denver, Colorado. I also led the effort in Colorado from 2020 through 2023 when it became known of the injuries to the public from the use of ketamine by EMS personnel, including the death of Elijah McClain in Aurora, Colorado. Ketamine is a powerful drug. I can attest to that from 40 years in practice as a pediatric anesthesiologist, where ketamine is an extremely useful agent. It is also a unique drug, one that does not have a reversal agent like opioids do. Everyone in medicine shares the goal of improving the care of patients with treatment-resistant depression and PTSD. Ketamine has shown promise in this area, but that does not change the fact that it is a powerful drug that can compromise breathing. There's a reason it is a controlled substance, and I emphasize the word controlled. When given in doses and routes where respiration may be compromised, it must be supervised by a physician with the appropriate airway skills. I will add here that the records from the Colorado Department of Public Health, the agency that regulates emergency medical technicians, showed that 24% of the intramuscular injections in 2019 were accompanied by complications, primarily breathing complications. It is also a drug of abuse. Diversion and even hoarding is always a possibility. You have the evidence of how this drug can be used inappropriately and even lethally when not supervised. We have the unfortunate example of Matthew Perry. Finally, I will point out that the unsupervised self-administration of potentially large parenteral doses away from an appropriate facility flies in the face of accepted means of treating these difficult conditions, which require a model of close observation and continuous and ongoing support. For all these reasons, I urge you to adopt the rules as published. Thank you.
Thank you, Dr. Clark. Appreciate it. Next, I believe we have Dr. Carl Bonnet.
Hello, Dr. Zaffron. Appreciate your time. Appreciate everyone's time today. My name is Dr. Carl Bonnet. I'm the medical director for Clarisana. We operate ketamine clinics in Austin and San Antonio. I'm a board-certified emergency physician, and I have a few brief statements about the proposed rules. First of all, the bottom line is my main concern is the requirement that a physician need to be present at the time the ketamine is being administered. I feel strongly that advanced practice providers are more than qualified to supervise the clinic when the ketamine is being given by the parenteral route. A large part of my experience to come to that decision is both working in emergency medicine, working with APPs who work in rural centers where there's not a physician present, but yet they're able to give these medications in ERs. And also I spent 20 years in the Army National Guard, including 4 deployments to Iraq and Afghanistan. One of the things that really struck me during my deployments is that the forward operating bases where they're closest to the action, where the combat is happening, we're always under the medical supervision of a PA or nurse practitioner. Usually it's not a physician out there. So the argument that I made back in 2017 when this whole question of OBA came up for ketamine was that if the Army is okay with putting their forward operating bases in the hands of advanced practice providers, that I would feel very comfortable putting our clinics in their hands as well. Now, with regards to the doses, I agree with some of the issues that the anesthesiologist had brought up. I would like to tie into what the gentleman from the TSA had brought up earlier about the idea of using sub-anesthetic ketamine for the pain control modalities. Now, we also use what I consider to be sub-anesthetic ketamine. Dr. Zaffron, I know you and I have had that discussion in the past about whether it is truly such a thing as sub-anesthetic, but nonetheless, we're using very, very low doses. We're taking it very low, very slowly, and I don't feel that we're getting anywhere near the plane of anesthesia in our clinics. So the last thing I'll say is that if these rules are passed, the irony, I think, can't be ignored that at this point in Texas, we are allowing oral ketamine to be given in a home environment where we've seen doses far in excess of 1,000 milligrams per dose, which I'll let you all calculate the bioavailability. That could be anywhere from 100 to 200 milligrams of ketamine in the bloodstream in a home environment, plus auto injectors, which are not FDA approved. These have never been cleared for use. They're just created and being used. So Texas would be allowing these practices to occur, simultaneously saying that a nurse practitioner, CRNA, or PA aren't qualified to oversee very low dose ketamine in the clinic. So I would respectfully request that the requirement for a physician to be present be removed from these rules. Otherwise, I do support the concerns that the other people have brought up with regards to home ketamine in the state of Texas.
All right, thank you. I believe it's Sandhya Prasad.
Hi, good afternoon, Dr. Zafran and the members of the board. I'm Sandhya Prasad. I'm the current president and one of the founders of the American Society of Ketamine Physicians, Psychotherapists, and Practitioners, which a couple people have referenced today as ASKP3. I'm a licensed physician who owns and operates an interventional psychiatry clinic in Houston, Texas. I'm a psychiatrist. And so thank you to the board and staff for your time and care and seriousness that you've brought to this process. It's very important, and we really appreciate the opportunity to have been able to engage in the process constructively as a stakeholder. And we're encouraged by this framework that these rules established. The work that you have been doing really has the opportunity to set a national standard, which is why this is so important. And we're proud to see that Texas is really leading and creating this expert-led regulatory approach. So ASKP3 has been involved in this process and supports a strong safety standards and remains really proud of the joint consensus statements that we had submitted back in September with the Texas Society of Anesthesiologists. The document reflects meaningful cross-specialty agreement around patient safety, physician-led care, responsible access for patients suffering from serious psychiatric conditions. I wanted to make just a few brief points, especially regarding the home use portion that was in this, this chapter. So ASKP3 first created guidelines around ketamine for therapeutic indications back in 2017. And that early set of standards was created by our founding members of the society, which consisted of a multidisciplinary board of physicians, including psychiatrists, anesthesiologists, and emergency medicine doctors. And even in that rendition, there was unanimous agreement regarding no parenteral home use. And since that time, I have been involved in crafting 2 expert consensus documents that are in the process of being published later this year. And again, there was unanimous agreement regarding parenteral home use due to concerns about safety and abuse potential. So I wanted to give that kind of background. And this consensus among experts is really clear. Parenteral ketamine belongs in a supervised clinical setting, and these rules reflect that standard, and we support them. And we appreciate the movement away from the mandatory across the board end tidal CO2 monitoring and towards an approach where the equipment is available on site and used at the physician's discretion instead of a blanket approach. So we strongly encourage and clearly codifying this standard. And then we also respectfully request that following the full adoption of the rules that the board provide a reasonable grace period for practitioners to come into compliance. This has the potential to affect a lot of practices, and a defined transition period such as 90 to 180 days could support thoughtful implementation and promote compliance and avoid unnecessary disruption to patient care. So at the core, we share the same goal as the board, protecting patients while preserving access to the treatment that for many has been life-saving. ASKP3 stands ready to help with the transition in any way that we can, and we're very grateful for your service, and thank you for your time and consideration.
Thank you, Dr. Prasad. Appreciate your testimony, and good seeing you again.
Good to see you.
Lane Haygood.
Good afternoon. My name is Lane Haygood. I am an attorney in private practice in Texas. Turn on my video here. Thank you very much for the opportunity to speak here before y'all today. Obviously, in my practice, it's a little different than all the medical providers, but I do have a lot of clients who have turned to low-dose ketamine therapy to treat treatment-resistant depression, PTSD, things like that sometimes bring them in contact with the legal system. And so the comments that I want to make today are geared towards Section 173.9, specifically the on-site requirement for physicians. My concern is that that requirement is going to make it economically unviable for many of these providers to exist, and that is going to have wide-ranging effects such as the loss of care or loss of access to care. The reason why I think this is important is because I'd like to echo some of the other commenters and things they've made. This is obviously something where we do have a legitimate safety concern. Certainly, I don't think I would disagree. I don't want people administering injectables at home and things like that. I think it needs to be done in a clinic setting, but I think that the current rules regarding the clinic setting or the proposed rule maybe just needs some modification and tweaking. I think the on-site requirement is the biggest problem there. Our APRNs and PAs routinely manage far higher acuity interventions under remote or collaborative supervision in Texas. I think that the on-site requirement imports the anesthesia context into the psychiatric context where it doesn't necessarily fit. And so I would encourage the board to consider something like a regulation that has a clear escalation protocol, the availability for perhaps real-time telehealth or phone consultation with the physician rather than requiring the physician to be there in person, because my concern is that if we make this economically unviable for some of these smaller providers or providers in more rural areas or outside of places where they can afford to have an MD or a DO on staff full time, then you're going to have a lot of our most vulnerable Texans not be able to access the care, which has thus far been, at least as I've seen in my practice, revolutionary in helping some of these people overcome the problems that they have. And like others, I worry that if that inpatient, in terms of these clinics, care is not available, they're going to turn to more dangerous, less oversight alternatives. And so I would encourage that we consider a modification of those rules. I thank everyone for their time and their consideration.
Thank you. Just one quick question. You talked about escalation to having somebody available from a telehealth standpoint to consult and so forth. How do you envision a telehealth consult or a telehealth emergent availability of a provider to manage the loss of access to an airway?
Well, again, I think that APRNs and PAs are perfectly capable of managing that. I don't know that needs an MD specifically on staff for that. I think many of our advanced practice professionals are capable of doing that, probably without the need for direct supervision.
So they'd be able to intubate a patient, put a breathing tube in, manage a potential difficult airway, if something like that were to happen?
Yes, I do.
Do they have the training to do that?
Yes, particularly under supervision.
How do you know they have the training to do that?
Again, I've encountered this multiple times in my practice. I've had the opportunity to observe some of these clinics in action, and I'm familiar with the standards for care.
So, okay, that's debatable, but I won't get into that right now. But what does the FDA classify ketamine as?
I believe it is a Schedule II controlled substance federally.
It's actually Schedule III, but it classifies it as an anesthetic agent, correct?
Correct.
Does it talk about sub-anesthetic doses of ketamine? I'm speaking specifically about the FDA right now.
Not that I'm aware of.
Does it define? It doesn't define that. Are there black box warnings related to ketamine by the FDA?
I'm not aware of the answer to that.
Okay, I believe there is.
I would assume so, but I'm not specifically aware.
So they consider it to be dangerous enough to where it requires a black box warning. It has a very specific type of indication as to what it's classified as. So, I mean, obviously, access to care is important, but also making sure that our patients that we're trying to treat are alive when we give them these kind of medications is also important too. So, all right. Anyway, that's just a couple of questions I wanted to ask, and I'm sure maybe others will address that as they testify.
Yes,
Ms. Hemphill. Sheila Hemphill, are you there? I think you're on mute if you're trying to speak. All right, we will come back to you if you
wait, here I am.
Okay, go ahead.
Okay. One, I would like this to pause until I can flip over to about slide 5 where I can see my clock, please. So please stop the clock until the camera comes on. It says it's been enabled, so is that on my end? There we go. Okay. Hang on.
All right, we'll put you back at 3 minutes. Go ahead.
Okay. No, because look, y'all been able to turn off the camera, and
We can
I
see
can
you.
tell
We can see you, Ms. Hemphill. You're there.
it's not showing on my screen.
Okay. I can see you.
Okay, well, I'm gonna flip over here, and let's see here. I'm trying to flip to get the clock. I have to flip. You only have 8 panels, and there we go. There it is. It is on slide 6. Okay, thank you. Now see, I have 3 full minutes. Well, board, I'm Sheila Hemphill with Texas Right to Know, and I have been very familiar with the boards dating back to 2016. And I am finding a disturbing trend is that there's not a lot of history that gets retained about what's happened in the medical board. Oh, there I am down here. Okay, great. This is my first time to be on this Zoom meeting with y'all in your new building. And the reason I'm back is because I work with legislators. I don't have clients. I register as a lobbyist because of the time I spend on these issues. But something came up about the medical board. I said, oh yeah, they have a policy on how to file a complaint against the agency. They said, really? I said, yeah, here, I'll send you the link. Well, the link from the modified
Ms. Hemphill,
website.
let me just stop you for a second. We're not in public comment right now. We're only taking comments about ketamine. So
you're right. Then I'm in the wrong section.
Sorry.
But I wouldn't know that because the agenda said they would start after 9:30. So I'm after 9:30. I will yield back for my 3 minutes in a minute. Thank you
All right.
so much.
Thank you. All right. Kelly Light Transcend, I believe is how we pronounce it. Or Kelly Light.
Yeah,
Hi, sorry, I'm
Yep.
here. I'm gonna give my spot to Dr. Cunningham, our medical director, because he wasn't able to raise his hand, and I will get back in queue. So
Okay.
go ahead, Dr. Cunningham.
Dr. Zaffron and board, thank you very much for the opportunity to speak. Wanted to address a couple of the questions. It was my voice that came in when you heard our therapist in person there and the questions about what we use. The device we actually use for our clinic is called the Caretaker. So it's got the finger plethysmography as well as that 3-lead capability. I will monitor that remotely for all initial infusions. The other part, when it comes to dosing and the infusion rate, I think this makes a humongous difference. All of the anesthesiologist testimony, I certainly agree with the dosing when the intention of this is to achieve procedural sedation as well as some degree of anesthesia. The ACEP has a policy on sedation with ketamine specifically, and it takes it off the usual continuum so that it identifies as dissociative sedation. So that maintains complete airway protection as long as there are not concerns of polypharmacy, which is typically other administered parenteral sedating medications. The component about our dosing range, as I said, 0.9 is the maximum that we will give. And typically over the first 10 to 15 minutes of that infusion, we are giving approximately 0.3 to 0.4 milligrams per kilogram of that. And that achieves kind of that initial dosing range that so the associated the therapeutic effect of that ketamine can be achieved in a shorter duration so that the therapist can engage in successful and effective CBT with the patient associated on the evoking of their prior traumatic experiences. In regards to that dosing range, when we turn that infusion off in the subsequent 20-25 minutes of the second half of that, it's typical of that same dose at that 0.4 milligrams per kilogram. When we turn that medication off, we see a complete return to whatever their level of conversant communication was within a minute or two of dropping that rate when we were maintaining that very low threshold of the dosing regimen. So once again, in over 4,000 infusions, we've seen no impact to even sonorous folks that we have that have obstructive sleep apnea. The other part and I'm a 20-year plus active duty full colonel in the reserves, as well as a Texas EMS physician. So in the regards of the requirement to have even an advanced practice provider from a PA or NP perspective or CRNA, in addition to a physician on site in Texas in a pre-hospital setting, and the ASA has agreed upon this administration as a stance in pre-hospital ketamine, that those are paramedics that are the intervening provider from an airway rescue perspective. Intubation is generally reserved very rarely in that setting, and most of the time, I know there's some concern about basic airway maneuvers as well as
I think,
the consideration.
Yeah, your time now, Dr. Cunningham. Sorry.
Okay. Yeah. Sorry.
All right.
So
Thanks.
that's just those issues addressed. Thank you, as well as the
Thank you.
economic.
Tim, I'm going to mispronounce this. Geltz, I think.
That's uncommon. I appreciate that. I am, let me pop my camera on here. Thank you to the board for opening this up to comment. I am a licensed professional counselor, associate, and certified ketamine-assisted psychotherapist at Transcend that Dr. Cord, who was just speaking, is the medical director of. As I said, I am a counselor. I am not a physician, but I do want to say that I deeply, deeply appreciate the concern for the safety of any patient going through this treatment for mental health concerns, because it is an anesthetic that is being provided. From discussions with the medical team, it is my understanding that dosing ranges are very relevant to this, but being a counselor, I cannot speak to that. What I can speak to is the incredible efficacy that this has been shown to have. While it is the case that all of the concerns about any physiological thing that could happen during an administration are extremely valid, and that's why we do medical supervision during the administrations, I do want to come back to the point that access to this is a public safety concern, because this treatment is the single most effective treatment to treat suicidality. And I've worked with a number of different clients. I've facilitated over 300 administrations conducting the therapy and seen people's lives completely turn around from where they are on the brink of suicide. They have had recent attempts, and they are now happy, productive people within our society. So while it is the case that we do need to absolutely pay attention to the risks that are inherent in the use of this substance for mental health treatments, we do also need to consider the fact that it is incredibly effective at keeping people alive when they are on the brink of taking it from themselves. With that, I recognize that I am followed by our Director of Operations, and he has a lot of really good input on these different things about the dosing. If there are any questions I could answer, I would be happy to.
Great, thank you. I just want to emphasize to everybody again is that this is only addressing IV and IM ketamine. We are not addressing intranasal. We are not addressing oral. We are not addressing sublingual. So obviously those medications, even though some may have concerns about the dosing on those even at home, that is not restricted, and that would be available in a different type of setting for patients to have available for, whether it's psychotropic or chronic pain conditions. So,
No,
Mr.
Sir, if I could speak to that for a
Sure.
moment, sir. I appreciate the time. We're at Transcend. We do specifically IV administrations because that therapeutic dose range is the most effective. We'd like to preserve that model because the most effective way, particularly for people experiencing trauma, is to go through those experiences again with support. But it is the case that that is very intense and it can be re-traumatizing. And with other administration methods, we don't have the option to simply turn the pump down. If someone's going through a traumatic experience, reliving it, with IV administration, we're able to tone down the intensity of that so that it is therapeutically manageable for that client. If it's the case that we do a sublingual, which I'll be honest, we're considering if these rules do go through, it's going to hinder our practice in a way that we won't have that control over their experience, and it is riskier for them. We're working with very high risk clients all the time, and we're extremely careful to take care in giving them the best therapeutic experience they can possibly have. And to just very briefly, to comment on the gentleman who is present there made a very good point that it sounds like there are some good clinics out there. I do believe I'm part of one of them. And he said there are some not good clinics out there. And I really hope that we can write the rules in such a way that we can maintain access, the primary issue here being a physician being on site because it's barely affordable as it is, and rewrite the rules such that good clinics can continue to practice the way that they are with just a bit of nuance in the rule writing. I agree with every other regulation in this.
Okay, thanks. Will Ratliff.
Hello, sir. Thank you for providing an opportunity to talk today. I'm a nurse and paramedic, and for the past 6 years, I've worked full-time at a ketamine-assisted psychotherapy clinic. Other members of my team at Transcend have talked as well. I've personally monitored thousands of ketamine infusions in this 0.5 to 0.9 milligram per kilogram dose range. Prior to my work at Transcend, I worked on a medical helicopter where we used ketamine for the facilitation of intubation. So I have experience in these different types of dose ranges. And I do feel that there are some differences. My hope is to not oppose any regulation here. I am pumped that y'all are finally looking at this issue because I've seen a lot of things transpire over the last 6 years being in this industry. I think that there could be some practical refinements to the rules, though. I presented a petition to modify the proposed rule that primarily looked at the subsection F, the physician on site requirement. And I just hope that y'all potentially consider it. The main aspect of the petition just looked at the difference between the dose range under a milligram per kilogram infused slowly versus practices such as high dose ketamine at above a milligram per kilogram or bolus administration, and broke down different administration routes, because I believe that we can write this rule a little bit more intelligently so that where the actual risk from high dose ketamine or rapidly administered ketamine can be ameliorated, and that clinics that use a remote medical direction model may be able to still administer low doses by IV, because if a rule set is written that in the real world, a telehealth company is allowed to give 1,000 milligrams of ketamine to somebody on their couch, but me as a nurse that is experienced in monitoring patients in this care can't get 1 milligram without a physician right with me, I feel like this is very difficult to square. And so I believe that the rule set as written could use some modifications so that essentially clinics that operate with IV ketamine, that when I have the option of turning off the IV due to the short half-life of ketamine, any insult can be immediately remedied. And I'd also just like to speak to, if you'd like to ask me any questions about the emergency management from a nursing perspective without a physician present.
All right. If that question comes up again, I can use you as a resource. So I'll keep that in mind.
I appreciate that, sir.
Tamara Vaught.
Good afternoon, and thank you for the opportunity to speak today. My name is Tamara Vaught. I am both a CRNA and a psychiatric nurse practitioner practicing in Texas, and I serve as faculty for the ASKP3. I operate a ketamine clinic serving an underserved population with no other inpatient ketamine clinic within a 200-mile radius. Many of my patients travel long distances because there are simply no other local options for this level of care. The patients I serve, obviously, as many have spoken, suffer from severe treatment-resistant depression, PTSD, and suicidal ideations. Many are actively suicidal and have failed multiple medications, therapy, and even hospitalization. And for these individuals, ketamine treatment is often life-saving. I support appropriate oversight in patient safety. My collaborative physician and I have spent the past 8 years developing safe, effective protocols. However, requiring a physician to be physically present will not improve safety. It will reduce access to care. If this rule is passed, many of my patients will lose access to treatment. These individuals rely on consistent care to maintain stable. Interruptions in treatment for these patients with severe depression can be dangerous and in some cases life-threatening. I am genuinely fearful for what could happen in their care if it's suddenly removed. I recently treated a patient who sought oral ketamine from an out-of-state telehealth provider due to limited access. She was sent high-dose medication into the tune of thousands of milligrams to be mailed at her home with minimal oversight. She felt unsafe, unsupported, and experienced only marginal improvement. After finding my clinic and pursuing treatment, we used a significantly lower dose, and I'm talking 100 milligrams total versus 1,200 milligrams in a single oral dose, in a monitored, supportive environment. Her symptoms improved substantially, and she is reported feeling safer and more hopeful. This highlights an unintended consequence of restricting access. When supervised care is limited, patients will turn to less regulated alternatives, and this is not safer care. As an APRN, I am filling a gap in an underserved community. If this rule passes as is, with the restriction of having a physician on site, my clinic will have to close, reducing access and increasing the risk for my vulnerable patients. Patient safety includes access to care. Removing this access for patients in crisis may unintentionally put their life at risk.
Thank you,
I
Ms. Watt.
respectfully urge the board to consider the unintended consequence of this rule and preserve safe supervised ketamine treatment. Thank you for your time.
Reese Ormond.
Good afternoon, Dr. Zaffron. Thank you all for having me, allowing me to speak. My name is Reese Orman, and I'm the CEO of NeuroGlow, a ketamine therapy provider serving patients across North Texas. Since 2021, we've treated over 1,000 patients and administered more than 5,000 infusions with no major safety issues. Our model includes comprehensive medical evaluations, psychiatric intake, preparation, and integrative therapy. I'm here today because I'm deeply concerned that the proposed regulations, as written, will significantly reduce access to care for patients who need it most. These are individuals battling treatment-resistant depression who have often exhausted every other option available to them. In our clinics, we regularly meet people at their lowest point. I've personally had patients tell us that they were close to taking their own life before starting treatment. Others have reached out afterwards to share that this care helped them reclaim their lives. These are real people, real families, and real second chances. We also serve a significant number of veterans. As you know, veteran suicide remains a critical issue in this country, with estimates ranging from roughly 17 to 22 lives lost per day. Many of these individuals are navigating complex trauma and have not found relief through traditional treatments. At NeuroGlow, we track our outcomes closely. We've seen meaningful improvement in approximately 82% of our IV ketamine patients, while maintaining a strong safety record through structured protocols and clinical oversight. I also want to address a key operational concern within the proposed regulations, specifically the requirement for a physician to be physically on site during treatment. All three of our clinics are located in rapidly growing areas of North Texas within the Dallas-Fort Worth Metroplex, one of the fastest growing regions in the country with a population of over 8 million people. And yet, despite that population density, each of our clinics falls within a federally designated health professional shortage area. Even in one of the most populated regions in Texas, it is difficult to recruit and retain physicians for specialized roles like this. So the question becomes, if this requirement is difficult to meet in a major metro area, what does this mean for clinics serving rural communities across Texas? For those providers, this will not be a challenge. It will be a barrier that is nearly impossible to overcome. And the result is predictable: fewer clinics, reduced access, and more patients left without care. I urge the board to reconsider and not advance these regulations as written, because the decision comes down to a simple question: are we increasing safety, or are we reducing access to life-saving care? For many of our patients, there are no other options left, and when access disappears, so does the chance to recover. For some, that difference is between life and loss of life. If the board does choose to move forward, I strongly urge you to allow for a 12-month implementation period. These are substantial operational changes that require time to execute responsibly while ensuring continuity of care for patients who depend on us today. Thank you.
Thank you. Leah Lothrop, and I hope I'm pronouncing these right.
Hi guys, my name is Leah Lothrop. Thank you so much for allowing us to be here today and for allowing me to speak on behalf of our team and our patients. I am a psychiatric mental health nurse practitioner currently working with NeuroGlow in North Texas. I am the nurse practitioner who does the initial evaluations in collaboration with my supervising provider, Dr. Aaron Brown. We meet with patients to ensure appropriateness of treatment. Sorry, guys. 1, 2, 4. To ensure appropriateness of treatment, and that we're meeting clinical standards for these patients. Oftentimes, our patients come to us after they have exhausted many other treatment plans and modalities. Unfortunately, as you guys know, in the setting of treatment-resistant depression, there's not a lot of options. This option for our patients is one that helps improve their lives dramatically. In my role, I am responsible for determining whether a patient is appropriate for treatment with collaboration from my supervising provider. In ensuring appropriateness for treatment, it includes a comprehensive psychiatric assessment, a medical screening, reviewing their prior treatment history, and ongoing monitoring with me throughout their care. The patients I see are not new to the mental health system, and many of them have been struggling for years. As mentioned, they've tried multiple medications or modalities without much, if any, meaningful relief. They come to us oftentimes as a last resort. These evaluations are not quick, they're not casual, they're extensive, and they're ongoing. They're structured, they're deliberate, and they're focused on patient safety. We are identifying risk, ensuring appropriateness of treatment, and building a plan of care that includes both medical oversight and therapeutic support. What I see consistently in our clinic is this. When patients are carefully screened and properly supported, their outcomes improve. They return to a reasonable quality of life, and they're able to verbalize that they are finding their joy again. We see patients stabilize, we see reduction in depressive symptoms, and we see people regain hope and re-engage in their lives. That's why I'm specifically concerned about these proposed regulations. Throughout this meeting, I've heard people talk about safety. Limiting access to care for these patients is a safety concern. These patients have worsening depressive symptoms and increased suicidality when we limit their access to care.
Sorry, your time is up. Thank you. Logan Davidson.
Thank you. Good afternoon, Dr. Zafran and members of the board. My name is Logan Davidson. I'm a senior advisor to Texans for Greater Mental Health and a former executive director of the organization. We are a nonprofit dedicated to advancing evidence-based mental health treatments and strengthening access to care for all Texans. We are here today as constructive partners, not as opponents, and our message is simple. Before the board acts, we want to ask, have we gotten it right? The people most affected by what happens in this meeting are patients, people living with treatment-resistant depression and PTSD, who have tried every medication on the formulary and found no relief, people who have been suicidal and found for the first time something that worked, veterans who came home carrying invisible wounds and who described ketamine therapy as the first thing that gave them their lives back. Clinical evidence support what these patients report. Studies show remission rate of up to 70% in patients who don't respond to traditional antidepressants. Ketamine is the only antidepressant FDA studied specifically for patients experiencing acute suicidal ideation, and it works, often within hours when weeks of waiting is not an option. More than 95% of Texas counties are federally designated mental health professional shortage areas. For the 13 million Texans living in those communities, access to this kind of care can be life or death. Regulations that create requirements clinics cannot meet, however well-intentioned, result in clinics closing. When clinics close, patients do not find another provider. In most of Texas, there isn't one. For someone managing suicidal ideation, an abrupt disruption in care is not an inconvenience. It can be a crisis. Texas wields real influence in national health policy. What this board decides will set a precedent other states will follow. That responsibility demands a deliberate, thoughtful approach, one that is confident it has balanced safety, access, and quality of care in equal measure. We are not here to oppose these rules. We are asking whether we fully work through access implications, particularly for patients in shortage areas, and whether the patient voice has been adequately heard. If this board is confident these rules are right, we have one request: provide a meaningful implementation window at minimum 90 to 180 days so that clinics serving patients today can come into compliance without shutting their doors. These rules require new registrations, staffing models, and equipment standards. A reasonable transition protects the patients who are in treatment right now. G4GMH will remain a partner in this work. We believe Texas can be a national model for how to regulate emerging mental health therapies responsibly and compassionately. We owe that to every patient who walked into a ketamine clinic because every other door had been closed to them. Thank you so much for the time.
Thank you. Jack Swain. I think you're muted still.
Oh, I see. I had my screen on a different page. Okay. Good morning. I'm Jack Swain, Vice President of Government Partnerships at MindBloom, one of the largest providers of ketamine therapy in the United States. I appreciate the opportunity to speak to the board today about the importance of maintaining access to at-home, subcutaneously delivered ketamine for patients who haven't responded to conventional treatments. This includes over 300 Texas patients currently receiving at-home subcutaneous ketamine therapy with MindBloom. Since 2019, we've provided over 700,000 at-home treatments, and we published the largest peer-reviewed study of ketamine therapy to date with real-world outcomes across over 11,000 patients. We have a study of subcutaneous administration currently under peer review that reports safety and effectiveness across nearly 4,000 patients. Our clinicians exclusively prescribed sublingual tablets for our first 4 years before developing a subcutaneous protocol in response to patient issues with tablet tolerability and absorption. This protocol was developed through an 11-month, 3-phase pilot overseen by a medical review board of independent psychiatrists, including the chair and vice chair of psychiatry at Houston Methodist. The chair, Dr. Ben Weinstein, also submitted a comment to this board in support of maintaining access to at-home subcutaneous treatment. Today, subcutaneous administration is the preferred route across our 40 clinicians because of its precise and reliable dosing. Our clinical study of subcutaneous treatment shows a strong safety profile and a rare incidence of issues with at-home injections. Over 80% of patients achieved clinically meaningful symptom improvement across depression, anxiety, and PTSD. The veteran community presents one of the greatest needs for expanded access to at-home treatment, given their disproportionately rural residents and high rates of depression, PTSD, and anxiety. MindBloom has treated thousands of veterans, including hundreds here in Texas, whose response rates exceed those of standard care. We plan to publish a study on veteran safety and effectiveness this June. I'm engaged in discussions with clinicians and researchers at the VA about using telemedicine to expand access to treatment. VA ketamine clinics report that travel is their patients' single biggest barrier to treatment, and one VA clinic shared that a third of their patients travel over 100 miles for care. Last year, we partnered with the Special Forces Foundation to provide at-home subcutaneous ketamine therapy for Green Beret veterans. I'd like to share a testimonial from their CEO, Mark Mallory. Quote, "Our partnership with MindBloom has delivered outcomes we rarely see at this speed and magnitude. Veterans are reporting symptom relief, improved daily functioning, better quality of life, and in some cases, a complete absence of suicidal thoughts since starting treatment. MindBloom's at-home delivery is resonating with a population that is often difficult to reach." End quote. In closing, we support regulation to promote safe treatment, but we ask this board to pursue targeted standards that ensure access to care for those who need it most. Thank you.
Great, thank you. I actually had a quick question for you because I was looking a little bit at your website. Just wanted to kind of get a little bit of an understanding of your process. Are you guys able to protect the HIPAA information of patients who input information onto your website when they do the intake?
We comply with state privacy standards. I would need to consult with our legal or technical team.
Okay, I just said when I was reading through it, I read a little bit about the fact that some of the information, well, actually a lot of the information on the patients is actually sold to third-party advertisers, and there's a very specific comment in there is that HIPAA as an IT company, as you classify yourself, are actually not applied in that instance to the patients, or that when they consent to it, I guess, within the framework of when they do the intake, but that there is information that is given actually to third-party entities not involved in their care, and that HIPAA doesn't apply because of the way you're structured. I just was wondering if you're aware of that, or,
We don't sell any patient data, but I would need to consult with our legal and engineering teams to understand specifics. But we don't sell patient data to third parties.
Okay, you just might want to look at your website and the information on there, because it does talk about HIPAA, typically HIPAA protected information for patients being given to other third parties without HIPAA applying to the non-physician component of your corporate structure. So I thought that was very interesting. Wanted to maybe hear a little bit more about that. So if you have a little bit more information on that, maybe you can get back to us and help us understand that part.
Sure.
All right, great. Dr. John Scott.
I have a quick question. Let me jump ahead here. Can I jump in?
Real quick.
Yeah. One question for Mr. Swain. Are your physicians checking the prescription monitoring program against what the patients are taking from pharmacies?
Yes, absolutely. Before writing every prescription.
They're not just reporting the prescription of ketamine to the PMP, but they're in fact cross-checking it to make sure that there are no other prescriptions that are controlled?
That's correct.
Okay, thank you.
All right, thank you. Dr. John Scott.
Good afternoon, Dr. Zaffron, Mr. President. I appreciate the opportunity to speak today. Distinguished members of the board. For all you that do not know, I'm a board certified anesthesiologist, also board certified in fellowship training in chronic pain. I want to start by saying thank you for putting this board and panel together and coming up with these regulations. At the outset, I want to say that I accept these rules and would like for these to be as adopted. Being an anesthesiologist, we all know that ketamine is a very dangerous drug. If pushed to the limits, it can cause respiratory depression. And if you don't have a physician available, have a difficult airway situations, that patient has to be intubated. So these concerns are all very much so with all of us. And so my number one concern is patient safety. And I understand, I do appreciate all the other people that have spoken for, but I cannot say that we have to have somebody that has a airway experience, and that being a physician that can take care of these complications that occur. As you know, there are no Narcans available for ketamine. It has to be worn off. And I can't speak any higher that for anyone that has ever used home ketamine, that there has been deaths occurred with this. This is a very difficult topic, and I really appreciate the opportunity to speak today as a member of the American Society of Anesthesiologists, and also as a member of a physician in Dallas-Fort Worth area, that we all have concerns about patient safety. We have to take care of patient safety in the airway, and that's a big concern. Thank you for the opportunity to speak today, and I appreciate if you have any questions. Thank you. And also a shout out to Mr. Michael Kokonos. I'm from Beaumont, and so is he. Thank you.
Thank you. Kelly Light.
Yes, thank you. Good afternoon. My name's Kelly, and I'm a registered nurse at Transcend, where I administer ketamine infusions and oversee the financial operations of our clinic. I'd like to speak briefly about risk and patient safety. We all share the goal of minimizing harm, but it's important to consider risk in full context. Major depressive disorder carries a lifetime suicide risk estimated around 15%. The patients we treat are often those who have failed multiple prior treatments, and they're among the highest risk individuals we see in healthcare. When evaluating these proposed rules, I would ask the board to weigh not only the potential risk of rare adverse events in a monitored clinical setting, but also the very real and well-documented risk of untreated or undertreated depression. Based on the available evidence, there's not clear data demonstrating a level of risk, particularly when ketamine is administered at doses under 1 milligram per kilogram over 30 to 45 minutes, that would justify significantly more restrictive requirements, such as mandated physician on site. In our clinic, care is delivered by a registered nurse with continuous monitoring with a physician available remotely at all times. And in over 6 years, we've not had a single event requiring a physician to be physically present. As Dr. Cunningham stated earlier, our patients remain conversant during the entirety of the infusion. If these rules result in clinic closures or make care more unaffordable, the likely outcome is not increased safety. It's that high-risk individuals lose access to one of the few treatments that may help them, or turn to less safe, unmonitored in-home care. In healthcare, we do not eliminate treatments because risk exists. We manage risk thoughtfully while preserving access to care. And while you point out that this is only for injectable ketamine, IV ketamine has been shown to be the most efficacious route for mental health disorders. Thank you for your time.
Thank you. Sandra Furlong.
Hi. You've heard from clinic operators and anesthesiologists. I'm a patient, so I'd like to say something, which is that I was diagnosed 30 years ago with major depressive disorder, and struggled with depression for years before that. I tried more than a dozen medications, 2 of which actually made it worse and caused incidents of suicidal ideation. I have been in ketamine therapy for about 3 years now, and it has been completely transformative. I can say without exaggeration that it is the reason why I'm standing here today. As a layperson, there is a question that I have that I haven't seen addressed quite in this way, which is why do these rules, and I can't stress enough how terrible it would be for me to lose access to my ketamine therapy. And I am wondering why these rules require a physician physically on site for ketamine administered for psychiatric indications, but not for the same drug at sub-anesthetic doses administered in pain clinics. And I guess I want to say plainly what clinic operators may be too diplomatically positioned to say. When the same drug at the same doses through the same delivery method is regulated one way for psychiatric patients and another way entirely for pain patients, that is not a safety framework. That's a policy choice. And this board should be prepared to explain it publicly, I think. Also, the published rulemaking record contains no evidence of a systematic pattern of serious patient safety incidents at independent outpatient ketamine clinics in Texas justifying this level of intervention. I agree with the idea of people giving themselves intramuscular injections at home sounds really dangerous to me, and I've never heard of that until the anesthesiologists today have spoken of it. And so I don't object to that, but I think it would be really terrible for many people like me, veterans, EMT techs who have terrible PTSD problems, to lose access to this well-researched and proven transformative therapy. So thank you for your time.
Thank you. And appreciate you as a patient being here to testify. Let me just emphasize that there is no intent here to decrease or minimize access to care. I think what the board's intent is, and that's part of our mission, is to make sure that we are maintaining safe access to care. So that's obviously a very deliberate thing. There's many different ways that care can be delivered. Our job is not to wait until there are sentinel events. We're trying to look at the data. We're trying to look at the research. We're trying to look at the what the FDA has said about these drugs. There have been incidents where ketamine has been used where people have died. There have been instances where anesthetic agents, whether they're ketamine or propofol or whatever, has been used where patients have died, even with the presence of a physician. I think the most famous example is Michael Jackson. They were talking about sub-anesthetic doses of propofol. Again, when we go back and we talk about safety, we're talking about really reversibility when you get to an instance where, where you cross a threshold that you can't reverse yourself from. But again, I just want to make sure that I emphasize as loud as I can that this is not about restricting access. This is making sure that we provide access in a safe manner. So that's of course part of the conversation today. That's part of the deliberation that we're going to have. Obviously, we're hearing input from everybody, and we're going to discuss this as a board, and kind of go from there. So.
Okay, I would appreciate it then if you would consider adjusting the rules as they are proposed at this time, because it would inadvertently create harm.
Okay, thank you.
Mm-hmm.
Dr. Jeremy Perry.
Good afternoon, members of the board. Thank you for the opportunity to give testimony this morning or this afternoon. I'm a board certified anesthesiologist and utilize ketamine. Can you hear me?
Yes, we can hear you.
Okay. And utilize ketamine regularly over my 20 years of practice. I'm here on behalf of the Texas Medical Association to support rules that ensure access to safe ketamine therapy for Texans. This discussion has been framed as a question of access, but the real question is, what kind of access are we providing? There is a critical difference between access to safe medically supervised care and access to unsupervised administration of an addictive, potentially lethal anesthetic. Only one of these protects patients. It is important to be precise about what these rules do. These rules address parenteral ketamine. They do not prohibit telehealth providers from prescribing oral or intranasal ketamine for at-home use. So claims that these rules will eliminate access for thousands of patients are not accurate. These rules ensure that higher risk injectable ketamine is delivered in an appropriate medical setting. The patients receiving ketamine therapy are among the most vulnerable in our system. They are being treated for treatment-resistant depression, PTSD, and suicidal ideation. These patients require clinical judgment, monitoring, and continuity of care. They need clinicians involved in their care. They don't need a model where a powerful anesthetic is prescribed remotely and used at home with minimal oversight. Ketamine is not benign. It carries risks of airway compromise, hypoventilation, cardiovascular instability, and severe dissociative reactions. Unlike opioid overdoses, there is no Narcan for ketamine. If a patient loses their airway or stops breathing, there is no reversal agent. In the absence of a trained clinician in a monitored, supervised setting, the patient will die. There is no clinical justification to lower that standard here. Evidence that parenteral psychotropic ketamine models are safe come from supervised clinical settings. Unsupervised at-home use is fundamentally different, and we have already seen real-world consequences. A recent wrongful death lawsuit describes a patient prescribed ketamine through a telehealth platform, sent home with the drug, and later found dead from ketamine toxicity. Recent reporting in the Wall Street Journal describes a case where a patient, while under the influence of ketamine obtained through telehealth prescribing, killed herself and her children. These events reflect impaired judgment, dissociation, and the absence of medical oversight at critical moments. These are not theoretical risks. They are predictable when oversight is removed. Expanding access to unsafe care does not improve access. It creates a system where unsupervised models undercut safe practices. And over time, safe care is displaced by dangerous alternatives. Texas has a clear standard. If an injectable anesthetic can impair airway reflexes, it must be administered in a setting capable of managing the airway. These rules do not eliminate access. They ensure that access is safe and clinically appropriate. In closing, these patients are vulnerable. They deserve safe care, not profit-driven distribution of addictive, potentially lethal drugs. These rules have been extensively discussed between the Texas Society of Anesthesiologists and the American Society of Ketamine Physicians, Psychotherapists, and Practitioners, as described by Dr. Prashad earlier. Both organizations are aligned.
Dr. Perry, I'm going to have to cut you off. Yeah, now there's only one other person that's testifying. If you want to come back and retestify or recomplete, I'll let you do that.
Yeah, that was good. I'm available for questions. Thank you.
Great. Thank you. Joe Steiner. Ms. Hemphill, are you going to testify about ketamine, or are you still waiting to have general public comment?
I need both, please. I have one on ketamine, and then I've got comments about what's happening on the new website.
Okay. I'll only let you testify about ketamine, not about the website right now.
Why? It's two different items.
Because we're not testifying, we're only testifying on the ketamine rule at the moment. We're still in discussion and deliberation on that.
That's number 18 and 22 is on the list too.
Ma'am, we're specifically just on the ketamine rule at the moment. We have not finalized that agenda item.
That's fine, but can I come back at 22?
Yes, ma'am, you can.
Thank you. I appreciate it. And let me turn on my camera. I realize I have control of that. Okay. Thank you, President Zafran. It's been a while since I've been here. On the ketamine issue, I personally was diagnosed manic depressive 35 years ago. I was sent home with all of the psychiatric treatment to help heal me that made me homicidal and suicidal. I identify so closely with the woman who just testified, but because of my passionate work on mental health, predominantly since 2018, I've been pleading with legislators to require the evaluation of physical root causes manifesting as psychiatric dysfunction. So when I listen to these people talk about how many people have failed conventional therapy for depression, I'm like, were they tested for toxoplasmosis, cat lady? Were they tested for Lyme disease? Were they tested for autoimmune encephalitis? Were they tested for allergies? All of which can create brain inflammation that exhibits as depression. I could have been that woman, but I have been off all medications since 1994, when I got off to be able to have my second child that I was diagnosed never to be able to have because of the drugs. The biggest question is, why are our treatments failing so poorly that they're finally getting to these clinics? And now, depending on how these rules are established, I've seen this. I've been doing this for 13 years, being at many mental health hearings. And I hear the same thing, which I think I'm kind of hearing is turf protection. It sounds like to me, from what I have listened to today during these testimonies, that there are clinics that have success rates. I don't know how, I guess I'll do an open records request to find out how many complaints come in from patients. And we all want safe procedures, but we do not want to limit access, it's been discussed, to patients that have no capacity to get the treatment that's been successful and given them back their lives. This also happened after 2016, when the medical board started locking down on the distribution of opioids for pain. And I'm very intrigued that the psychiatric delivery of ketamine would be different than pain. So I hadn't even really dug into this one. I've been over in the CBD and hemp and opioids in that arena, but predominantly distraught because we're not looking for physical root causes. The breakdown of medicine that takes conventional physicians to have to produce their scans or their labs to substantiate their diagnosis, to do the procedures, to bill. If it's mental behavior, they're shipped over to psychiatry, and it's predominantly abused in our children. So I hope that we can bring a lot of these and get good rules to service the need that's there and provide the safety necessary. Thank you, board.
Right. Thank you, Ms. Hemphill. Joe Steiner.
Good morning, everybody. I appreciate the opportunity to speak on this. I also am a patient. Several years ago, I was diagnosed with a condition called trigeminal neuralgia. The medical community has a really cute name for it. They call it the suicide disease, because many people that are diagnosed with this end up taking their own lives because of the intractable nature of the pain. 1 year ago, I was at that point. I live in Oklahoma. I searched the entire state. I called every number I could get a hold of and could not find anybody. My primary care told me about ketamine, but we could not find anywhere in the state to get it. I expanded my search and I found clinics in Texas. So every 6 weeks, 4 to 6 weeks, I drive 500 miles round trip, get a hotel, Uber rides back and forth. You know, the whole thing is a massive expense. It takes 2 days out of my life. Without that, I would be dead. I cannot stress that enough. Without the relief that came from my ketamine therapy and the ability to go to a clinic, have medical professionals overwatch that whole thing, absolutely saved my life. It's my belief that if you restrict it, people either A, will find it on the internet or find it, at home and be more at risk, or they won't get it at all. And their life will continue to deteriorate to the point of suicide. I tell people I'm not a drug person, but I champion ketamine to anybody that I meet that seems like they're struggling. I cannot express deeply enough my belief that if you restrict it, make it harder. I mean, I already have to jump through multiple hoops. I had to, re-download apps and do all, multiple things just to be on this call today. But it's that important to me to express to the people that can make decisions about this. If it had been just a little bit harder, I would have given up everything. So I'm grateful for the framework that already exists in Texas. My plea is please keep it available to people. Thank you for your time.
Thank you. And again, I really appreciate you as a patient coming and testifying. It sounds like you already, travel to get access to the medication. And I don't think there's anything in the rules that we're doing that would eliminate the ability for you to access this medication in the proposed appropriate setting that is on here. So I hope that you continue being able to get the treatment that you need so that you can not be in constant and persistent pain. Rich Seldine.
Yes, can you hear me?
Yes, we can.
Hello? Okay. Thank you for letting me speak on behalf of the board this morning. My name is Richard Seldine. I work for MindBloom, and I see patients as a nurse practitioner in Texas. I assess for depression, anxiety, and PTSD. And I've been working with the company for 2 years, and we offer sub-Q ketamine right now at home. And we have a very safe protocol in place where we have patients that are supervised while doing ketamine. We have a dosing protocol, and I've had a lot of success with clients in this program, both with the oral administration and sub-Q. And my concern, and along with my colleagues in the company, is that people are coming to us for ketamine, sub-Q ketamine and oral ketamine, and there's concern that this is the option for the sub-Q ketamine is taken away from these clients. They're not going to be able to afford to go to a clinic. And just speaking of adverse reactions, I've not had any with my clients other than anxiety and nausea and anxiety at points in time with their treatment. So I would hope that the board, specifically looks at what we do, how we do it before a decision is made that will impact clients that are not going to be able to go to clinics because of affordability. So that's my concern. I do the assessments as a nurse practitioner, and I vet these people. I just don't hand out ketamine to clients. I make sure they're appropriate, they have a condition that can be treated. I've had a lot of success, especially clients with suicidal ideation. So what I would hope, this is a very narrow scope because we do provide sub-Q ketamine. What I hope the board will consider is how we administer this and how we have safety protocols set in place and what our success rate is. Because I know for a fact, I do this every day and I'm talking to clients, they're concerned that if this is taken away from them, they're not going to be able to afford to go to a clinic to pay, for services. So that's my concern. And I appreciate you listening to what those are.
Thank you. Just a quick question. You talked about affordability. What is the current cost of going through this process right now for a patient?
It's on the website, but 6 sessions are about $1,270. And then I don't have the exact number right here, but it goes up from there. There's 12 sessions and 18 sessions. The more sessions you do, and most clients do anywhere between 6 and 24, depending on how they feel and their response to it. But $1,270 is the cost for 6 sessions.
Okay, and insurance doesn't pay for this, correct?
From what I know, no, but they do have flex. I know that they take flex spending for this.
No, I understand. That's a little bit different. Why doesn't insurance pay for this? It's such a, I mean, I'm hearing that it's such a life-changing event that, you know, it sounds like it's the standard of care out there. I'm just kind of curious as to why insurance doesn't pay for this.
I would say because it's being used off-label. That's my
But
thought.
if there's so much research, I mean, again, I've been hearing for the last 2 hours, there's so much research and peer-reviewed studies on it and so forth. So I would have presumed that by now the FDA, instead of black labeling it, would have approved it.
Okay, that's a good point. But I mean, I'm just seeing the response and how we do our program and the results we're getting. So that's all I can speak to. And, you know, I'm dealing with clients every day and I see the results, and that's what I'm focused on.
No, and I appreciate that. And that input is very important. I'm just, you know, trying to understand why, if there's so much data out there and so much positive impact, that this should be the standard of care and it should be compensated and it should be covered. I actually happen to sit on the Anesthesia and Analgesia Drug Product Advisory Committee, and this hasn't even come up as a form of modality. And, you know, I'm not questioning at all whatsoever the ability to use it off label at all, so long as there's proper consent for it. I'm just kind of having a little bit of a hard time understanding, if this is such a strong impact, why it's not approved. And this is just an open question. I don't know the answer. Why it's not approved and why insurance isn't paying for it. So anyway, on to the next one. Dr. Rebello. Dr.
Can you
Rebello,
all
are you
hear
on?
me? Yes.
Yes, I can
Can you
hear
all
you.
hear me? Okay.
Yes, we can hear you.
My camera's not working properly on my computer, so I'll do this orally. So good afternoon. Thank you for the opportunity to testify. My name is Elizabeth Rebello, and I'm a board-certified anesthesiologist, a professor of anesthesiology, and also trained as a pharmacist with over 30 years of experience both administering and dispensing ketamine. I also serve as the president of the Texas Society of Anesthesiologists. I'm speaking in support of the Texas Medical Board's proposed rule on injectable ketamine administration. I strongly support requiring injectable ketamine to be administered in a clinical setting with appropriate monitoring and with a physician physically present. These rules address injectable ketamine. Injectable ketamine has a safety profile that requires monitoring because of potential life-threatening effects such as cardiac arrest, airway compromise, and dissociative reactions, which we cannot take care of if we are not present on site. Unlike opioids, in which there's a reversal agent naloxone, there is no reversal agent in the event of a ketamine overdose. I also strongly oppose injectable ketamine models where patients self-administer medications shipped directly to them. From both a pharmacological and anesthetic perspective, this raises serious safety and ethical concerns, as both injectable IV and subcutaneous ketamine absorption can be not predictable. In hospitals, ketamine is tightly controlled with strict accountability. That standard should not change simply because care is delivered outside traditional settings. I'm very sympathetic to the patient seeking relief, but safety must come first. The core tenet at the heart of my and my colleagues' practice is patient safety. Patient safety is especially important regarding a drug such as ketamine. The Texas Medical Board's proposed rules appropriately balance access with patient protection And I want to thank the board for their work on these rules. Thank you.
Thank you, Dr. Rubello. Our last one, I don't want to purport to mess up the last name, but it's Mr. Dean Hospital. Is that?
It's L'Hospital. You got it.
Okay.
Don't worry. I wouldn't expect anyone to get that right the first time or subsequently. I work for Mindbloom. I had held off on speaking. I'm an attorney, and generally I think we need to hear less from attorneys. But I did want to jump in and say some things that I hadn't heard anyone else say yet, especially the patient voices. I attended earlier sessions where I heard about a provider shortage, on the horizon, and I wanted to flag that I think that this rule would have an inescapable effect on the amount of people who are providing this care. Unless you're going to replace every NP and every at-home provider with a physician who's in person, then it necessarily is going to reduce the amount of providers that are providing the service at a time when it seems like we're looking how to get more people providing these services. I heard about access as well and accessibility, and I wanted to give multiple dimensions of that. And there's been talk that this is not anti-access, and it's about safe access, and I agree with that. But of course, there's a continuum here, and there's been a lot of sort of black and white thinking on this. Mindbloom also supports safe access. We have a full protocol from end to end that touches every aspect you could possibly want to see in a protocol: anti-diversion, titration, everything. I'm not a physician, I'm not a provider, so I'm not going to get into that in detail. But we obviously also believe in safe access. I want to point out that a vast majority of Texas is in Texas counties or in mental health shortage areas. So it's not just about people that are sort of generally far away from an in-person clinic, but also mental health services in particular. And how much of an issue cost is with accessibility. It's a lot to have to drive 100 miles to a clinic. Frankly, it's a lot to have to drive 20 miles to a clinic, especially if gas is $4 a gallon. So this is a real cost that you can't ignore. And the final point I want to make, and I'm sure there'll be questions, the final point I wanted to make was, that there's been some talk about sort of isolated incidents. We talked about, Matthew Perry, I heard about Michael Jackson, and these are, newspaper headlines. And if that's meant to sort of trigger a safety concern, I just don't think that's a good way to make policy. We have data. We have a subcutaneous study with almost 4,000 patients, and we had an SAE rate of less than 0.01%. That's data. And, I expected that the board, when they're making something that will necessarily restrict people's access, that will necessarily drive up the cost and will restrict providers, that's fine if you balance that against the data on the other side, which I just didn't see here. I would expect you to look at studies. I would expect you to be able to promise patients that it's not going to cost them their medication, that it's not going to make it unavailable, and that there's not going to be a knock-on effect. Because I can tell you, with 22 veterans dying of suicide per day, and the number of other people dying of suicide every day, and just the quality of life,
So you're at time.
Will die.
You're at time. You're at time, but I want to ask you a quick question that I asked before. And again, I hear this about data. Data is data. There's peer-reviewed data. There's non-peer-reviewed data. There's data that can look at, regardless, I'm just trying to understand why the FDA has not approved this today, as of yet, as a therapy that is not off-label, if there's so much data out there.
Well, I imagine because it's just an off-label, generic drug now.
But
nobody wants to pay $100 million. Nobody wants to pay $100 million.
I'll let you finish.
To get
but
FDA
everything
approval.
starts off as off-label until there's enough data to justify it being something on-label. So again, I keep on hearing about all this data, and I'm trying to understand still, until now, why haven't we moved from something that is off-label to on-label? So if there's so much data out there, I mean, that's the golden rule for access, is that it becomes on-label, that you have insurance. Talking about from a patient safety standpoint, to me, has nothing to do with access. That's more about making sure that our patients are alive. If we want access to care, then you would have this as a paid service, and that typically means providing data to our regulatory agencies so that it becomes a covered service that is not off-label. So help me understand why that hasn't happened yet.
Well, I think you probably have more faith in insurance companies and the economics of our healthcare system in the U.S. than I do. I'm a pessimist, but I like to consider myself a realist, and that my pessimism on that is real. It costs well over $100 million for a drug under the old regime to get the sort of data that the FDA was trying to clear it. Now there's an accelerated path, and that's certainly something that I would like to see. But I wouldn't start from a premise of insurance won't pay for it, ergo it must not be helpful, because I think you're going to find a lot of patients out here.
I didn't say that. I didn't say that. We're on the record. I did not say that. I said that we're talking about concerns to access to care because we are putting barriers. I don't consider it barriers. I consider it safety measures. But when we talk about access to care, the biggest access to care that I'm hearing with something that costs $1,800 for 6 sessions, that's a pretty hefty amount, is that it really should be something that
it's $1,200.
Sorry, $1,200. It's still a fair. It's still a significant amount, but that's something that should be covered if it's something that there's a lot of data out there that justifies its cost. We are not talking about inhibiting its access to the medication based on a physician prescribing it off-label. That is completely within their ability to do so. I don't imagine that I can't imagine that insurance is not going to cover something that is FDA approved. And I keep on hearing about tens of thousands of patients benefiting from this. This should be FDA approved 10 years ago. So again, I'm asking this question. You said that you have a lot of data. I'm trying to understand from you specifically why that hasn't happened yet. We are not inhibiting access to care from the standpoint of not allowing this drug to be used. We're talking about specifically a proposal for rules around specific modalities of the drug, IV and IM, in a setting where we're saying it needs to have appropriate safeguards, guardrails, in order to make sure that it's safe for our patients. So that's the only thing I'm asking, as far as why, with all this data out there, has this not become an FDA-approved modality of therapy?
Yeah, can I jump in here?
And as a physician, I'm sure you're aware that I think approximately 40% of mental health psychiatric medications are prescribed off-label. So it's not uncommon at all, and it doesn't have anything to say about the economics or the efficacy of ketamine. It's also about a 10-year process to get something FDA approved. So there's a medication on the market right now that, by virtue of not being having spent $100 million to get this FDA cleared, it's available now. It's saving lives now, and it's not a hypothetical thing in 10 years that we're going to jealously protect as IP and make available to as few people as possible. Okay. And the cost of MindBloom is still cheaper than the cost of the FDA approved products.
Okay, I would question the $100 million figure. Like I said, I've been through the FDA process before as a person who has been looking at it from the advisory committee standpoint. I can guarantee you it's not $100 million. But anyway, let's move on. Georgette Montserrat.
Hi there. My name is Georgette. I am the head of talent at MindBloom. I am also a MindBloom client myself, and my mom is a MindBloom client. I am a born and raised Texan. I grew up in Laredo, Texas, and MindBloom has been absolutely life-changing for me and my family. Growing up, my mother had a lot of mental health issues, so much so that I remember one time her grabbing a knife and threatening to kill herself when I was in elementary school because she was really stressed from a tantrum that I was throwing as a child. That I'm sharing that very personal information to give you context about the kind of mental health issues we experience in our household. I got my mom to look into MindBloom and try it herself as a client, and it has been so life-changing for my family and I. Just to see her, the way she shows up for herself and her kids now, And I completely trust MindBloom to treat clients appropriately in a remote, at-home environment. For context, my younger sister, she also, from this upbringing, had a lot of mental health issues. And unfortunately, she was actually rejected as a MindBloom client because our protocols didn't allow her to start remote treatment. They said that she was too unstable and that she should seek some therapeutic resources first to get her more stabilized before doing at-home treatment. So MindBloom is treating clients at home, but just because somebody is asking for at-home ketamine therapy doesn't mean that they're going to get approved. We have very thorough clinical protocols to make sure that we treat the patients that we know that we can treat safely. Patients like myself and my mother who were good candidates for the at-home treatment, and not start my younger sister who wasn't in a stable enough place to do at-home ketamine therapy. And so this medication has been life-changing for our family. Laredo has so few care providers, it takes about 3 months to get into a psychiatrist's office. And we are 1.5 hours away from San Antonio in case we needed sooner care. But my family, most of my life growing up has been under the poverty line, like a lot of Texans, and like most of Laredo, or a large majority of Laredo, being under the poverty line. And we would not have been able to afford any in-person clinic from a financial perspective, from a time perspective.
Thank you so much. First of all, I appreciate you coming here and speaking to us as a patient. Mental health is something that is obviously very difficult, and I know it's got a lot of stigma attached to it. And your point about psychiatric care being in short supply is well noted. I know the governor has put some funding behind making sure that there's an increased number of psychiatry residency spots to help address that. So that's something that is critical. I'm glad you're able to access a lot of this therapy at home. Obviously, nothing in this rule will stop that. That will be something that, even if this rule is implemented as is, you will still be able to get the home therapy that you've been getting, as it's important for you to be able to get
For
that.
additional context, my mom and I did not respond to the sublingual ketamine, and that's why I share my story. It was only through subcutaneous that we were able to see results.
Yep. No, and you still, from my understanding, you'd still be able to get that. This is talking about IV and IM in those type of clinic settings. So, but thank you so much for coming and speaking with us. And again, I wish you well, both you and your mom. Okay. All right. Is there any additional testimony? Okay, I stand corrected. I believe sub Q is in the definition. Let me just make sure that I confirm that. Okay, so it's IV, sub Q, and subcutaneous, and IM. So IV, subcutaneous, and IM. Okay, sorry. So I stand corrected on that. Okay, any other testimony? All righty. So we are going to go back to our board members. You have before you the proposed rules with the couple of modifications that Mr. Freshour had spoken about in the language in there. There's obviously the written comments that were sent in that you should have in front of you in your files, as well as the testimony that you heard today. I'm going to open this up for deliberations from the board members specifically. And at some point, we'll have to decide on how to proceed on, make a motion on approving it as is, make a motion on making some minor modifications. Remember that the modifications have to be non-substantial in order for it to be considered today. Otherwise, it would have to go back out for public comment again. So anyway, I'm going to open it up for deliberation. Please go ahead and raise your hand as board members if you'd like to make any comment, and I'll go ahead and give it to Scott to also make some comments before we open it up completely.
Yeah, I was just going to say, if you all will go in and hit refresh, we noted that there was a typo in one of the corrections that was made. So we just want you to refresh to look at the most current rule. You will see some yellow highlighting in that. Those are some of the changes that I spoke about earlier today. So just be aware of those, and that's all that means. So it just flags those recommended changes, which is just a slight variation from the rule that you had voted to give to the register. We made a couple of, non-substantive adjustments. It did not change anything. So I just want you to know that's the rule you're going to be working with. Then, as Dr. Zafran said, it's now your discussion. You've heard the comments. We've got the comments. You've heard them. What you heard is what we received in writing. We could break it down a little further, but you hear the overarching concerns that were articulated. Do you want to change the rule? Do you want to, you can ratify it as it is. If there's any changes, my team and I will make an assessment. We can do it right here. What is substantive and non-substantive? The framework is going to be looking at that. If you decide to change anything, is it a logical outgrowth from the rule as it existed? So again, there's quite a bit of flexibility. So if anything is potentially made as a motion to change, Dr. Zafran, that is what the substantive change is. The case law says, is it a logical outgrowth of what was already there? Unless it's something new and entirely different, more likely than not, you will be able to proceed today with the rule. But again, we'll make that judgment call as needed, if needed.
Scott, and just to, because we've heard a lot of really good testimony today. We got a lot of good comments, kind of on both sides of the rule as is, and those that have some concerns with it. But not trying to just too much oversimplify it. But would your assessment be, after everything we've heard and read, that the main concern is that there's a lot of consensus around the majority of the rule? It's the on-site portion of the physician.
Absolutely. Okay. I think that is. And the only other one that was a bit unusual, and again, Dr. Zafran, this is more for you medically. There's quite a few things about the sub-Q today that we really hadn't heard before. So, but yes, Brent, or Mr. Carlton, the on-site's clearly the issue.
The main concern.
The other thing that I
in-home and in-person.
Yeah, the other thing that I did hear, though, is that for some of them who talked about their concerns with the presence on site, is that if we're going to implement that, to make sure that there is an appropriate amount of time in the implementation side of it. So I wanted you to comment on what that would look like also.
Yeah, we would not put that in the rule, but Mr. Carlton, myself, Mr. Palazzola, we've already started talking about the phase in and how to do that operationally, because obviously if the rule's adopted like this, you can't just drop it today and say we're changing it. So we have a couple of strategies that we are thinking about. And one of the suggestions, and again, we haven't quite worked this out because we don't know where the rule would end up, but one of the suggestions was, let's get people registered and then over a period of time go in and see what they had. But the first step would be to get them registered to know our universe. Once they're registered, have a time frame for phasing in to meet any of the standards. So again, flexible standard. We just hadn't really pinned it down, but that is one of the primary things I thought might work, and I just kind of threw that out there. But again, operationally, we haven't fully decided, but I think we've got a general framework.
Okay, so we're looking for comments. I think Miss Morgan is first.
Yeah, of course, being from West Texas, and of course, Dr. Nato is from Odessa, and being from West Texas right now, a lot of patients have to go to Lubbock for special care. and which is an hour and 45-minute drive or more. So I do have a little bit of concern on the physician on site, just considering the population in West Texas. In addition, in Midland, for example, we have to bribe doctors to move there, offer them $100,000 or more to move there at night, so their spouses won't see the landscape. So there is a big physician shortage in West Texas. The on-site at all times physician concerns me a bit. I just wanted to make that comment.
I guess my comment would be let me turn off my hand. Similar to Ms. Morgan's, I'm from El Paso. We have the similar challenge of recruiting physicians. We're critically underserved. It takes a long time to get in to see a physician. And I think the access to care is really important. And I think from my thought, and this is me just trying to wordsmith, but under 173.9, what is that? F, where it talks about delegating physician must be immediately available on site. I was wondering if, we could entertain the idea of saying immediately available on site or remotely via video conference. And so they could actually see the patient, the nurse that's in the room that's able to do that can show the doctor what's happening. And so it's kind of like doing telemed, but with the nurse in the room with them. So it's maybe a hybrid of the situation where you're still getting that access, but in clinical settings where you can't have a doctor there all the time, the nurse can immediately get a doctor remotely and still get that access to care. And you're able to get the nurse who's got the training in airway management and can call 911 there to manage the patient directly, so that you're still in that situation. I respect what MindBloom does. I think they've probably provided, filled a need and filled a gap in services. But I also recognize the challenge of people doing that in their home. So I like the idea of it in a clinical setting where there's more of a controlled environment. But man, we don't have enough doctors out here. And I sat on the local hospital board for 8 years, and recruiting was an incredible challenge. And so the idea that care isn't available because there won't be doctors there to be able to supervise makes it a really big challenge. And that's one that hits home for me. So I'd love to see a change to add that remotely via video conference in addition to the on-site management.
I have a question regarding that.
Okay. Well, I was going to say, let me go down the list over here. Why don't you go ahead and just raise your hand, and I'll get right to you. Dr. Green?
I think to your point, Ms. Troncoso, I think that like a lot of other telemedicine things don't involve like urgently intubating someone. So I think that was kind of the issue with why it needed to be in person, but I'll let the anesthesiologist also comment on that. Does anyone on the board or staff know the scope of the use of this treatment? Does anyone in the world? Maybe not. Maybe we don't know. Like there's maybe no way to calculate. I know you will know once the places have to register, then you'll have some idea of how many registered places are doing it. But does anybody know like how big of an issue is this? How many people are using this therapy in Texas?
We don't have exact data, Kelly. It's kind of like the med spa thing where it's been proliferating very quickly, hence why there's been an attempt to kind of put some regulatory framework around this. It's kind of been a free-for-all for quite a bit. I mean, we've heard of, kind of like Botox parties at houses. We've heard of ketamine. And I'm kind of looking at the extreme. Obviously, what we've heard today are very structured, very specific types of environment that are out there, but it's been proliferating quite a bit. And again, there's a very specific, obviously off-label use for it. But also the confounding thing is that it is a cash pay thing, which invites quite a bit of a proliferating business. That does not take away at all from the fact that it provides what sounds like or what feels like a needed service for both psychiatric patients and for chronic pain patients. So anyway, but that's, we know it's proliferating. I can't give you a number. Dr. Tibbles.
Thank you.
Yeah, I want to revisit Ms. Troncoso's point and maybe ask a question, Sharif. I thought that the conversation around APRNs and skills was somewhat compelling. Like I can imagine many physicians on site who are completely incapable of managing an airway. I can imagine many APRNs with tons of experience that would be way better than I would be managing an airway. So, is this a leveling issue or a skill set issue? And is there a way to sort of navigate that without necessarily dictating physician versus more focusing on, reliable skill set? Oh, one other quick point, just because it came up a few times today, and just to give my point of view, I think there's actually really good clinical evidence for this use case. I don't think that FDA approval is a proxy for efficacy. Dexamethasone and croup is not FDA indicated. Gabapentin for neuropathic pain is not an FDA use case. Those are all category 1 evidence standard of care. And so I think that those things are distinct, but there's tons of first line that everyone in this room would agree are standard of care that are not FDA approved for that indication for lots of reasons. So, but I wanted to make that point, but my real question or point of the conversation is around the APRN.
Jason, there is provisions about training and airway management in the rules that apply to all those that are there. That is very specific to all those who are providing care, whether it's the APRN or whether it's the physician on site. So it's not just a random, I'm available and that's it. And I think others on the board can, make a point of noting that ACLS is not sufficient by itself to look at as far as airway management is concerned. If you're having to get to the point of ACLS, you've already kind of went beyond where you'd want to manage the airway before it gets to that point. But again, this is all part of what we're discussing over here. Mr. Crane?
Yes. In running hospitals for 30 years, I've heard many a physician tell me they'd much prefer a paramedic establish the airway. So I haven't heard otherwise, as a matter of fact. As far as telemedicine, how expensive would that be to include that in part of the treatment? Plus, can a patient do without an airway if you get telemedicine on the line? That concerns me as well. Yes, there is a massive shortage of physicians throughout Texas, rural Texas, and I've run a rural hospital in Texas. I can assure you that exists, and you can't hardly recruit a physician to that area. And also this is question of risk. Are we risking a bad outcome with more patients who might commit suicide without the medication than we are with the patients getting the medication and yet having a Michael Jackson experience with it? That's all. Thank you.
I'd be kind of interested to look at the data as to, has the incidence of suicide decreased significantly pre and post proliferation of ketamine clinics? I mean, ketamine clinics have been really proliferating over the last couple of years. I haven't seen the data, but I haven't also seen evidence that there's been a significant decrease all of a sudden of suicides as this has progressed. If there's been like a 20, 30, 40% decrease in suicides all of a sudden with these clinics, that'd be interesting data to look at, and I would hope I'm presuming somebody's looking at that data specifically. It'd be interesting to look at that kind of data. I mean, because that would obviously have an impact. I know that there's a lot that's being said to that, but I haven't actually seen data of pre-ketamine clinics versus post-ketamine clinics and what that incidence looks like. Dr. Jones?
Thank you. Yeah, let me just pick up right where you stopped. I did do my very best to kind of research the topic, look up the studies, including the studies mentioned by the company that was represented today called MindBloom. But my understanding is that intravenous ketamine does a good job at decreasing acute suicidal symptoms, but that there is not good data one way or the other for how it does long term. To your point, and I think there's a lot of anecdotes today that support that it, and patient experiences we have to hear that it does have, a place, and it is a valid treatment option, as an off-label formulation. But hearing from some of my physician colleagues today, and just being, in the operating room working with anesthetic agents day in and day out, I don't think it's reasonable to try and manage an acute airway situation from a distance. And that's precisely why we put that language in there. Telemedicine is not going to tell you that you really got to get under that jaw and lift it up. And, you got to make sure that mask is fogging and all the things that go along with, managing an airway before it goes on to ACLS, as you mentioned. And while I'm sensitive to the lack of physicians in certain areas, with this being kind of a newer form of therapy, and we don't have any long-term data on the effectiveness of ketamine and a decrease in suicide, I'm hesitant to sacrifice safety standards to entertain data that we don't have. Whereas we definitely know that ketamine is an anesthetic agent. Its one FDA approval in IV form is general anesthesia. Doesn't mean you can't use it off-label for exactly what was discussed today. But, the way I see it, it's still an anesthetic agent, and different patients respond differently to different doses, no matter how hard you try. And even folks who, run a good clinic. Another comment I wanted to have is a lot of folks today sound like they run excellent clinics. We have to consider the bad actors in our rules too. And that's something that I want to kind of exemplify here. We have to consider the physicians who want to run 20 of these clinics and not have properly trained people, because it's a cash-paying enterprise. And so, I want to make sure that we try and get the balance right. And without long-term data on ketamine and suicidality, I struggle to sacrifice immediate safety.
Can somebody comment on what exactly is the black label advisory from the FDA on this? Because that's a pretty significant thing that I think we need to make sure that we're aware of.
I've got it right here. So black label, that has to be FDA approved medicine. And so Spravato is the FDA approved version of ketamine. It's an intranasal formulation. And, I'm just going to read it directly so that I'm not trying to mince words. It says, risk for sedation, dissociation, and respiratory depression after administration. Monitor patients for at least 2 hours. And those patients get monitored in a clinic setting with a clinician there and vital signs and stuff.
And this is not what we're even addressing. This is something that,
and that's
is
just for
actually
the
being used at
intranasal,
home.
not for IV.
Yeah, no, I mean, this is something that's being used at home. Before I say anything, I'm going to let everybody talk. Dr. Naidu.
Yes, sir. I think you talked quite a bit about FDA black box warning. It's an anesthetic drug. It is not like gabapentin, and it's a scheduled drug. And we talked about access, but affordability. No, I don't think many people can afford like $2,400. Each session for an IV and facility fees and all that. And we're going to open a gateway for many people like counselors, therapists, LVNs, RNs, and so many people to give this medication under telemedicine, under supervision, but not really physician being there. And I'm sure some people know 10 years ago, we had a cancer doctor from Houston. A lot of patients came and gave their testimonials, many ones. I think you all remember, I think Scott remembers it. And I think we need to be careful to open the gates for this drug. Every street will have a ketamine clinic. every place will have it. It's not that proved to be in chronic cases of depression. And it may be good for the seizures. If a patient comes with a seizure, give it, they can abort the seizure. And that's my point.
Thank you, Dr. Naidu. Mr. Rosal?
My big concern is just a physician on site. There was a lot of talk from fellow board members about areas where there's not enough physicians. I would argue there's not enough physicians in Texas, regardless of where you are. There's waits everywhere. I'm in a major metropolitan area and there's still waits to see physicians. I mean, we talk about physician shortages. This is why other bills to address and support physician shortages. So I'm just concerned. I know patient safety is our #1 priority and what we're doing. So it's necessary to put some guardrails, but is there some flexibility to the on-site of like within a 5-minute distance or something that allows maybe the not as harsh on-site flexibility? I don't know that I'm comfortable with telemedicine, but something where you're within the vicinity of something. And I appreciate Dr.
When we say immediately available or on site actually doesn't define
in person
where that person should be. I mean, I know that it does not mean being physically in the room. You know, I think that there can be an argument made that, you know, you probably need to be in the building, that you probably need to be able to get to the patient if there's an airway management issue within a reasonable amount of time. But it doesn't mean physically being in the room. I don't think anybody thinks that that's the definition.
Is it flexible enough to say your driving distance?
Well, again, so it's been purposely, if you look at CMS definitions of immediately available as it applies to other things, it's purposely not defined. You know, I could be on another floor of a hospital and be able to get to the operating room faster than if I'm on the same floor of a hospital, but on the other end of the hospital. So it leaves it a little bit to judgment. I think driving to the area, there's always the assumption that, you know, you can get into the accident on the way over there. You know, you may be upset. I think being at least in the vicinity of the building or whatever it is that, you know, if you're kind of going down that definition, but I don't think it means, I know it doesn't mean being physically in the room, right there. Yeah.
That's my one concern. Other than that, I think it's important to have guardrails.
It's my turn.
Yes.
Again, thank you. So I want to double down on what Dr. Jones said, which is, you know, we have to think about the lowest common denominator when we're thinking through these things. I'm a safety guy. I don't think this stuff should be given sub-Q at home, completely unsupervised. Like, setting those things aside, I'm focused on the on-site physician. So tell me where my logic falls apart. Presumably a CRNA who you guys trust to manage airways every day would not meet the criteria as on-site as someone that, from a regulatory standpoint, could be on site and meet these criteria. I could go take an airway course, get ACLS certified, and satisfy the rule. You don't want me managing your airway even after a weekend airway course. You would want that CRNA who's done this thousands of times, managing that airway. I also agree that telemedicine in this case is probably more theatrics and optics. Like, trying to manage an airway over some sort of AV connection, to me, feels of little to no value. I'm focused on, does it have to be a physician? Because if not, that broadens the access issue greatly. Like, I'm a safety person. I want a well-trained person on site who can manage an airway. But if we're saying any physician can take the appropriate courses and meet the criteria, I'm not actually sure that that is moving safety forward, necessarily. I'm open to being wrong. I just need someone to tell me why I'm wrong.
So I'll give you a quick answer to that. A CRNA is very capable of managing an airway, but a CRNA also is always providing an anesthetic in the presence of a physician. You know, there's, you know, if they're giving a narcotic, and I think that's per the rules itself, and that's part of the Attorney General's opinion that was given, is that if a narcotic is being given, that has to be, the anesthesia has to be given in the presence of a physician. the physician may, and I think in the rules we talk about the physician having proficiency in airway, but there's also a decision-making tree that you're going down into how to manage that patient that you've lost an airway in. Once you start getting down to the point of losing an airway and giving direction to whoever's there, whether, presumably the CRNA, about managing that airway, managing the hemodynamics around that patient, because when you start losing an airway, your oxygen saturation levels are going down. If you have an obstruction, now you're starting to get into the realm of negative pressure pulmonary edema, which happens with obstruction. There are things that happen with an obstructed airway that go beyond just intubating a patient. It's not just the act of intubating a patient. Obviously they can start becoming bradycardic, hypotensive, or even hypertensive once you start getting into that obstructed airway and lower O2 sats and stuff like that. The concern is, Jason, by the time you lose an airway, you've already gotten to a period of time where the patient is hypercapnic. And, once you start losing O2 saturation levels, your O2 sats, especially if you got oxygen being administered, gives you a certain amount of reserve. So you can stop breathing and your O2 sats are not going to go down for a period of time, usually after you become hypercapnic, which in itself becomes a sedative. So a lot of times we have patients that don't wake up, not because of the anesthetic agent, but because they're so hypercapnic that the hypercapnia itself becomes a sedative in itself, and it becomes a vicious downward cycle. So
okay, I can get on board with this, but if so, then we should mandate that it needs to be an anesthesiologist or an ED physician. Like if we're going to take that hard of a line, that we're going to take, in my opinion.
Well, when we talk
everything
about
you just said, because
when we talk about
by next week, I
CRNAs,
can meet these criteria.
yeah, when we talk about CRNAs giving an anesthetic in the presence of a physician, we don't restrict whether it's an ED physician or an anesthesiologist. There are CRNAs that give an anesthetic, give propofol in the presence of a GI physician. There are CRNAs that give anesthetics in the presence of a psychiatrist when they're doing electroconvulsive therapy, which is also something that is used to treat chronic depression. We don't say that ECT can be done without a physician being present, but the psychiatrist can be doing it with a CRNA or with a CRNA that is being supervised by an anesthesiologist, or like I said initially, where the psychiatrist is the one supervising the CRNA. So what you're discussing there goes above and beyond what we actually find acceptable out there. Right now, the standard is that if you have somebody who is qualified to manage the airway, it has to be done in the presence of a physician, but not because the physician is the one who's necessarily able to manage the airway, but because the physician is dealing with the medical management of that patient in a compromised airway.
Okay, well then maybe that goes back to the telemedicine piece. If it's not the physical on-site management of the airway and it's the cognitive work of managing the medical issue, then maybe
that again kind
telemedicine
of
does
goes
work.
below the standard of what we accept right now in different types of settings. If we're presuming that ketamine is leading a person to be under a general anesthetic, for lack of a better word, in that type of scenario, you have a physician present, not remotely.
Okay, I'm going to ask one more question. I'm going to yield because I could go around this circularly all day. Address to Dr. Jones' lowest common denominator outlier issue. What stops any physician from checking the boxes of ACLS, some sort of airway management, being on site, and being completely incapable of actually being helpful?
You wouldn't be able to pass an airway management course without passing an airway management course. ACLS is very, very different from actually passing an airway management course. An airway management course shows that you have to have proficiency in managing an airway, whether it's a jaw thrust, whether it's putting an oral airway or a nasal airway in, whether it's putting a laryngeal mask airway in, or up to the point of intubation. So having an airway management course proficiency is not just a minor feat.
Then what prevents an APRN from being able to meet that standard?
So let me ask you this, Jason. Why don't we just go ahead and do cardiac caths with just moderate sedation in a cath lab without even a physician present in the room?
The tactic of a hyperbolic question back to me is a good one.
No, but I mean, I'm saying we're talking about lowering a standard that we already have out there. The standard out there is if you're providing moderate sedation or deep sedation, which goes to deep sedation or to general anesthesia, it's done in the presence of a physician. So what you're suggesting is actually lowering the standard. you, if we're going to go to moderate sedation, deep sedation, or general anesthesia, and that standard, as it stands, requires a physician to be present today in any kind of setting, how are we lowering that standard? I think the discussion is we're only providing anxiolysis, and in anxiolysis, you don't necessarily need to have a physician present. I think what the conversation is that with the specific use of ketamine, that the progression from anxiolysis to moderate, deep, or general anesthesia is something that you can't easily control. That's the difference here. I can easily ask a nurse to give Versed and create anxiolysis or even moderate sedation. But the difference is if I start having an airway issue, my answer can be give Romazacan or Flumazenil and reverse the Versed, reverse the benzodiazepine. And you don't have an issue anymore. The issue with ketamine is that there is no Flumazenil or naloxone that you can use to reverse the process. Your only remedy at that point is to manage the airway. I think that's the difference we're talking about in this type of scenario versus others.
Okay.
Again, I'm not, look, at the end of the day, we may say have a different scenario out there, but I want to make sure that we're absolutely clear that we are potentially changing the standard than what we actually have today, given somebody who goes to moderate, deep, or general anesthesia.
Yeah, last statement, I really will be quiet. One difference is no one is intentionally going in. When you're going into the OR suite, you're intentionally pursuing those things, and we're talking about emergencies of unintended consequence. But points I'll take, and last thing I'll say, I appreciate, Sharif, you and I are friends, and I appreciate that you and I can have this debate publicly, and I think it's, diligent, caring people can have differences of opinion here. And I think the heart of this, everybody on the board really is like, how do we balance the spectrum of risk and access? And in the end, really wanting to figure out what's best for the public here in Texas. So Sharif, I highly respect you and appreciate the time.
Jason, I am one member of the board, and board wants to make modifications and do things differently. I just think that all of us are providing a perspective that's important, but that's why we're having this deliberation. It's important. It's important that we're having this in public, that we're being thoughtful about it, that we're considering everything that was said. And at the end of the day, we could go in a different direction. That's fine. But it is important that we do have all this deliberation and these different perspectives out there. So that's good. That's a good thing. Ms. Barnes.
Yes, sir. Thank you. Just a couple comments, I guess. When we talk about vicinity and how close the doctor is, the physician is to the clinic. But one case that you mentioned earlier, the physician was 120 miles away in that death case, and so there was no way that he or she could be there in time to help that person. So vicinity would really have to be outlined and spelled out very well. I really would like some data on the number of times or the usage of IV ketamine. One of my clinics is considering the nasal delivery system, and I think that's a lot safer from our perspective and from some of the research that we've done. But I like making decisions based on data. And is there really a lot of usage of the IV delivery system? Does anybody know?
That's part of the issues. We don't have very good data on that, Sharon. I mean, it's a good question, but part of the advantage of registering all these facilities is that we would actually be able to collect a lot of this data.
That was said earlier. So I thought I heard Scott or Brent or someone say that we would have a transition period of 6 months, 8 months to allow people to either adjust and recruit. I'm in the Houston area, and it is difficult to recruit providers, even with our critical mass here and medical school now for Fertitas, it's difficult. So having someone on site would be a challenge.
Okay.
Thank you.
Are there any other board members who would like to speak? Okay. Look, obviously there's this is kind of of a problem of something that has been created in the last year or two, because now all of a sudden we have a proliferation of entities out there that are providing this service. And, now the issue is, well, if we all of a sudden put guardrails around it, it feels like we're restricting access when if we had done this 4 or 5 years ago, it wouldn't be restricting access. It would be making sure that the growth of this industry is done in a way that, that we thought might be safe. So this is kind of an issue that we're trying to deal with this retrospectively, and I don't know what the right answer to this is. I do know that there are legitimate concerns, and, even if we try to think of ways to preserve the safety, if we go down that route, I think it's got to be very thoughtful and it's got to be very deliberate about what that looks like. I will just remind you that with med spas, there is no limitation as to how many med spas a medical director could be overseeing, and what that looks like. So if you go down that path, how often does that physician need to actually visit the facility physically and make sure that they're making sure that that the place is safe, and that all the provisions that provide that type of safety measure is adequately there. We talked about end-tidal CO2 being a metric that needed to have a physician make a decision as to whether it was appropriate to use or not. If the physician's not there, who is ultimately making that decision? Are they going to be asked to be made available on every patient to make sure that that decision is made? Or are we going to say that, well, that's too cumbersome also, even if they're asked to be there by telemedicine on every single one of the patients that are there? So, again, I just want to make sure that we're thinking through this in a way that doesn't have unintended consequences, because we are looking at an issue of access, which is important, but at the same time looking at patient safety. Again, I don't know what the answer is. I know that we've spent over 2 hours now talking about this, 2.5 hours. I know that we've spent 3 months collecting comments. I know that we spent several months before that making sure that we had stakeholders sit down and discuss and make sure that we had a deliberative process in discussing this. I find it interesting that a lot of this concern percolated from certain entities in the last 2-3 days, when we had literally probably about 6 months to talk through a lot of this stuff. I don't think that magically everybody appeared out of the woodwork making a concern out of this in the last 2-3 days. So I just find that very interesting. I do know that the legislature looks at deliberating this also, whether it's limiting the home usage or whether it's making more liberal the clinic usage. Right now we are limited within an OBA setting, which we do have standards around, talking about what those standards around an anesthetic drug looks like in this kind of setting. That's why our scope is fairly limited to specifically the OBA setting. That's why we're not talking about home usage. That's why we're not talking about non-IV, non-IM, non-sub-Q usage. I understand we've heard the concerns about, well, intranasal could be dangerous. Well, what if they take a large dose of PO? That's a little bit of outside of our scope right now when it comes to specifically this. So anyway, I put that all out there. Dr. Green, you got your hand up. And I know Dr. Cook, you got your hand up right now, but I'm sorry, we're past the public comments on this right now. So I'm leaving this with deliberation between board members at this moment. So Dr. Green?
Do we, and you guys may have talked about this and I missed it. Do we know what other states have done? Do we know what other states are doing in this regard?
Well, I can tell you that a lot of states are starting to go down the path that we're going down, because this is a problem that has become a problem in the last couple of years with the proliferation of what's going on out there. So the easy answer to your question is yes, they're all kind of going down this path. And yes, a lot of states are looking to us as to what we're doing also. But yeah, it's all kind of happening in real time, Kelly.
I'll build a little bit on that, Dr. Zafran. We had conversations with some of the folks from the Ohio Medical Board about the ketamine rules, and they they may have gotten tired and left, but they were watching the board meeting today for the specific purpose of looking at our ketamine rules and how this was progressing. So yes, and there's quite a few states that are looking at this, as Dr. Zafran said, but we specifically had the folks from Ohio hopefully attending, and hopefully they may be still on. If you're out there, Kimberly, I hope this has helped you a little bit in our discussions on that. So,
I just want to give some perspective also on this. We've talked about the opioid crisis quite a bit, and the concern about making sure that the proliferation of this is done in a thoughtful, safe way. In order to get Robitussin D today, which has pseudoephedrine, I have to show my driver's license. And there has to be a limitation as to how many times I can get it in a month, because pseudoephedrine is taken and is mixed in a home lab and is used to make some forms of let's say, just prohibited agents. We've all heard about Special K. Does everybody know what Special K is? Yeah. So Special K is, ketamine that is used out there where it can be, it is being done in a manner that is inappropriate. I guess that's the easy way to say it. This is not just your typical drug. This is not dexamethasone. This is not a non-steroidal anti-inflammatory drug. This is a drug of abuse. And, frankly speaking, I didn't talk about the home stuff and all that, but I've had some folks tell me that they've gone onto these websites, some of them of websites that may have been here today, and talk about the fact that the intake of this is incredibly easy with very little oversight. And the ease of being able to get access to these drugs without having to actually speak to a physician or speak to a nurse practitioner or speak to anybody is ridiculously easy. And that's in a setting that we're not even controlling yet. We're not even addressing yet. But the ability to get these drugs that we're talking about, drugs of abuse, is not something that is difficult to do. That's today. Any one of you guys can get on one of these websites and go through the intake process all until you get to the point of getting out your credit card and spending $1,500 and asking who you're speaking to, whether it's a nurse practitioner, whether it's a PA, whether it's a physician, and they'll give you that information as soon as you pay your money. So, we talk about access, we talk about all of this. Yeah, access is easy to understand when it's being made easy, but with very little oversight. And I just put that out there because I want to make sure that we're mindful of the scenario that we're dealing with out there, and how it's not going to be easy to go back on whatever we put that's out there. I mean, if we say that we want to restrict it to a certain setting and we find that is even more prohibitive, these are rules that can, I don't want to say easily, that can be changed to open it up. We talked about addressing med spas for many, many years. And in many instances, I was asked, what problem are we trying to solve? This is going to be prohibitive to access to care. People need hydration. People need to be able to get these vitamins. What are we trying to solve? And it took somebody dying before we had Jennifer's Law passed. So we could sit here forever and talk about the fact that what problem are we trying to solve? That's great. But I don't want to come here 2 years later and say, we've had a death, now we need to address it. So again, on a drug of abuse, on a drug of addiction, on a drug that is already a Schedule III because of its abuse nature, on a drug that already has a black box warning on it because of its potential to cause respiratory depression and go down the pathway of obstructing an airway, with patients who are already taking other psychotropic drugs that already may be causing them to have sedative types of potential. Risperidol is an antipsychotic drug. It's an antidepressant. A lot of folks with depression are on risperidol. you add risperidol with another agent on a sub-anesthetic dose, now you can have an airway issue. Is anybody asking about that? I can tell you in the intake that several of my colleagues have gone onto these websites and done these intakes. That was not a question that was asked. That was not a question that was asked. And as Sharon had alluded to, there have been instances on these drugs given at home where bad outcomes have happened. So now we're talking about an IV drug where you're going to get it at 100 milligrams per cc. Somebody may mix it wrong, like what happened in Jennifer's Laws bill, where 15 milliequivalents of potassium was given in 15 minutes, and the patient went into cardiac arrest. They called 911. They did CPR. That patient still died. And a year later, the legislature at that point started putting laws around it. When 2 years beforehand, the question that was asked was, what problem are we trying to prevent? Well, we figured out what the problem was a year later when somebody died. So anyway, that's my rant. You guys are free to propose whatever you want. I'm 1 out of 19. I will go by whatever we pass as a rule. I just want to make sure that we're all made aware of the circumstances around all this. Mr. Kokonos, you got your hand up.
Yes, sir, Dr. Zafran. You know, from what you just said and what you said, Jason, was very helpful to me. There's no animosity in that, but it helped me a lot. So Dr. Zafran's not worried about our feelings, and we don't need to be worried about, because you asked some very good questions. Dr. Zafran, and what you're saying, I mean, Houston is already the opioid capital of Texas, of the world. We don't need to be the ketamine capital of the world either, especially since the cartel will be mixing that stuff up faster than you can imagine and sending it over here. So there seems to me that this is very dangerous, and we need to really consider what we're trying to do. Thank you.
And Dr. Zafran, if I might, kind of just jump in here to be a little, just to be clear, it sounds like to me the issue that y'all seeing where there's a little bit of divergence here, and I'm going to just talk a little bit more about our comments that came in on the rules, because now we kind of see the direction that it appears the board is considering. You're looking at the on-site supervision standard. In our original draft, we said immediately available. You all as a board voted to do the in-person language that you have in front of you now. A great majority of our commenters, as you could tell today, were very, very reflective of the comments we had received. But I think out of just transparency and fairness to everyone, several folks did comment along the lines of what Ms. Morgan, Ms. Troncoso, I think it was Dr. Tibbles, commented on, is there a way to do this, some kind of remote, audio, video, two-way, et cetera. Several commenters said if they were going to do that, and it's funny that y'all said that, and the reason I bring this up is that you hit specifically on a comment. So I think I have to tell you out of my duty, several folks said that exact same thing, but they said if you were going to do that, and I think Dr. Zafran, you alluded to this, and I'm being a little more specific because I had the pleasure of reading all of the 200 comments. Dr. Zafran, I don't think you had that pleasure, but did you get them all? I didn't know if you had time with yesterday's appeals. Well, great. So several folks, and a couple of them were physician commenters, said the very same thing. If there was going to be some kind of a remote with a two-way audio video where there was a physician who was remote, that individual would be required to physically go and see that clinic, again, as Dr. Zafran alluded to, on an interval. Now, they didn't give, some examples were 30, 60, 90 days, and have to physically go and verify that. So there were comments along those lines. I just bring that up because listening to the comments, I think it's only fair to know that there was already some thought in that. But again, I wasn't going to go through all those this morning when we started because didn't know where the board was going to end up. But since that seems to be the focus, I think it's my duty to tell you that that's where some of the commenters were coming from, which implicates, some of the things you're talking about. We do have, the training and that kind of thing in there. The physician would still be the only one ordering it. But even the rule as it's written now allows the administration by your PAs, your APRNs, and that kind of thing. So again, just bringing that focus on that one narrow issue of the on-site, and that's where the commenters kind of hit on what I'm seeing as the board is discussing here. Procedurally, Dr. Zafran, do you want me to cover that, or do you want to talk to your board a little bit more?
Well, I mean, there's a couple of questions that kind of come into that. So if we're talking about two different pathways here, we already have some very specific language about proficiency in airway management.
Yes, we do. Very.
And I think if we're going to go down that path, I think that's going to be a very big part of that. That's number one. Number two, we talked about the decision on how or when we utilize an end-tidal CO2. And, if we're going to say that a physician is the one who's going to make the judgment on whether an end-tidal CO2 is going to be monitored, I'm still going to say that needs to be on every single patient. Now, whether you want to say that's remote or not remote, I still think that needs to be held. Are we going to say that's still an access issue? Again, that's my suggestion. I'm only one individual here, but if we're talking about making a judgment as to how much we monitor an airway, that's a physician judgment. What medications are they on? What's the physical status of that patient? Who's making a determination of what that ASA status is, what their airway looks like, and what those risks are, and how much monitoring you're going to have before you actually proceed on with that level of care.
Right. Well, let me say to that, not being a physician, but knowing you and I have had quite a few discussions on this. If you were to go down that road, one of the things why we've initially said you needed the CO2 end-tidal monitor was with the thought the physician was going to be there, but the consensus statement was, well, if the physician's going to be there, he or she, who's ever there, could decide. So that's why we changed the rule to say if necessary. Now, I think theoretically, when I talked about logical outgrowth, if your board were to say, well, we're going to allow, just change it to immediately available remotely, you can be, but it has to be two-way audio video conference, you have to visit. You could, and again, you would know this as a physician and not just Dr. Zafran, all of the physicians. Do you then say, if you are going to do that, then you're going to then require and change it back to how you started and require a CO2 end monitor there?
Or you could say, if a physician is not present on the facility, then an end-tidal CO2 monitor must be utilized.
And see, again, so this is exactly why I put that out there.
But I mean, again, we're kind of going back to somebody said that was cumbersome, and it's almost like you put a safety mechanism out there, and it's too cumbersome. And we can talk about how many people died in GI labs or stuff like that because end-tidal CO2 monitors weren't used. And again, it can go down different pathways. Zach, you're very quiet.
Pensive.
So look, I mean, I think me and Zach are the only ones in this room who have had to manage an airway, not only in a controlled setting, but also in an uncontrolled setting. And I think the level of anxiety that you see with the two of us is because we've seen where this can go bad and how fast this can go bad. I also understand that there's a lot of board members that are trying to address this access issue. And I think if we're going to balance this out, if we're going to be less rigid in one area, then I think we're going to have to be more rigid in another area. If we're going to say that there's, and again, I'm just putting this out there as a suggestion, but if we're going to say that a physician can be remotely present. And when I say present, that means that, in a moment's notice, I got to be able to switch on a video phone and that person needs, or someone needs to be available. That the only instance where end-tidal CO2 may not necessarily be used is if that physician is not necessarily on site.
Yeah.
Again, I'm just throwing things out there as suggestions. I do think that these facilities need to be physically visited with a frequency that we should define.
Oh, definitely.
And I do think the number of facilities that one physician can oversee also needs to be very clearly defined. I'm going to be the first to tell you that I'm not comfortable with this whole thing at all. But if we're going to go down this pathway, I think there's got to be some very rigid guardrails around it. Because the last thing I would want to say is we are compromising patient safety to accommodate this access thing. I would be a lot more comfortable saying that we are trying to accommodate this access thing by looking at different ways to address safety as best we can, given these type of settings.
Alternatives.
I mean, I agree, Dr. Jabber. I mean, what we're trying to do at the end of the day is to slow things down to make sure it's well thought out and safe. The efficiency of the, I hate to say I'm not sympathetic to the efficiency of the setup, right? But at the end of the day, the most important thing here is that we slow everything down enough to make it safe, to where there is a decision that's thought about before the problem occurs. Because like you say, when you get in that emergency situation, it's not pretty. And time is time. It is what it is. 3 minutes, 4 minutes, 2 minutes, call it what you want, depending on it's very difficult. I agree to compromise on safety for efficiency.
Hey, real quick, like by definition, we have, this is a spectrum of compromise. Otherwise, why don't we just require that every one of these must be done in an OR suite? We're not saying that. That would be way safer. It's like by definition, what we are having to operate on the spectrum of access, risk, and safety. So just because we're anchored on what's here today, you don't get the high ground of this is by definition the safest scenario, because I can tell you some that are safer.
Yeah, Jason, I don't disagree with you. I think the only hesitation that a lot of us have is that you are looking at an irreversible drug, but that doesn't negate what you just said. I don't disagree with you. I'm just pointing that out as to why this may feel a little different. Kelly?
Yes, I think that one thing you said earlier that made a lot of sense to me was that it's reasonable to start off more stringent, collect the data, register the places. The rules can be changed in the future. This is not the end of end of everything here, and it's better to start out safe, and then you can relax rather than starting out relaxed, and then someone could die. It's when I was teaching high school, they said you have to start out being really strict. Teacher, you can't start out being nice because you can't go back. It's very hard to put the genie back in the bottle. So I liked that comment that you made, Sharif, and I think that starting out with more guardrails is safer for the public.
Gary? I think you're on mute.
I can't hear you.
Excuse me. Anyway, rural hospitals have clinics, and they have physicians, nurse practitioners there. They have empty rooms. They could do it there. So, and they're all over the state of Texas.
I would say something, but I'm not going to. But yeah, you're right. But remember that this is a business also. And I don't think those businesses want to give up the revenue stream to a hospital as opposed to their clinic.
That's true. I was speaking mostly about limiting access. I don't think you would.
Yeah. Now, I will answer Kelly in a little bit of a different way. So if we became very stringent, and if we were challenged then we would have no rule for a period of time. So being too stringent may actually cause us more of a problem as far as oversight. I'm gonna do something that I'm being told I'm allowed to do. I'm not gonna participate in this part, but I want you guys to raise your hand if you are all comfortable, or whoever's comfortable with the rule as it is written right now.
This isn't a motion, it's not a vote.
Polling is fine because you're in public. You're not making a decision. Your president has just asked what people's positions are, and I think there's probably going to be several options thrown out by your president here, which is perfectly permissible.
Seven.
Oh, of course. You said you weren't going to participate.
Okay. So right now, as it stands, it looks like, as it stands right now, with the rules as written, you'd have 7 votes from what I'm seeing. Okay, let me see here. Okay, so let me go to the other extreme without any guardrails. Everybody can put their hand down. Raise your hand if, and this is again a polling, if we were to say that the rules as they are right now, but no on-site physician. And nothing else.
It's basically just removing the word on site.
Basically say immediately available, I think.
Well, it says immediately available. You just strike the word on site.
Only one person? Okay. All right. Hold on. Sorry, 2. Okay. How
I
about?
I don't know if you can hear me. I'm driving,
Yeah.
but I raised my hand.
Yeah, we
see it. We see it.
You're the only one. So it's, or we got 2.
Okay.
So
What if we said, not on site?
I'm sorry. I don't know
Actually, I do.
whether you saw my
Okay.
vote. The first one was my vote also, along with 7, 8.
Okay.
Okay. All right. Okay. Still not a majority. So on site, I got 2. James, were you trying to say something or are you voting?
He was one of the 2.
I was
Okay.
one of the 2 immediately available. Sorry about that. I'll take it down.
Okay. So now we're saying not on site, immediately available, but with immediate video conferencing available.
Yeah, there you
I'm gonna say yes here because there's a lot of possibilities. But like,
I'm giving a very
Think-
big generalities, Jason.
right, but like things like
Same.
limiting, on-site visits and limiting, like there are
Yeah,
other
no, of course.
iterations of
Yeah.
this that I'm voting yes for.
Yeah, I'm just trying to get a very basic premise of where we can go and then kind of build on from that.
Same-ish, yeah. I mean, this is the closest to,
Okay. So we got 3 there.
4. We got Dr.
4.
Martinez. So now we're 4. Ms. Barnes, so you 4 or 5.
Okay. So what about on-site? On-site, not necessarily physically there. Immediate video conferencing available. Limiting the number of clinics that they can be directing at a given time, and specificity around how often there needs to be physical visits and inspection by the physician of those sites at the same time.
So go through that one more time. I'm sorry.
Okay. Saying that you have to be immediately available, which does not mean on site. Immediate video conferencing available, and add on there the guardrails around immediately available by video conference, but also limiting the number of clinics they could be overseeing, and also how frequently, being very specific about how frequently they need to inspect those clinics also, whether it's every 12 weeks, 8, whatever that number is.
Let me ask something. Is geography a component that could be worked with?
They struck that in the-
Or does that destroy the access?
The problem is
model
delegation
to-
has taken that has struck that out. It's either on-site or.
Yeah, Dr. Jones, as you recall, it used to be supervision and delegation was, 75 miles and primary care. All that's gone away. So again, what you're looking at under most of your delegation is, you're either immediately available or, as Dr. Zafran said, but if you start getting into mileage things, you're going to run into a huge potentially geographic problem. I think Ms. Troncosa hit on that. I believe that was in the El Paso area, the Laredo area. That really is, and that's one of the reasons we have telemedicine being so robust now
you might
with
as
the
well.
audio and video.
Yeah.
Yeah, okay.
And I remember that I referenced at the very beginning here that the airway management course has to be robust and has to be very specific and so forth. When we said that they don't have to be on site, did we say that there had to be either a nurse practitioner or a physician assistant on site?
What the rules?
I don't know. I'm not sure.
We know that it's the administration.
What's the
can
rule
veto-
say?
So
Yeah, I
that's what
think
we're looking
so.
at.
It's
all right, the
it's
rule-
NP, PA, or
Yeah,
RN.
it should be one or the. I mean, I hate to go back to billing, but CMS requirements a lot of times require one of those two as a professional end of the spectrum.
Yeah,
to be
but the way the
able
rule
to-
is written right now is it includes RN by itself, which I wouldn't be comfortable with under any circumstance.
Yeah, the current language.
Same.
Yeah.
The current language says there must be an APRN, PA, or RN present at all times when administering PKT.
And I think the RN was in the context of a physician being on site.
Right,
Yeah.
because it goes on to say, and the delegating physician must be immediately available on site.
Okay, so what I just said is at the last suggestion of polling, but restricting it to, it has to be an APRN or a PA on site with very specific airway management skills.
If the physician's not on site.
If the physician's not on site.
Yeah.
And the rule as it's written, it says the airway management course has to be for moderate sedation. So it's at a high level to ensure.
Well, it has to be actually higher than moderate sedation. Airway management means that you have to actually be able to manage the airway.
Right, but we put that in the rule just so it was a minimum floor that you wouldn't get some 2-hour course or something, Dr. Zafran, if you recall. That was why you did it that way.
So that's 9. That almost gets us to a majority.
Well, now you've got 9 showing.
Plus maybe me.
Well, we just got to at
We
least
don't
get to 9.
That gets us
to
to
10 to get us to the majority. Yeah.
Yeah.
So yeah,
All
there we
right.
go.
So that's actually 10 right there. Okay. All right. So it looks like we've got some form of getting closer to some consensus. Yes. So let me just kind of go over what I suggested when we pulled this, and let me know if there's any additional things that we would want to put in there if we went down this route. So we said that if the physician is not on site, then it can only be a PA or an NP with airway management skills up to the ability to intubate, which would be making sure that they can manage an airway, period. Immediate video conferencing availability. Somebody writing all this down? The ability to a maximum of, somebody give me a number of clinics that they could be overseeing.
I mean,
5.
3, not many.
2 to 3.
3, 5, what did I?
I was thinking 5, so 3 to 5.
3 to 5.
Okay.
Is there precedent for that
Bye.
in anything else? I'm
No.
just like coming to a number rather than
No.
just me
The
guessing.
only thing that we have, Jason, is the number of FTEs that you could be supervising or overseeing. And that FTE number is a very loose number because it's 7 FTEs, but that could mean 30 people who are doing a quarter
so
FTE.
going off of that, presumably, like if you had 7 really great mid-levels and 7 clinics, is that too many?
No, I think that's too many, and I'll tell you why. Because those folks are not actively giving a medication to a patient that could be leading to a respiratory event. These are people who could be managing
that's
blood
fair.
pressures,
Yeah.
Presumably
other
all at the
issues and
same
stuff.
time.
And then that's
Okay.
and then I would think geographically that's gonna become more difficult to manage if we're also requiring frequent visits.
How many CRNAs is it standard for an anesthesiologist to be managing at one time?
So when you talk about medical direction, it's 4 to 1.
Maybe that's a precedent.
But
You're
they're
saying-
all
so
in the,
I-
those are all people that are in the building with you, right? That you're managing, they're doing 4 ORs. and
Medical
you're going
direction, you're in
between-
the building, correct?
Right. So,
Immediately
but,
available.
Because
and
if you
so-
go beyond that, because if you do medical supervision, which goes beyond that, there has to be a physician in the room,
it's a surgeon.
Well, I guess one
or
thing,
GI doc, or
one thing to consider. So is if you have, or if we're going to say 3 sites, 3 locations, then that could be 3 locations of 1 PA or APRN each, or you could have 3 locations of 10 each.
Right.
I'm just throwing this out for reaction, but like to me, it feels like the number of APRNs or PAs that are actively doing something feels like the gating item. So like when I hear Sharif say, I can have 4 CRNAs, in a hospital setting active and you're, managing them in some way, like, and maybe that doesn't make sense, but like it feels like you can have 4.
but I'm physically
People
there,
doing stuff.
Jason. The difference is I'm
Physically
physically
there.
there.
Yeah, but you can
I'm-
only be physically in the room if something goes bad with one of them.
Well, but you're there. Even if I have to manage it from across the hall, I mean, there's a very rare setting where I have 2 bad C-sections going on at the same time, and in a scenario like that, I could be literally just popping from one room to the other. But I'm physically there,
Yeah, but
and you're
also
talking about the OR suite where everything is right next to each other.
right. You're also talking about managing like sedated people, not managing the less than 1% fringe risk.
Yeah. I said earlier, Jason, that if we're going to go down this path, I think we got to be careful about being, we're kind of going to from one extreme to the other. If we're talking about clinics that are potentially not necessarily restricted to certain geographic areas, and that, you're doing multiple cases in these where there's not a physician physically present there, I would not equate that at all to.
I don't think I'm being permissive. It started with someone saying 3 clinics, which could have infinite APRNs. I'm saying you can have 4 APRNs at a given time.
I don't think we're
I'm
talking about the
actually
number of
being less-
APRNs. I think we're talking about the number of clinics.
Well, I'm telling you what I'm talking about, which was I was trying to anchor to your 4 to 1 individual ratio. That's what I'm
Yeah, but that 4 to 1 is in one physical setting. I'm talking right now about the number of clinics that person who may not be on site is overseeing.
4.
I think Dr. Tibbles his comment was coming after I was just kind of bringing for discussion that someone could be, they could be managing 3 locations that only have 1 PA or APRN each, so a total of 3 people. Or they could have 3 locations that have 10 PA or APRNs each, and there'd be 30 people. And that's so he's trying to latch onto. It's like
You're saying that multiple cases could be going on at the same time in
right, and it
one
could be hard to
facility.
keep up with all of them. So do you limit it not to the number of locations, but the number of people that are?
That's my
I think it should be
Yeah,
both.
so-
That's,
so
and
if we're
that's,
talking-
I see Dr. Tibble's point. That's also kind of my concern because
I mean,
they could have,
They both need to
500
be-
locations, but if there's only 2 people, well, they're only managing 2 people. But if they have 2 locations and each location is doing a bajillion patients, that's more concerning.
The doctor needs
So
to be
the
able to get to
environment
each.
for this- So the environment for this, if it's for behavioral health and mental, is that at every clinic, or would that be more of a specialty or specialized? I'm just thinking about my clinics when we do medication assisted treatment. there's maybe one or two, maybe. And again, that's the nasal we're talking about, not the IV, which is not, very prevalent in our clinics. So is it really, do you see the usage being that high?
It might get there.
It might get there. I mean, that's the problem with these.
Mental.
I mean,
yeah.
it turns into another med spa kind of thing where just it's the thing to do, and it boils out of control quickly. I mean, unfortunately,
So we're making decisions. We're making decisions on the unknown right now. So maybe we do start very conservatively and adjust as necessary.
And I think the number of locations is really important because the doctor has to be able to physically go once a week. And I tell doctors who want to be a medical director of a place, you need to go once a week during business hours unannounced. You need to go once a week when they're closed. You need to have a key to every cabinet and you need to look at every computer. You need to see what they're ordering. Are they by chance ordering TPN? And you just don't know because they have your medical license and they can order whatever they want and possibly someone will die. And so it's the number of locations is very important. And I agree with Dr. Tibbles, the number of individuals supervised is also important.
I think those have to
be. I mean, what if, I guess you could do something like three clinics or 6 delegates or something like that. I mean.
Let me put another monkey wrench into this. What if you had one location that has 6 procedures going on at the same time? Is there a magic number in one specific facility that if they're going above that there should be a physician physically present there?
Yeah, I mean, the answer to that is yes. I mean, I think that's where I think what Dr. Tibbles was also trying to do was how many can you, I mean, again, the comparison would be anesthesia, right? To what you're talking about. And even then, I think it would be pushing it, but it could be no more than 4 in my mind, right? Without having to have to physically be there, just like you in the OR, Dr. Tappan.
I guess, but the question is the way we're doing it, if we said just 3 locations, I could be overseeing 3 locations remotely.
We would have to put limits on both. I think the number of locations and the number per location. I think there's no way to get around that.
Yep.
Otherwise, we're taking a big risk.
I think that's right. And I was curious what the anesthesia standard was, but I just want to point out a point I made a minute ago, may have gotten missed. The event rate of the thing that the physician is going to need to manage is dramatically different in those two. Like managing like active surgeries where you're sedating every patient and every patient's airway is very, very different than the event rate of the published less than 1% serious adverse event in this case. So it's not apples to apples, but I do favor erring on the side of safety and conservatism.
Okay. So what was the suggestion?
6.
3 locations, no more than 6 total cases going at the same time?
More than 6 APRNs.
Or 6 APRNs that they're over, or 6 delegates, I mean, at a time?
No, just total.
Or total?
Total. 3 locations, 6 delegates.
Okay, and there's nothing here about FTEs or whatever, right? Just 6 delegates, period.
No, that's too easy to game.
Too easy for people to get too confused. They don't deal with that business. Like an anesthesia.
And the other thing that we said is that if there's no physician on site, that end-tidal CO2 monitoring is mandatory. Is that correct?
I think I would.
I will yield to the expert.
I'm all right with that.
Yep.
And how often does the doctor have to
Dr.
visit?
Jones, do you agree with that? It sounds right.
Yes.
Okay, then I do too.
I agree.
We didn't answer that yet, Dr.
What about, to Dr. Green's question, how often should these clinics be visited physically by the physician?
Is there precedent for that anywhere?
Well, the precedent that we have is the OB. Well, I don't know.
No.
I don't think so.
I mean,
the precedent we have is you as the board have the discretion because you're setting new rules for a new area of practice.
Yeah.
to ensure the
understand.
patient safety and manage access, which is what we've been hearing all day. So, yeah,
I understand. I'm just trying to not be arbitrary. I mean, I could say it feels good to me that it's once a month based on absolutely nothing, but that's my answer with zero evidence to back it up other
Yeah.
than how I feel.
But I mean, I think maybe this would help us get around the problem that we all know we have is somebody 600 miles away that never sees the clinic and they're the medical director. There's a lot of people that say, well, I didn't know. I didn't know.
Yep.
I didn't know.
Absolutely.
This
Well,
may
I
be a
mean,
way
how
of
do
us
they-
showing up.
The
You
How
know,
do
you're a
they
medical-
establish a doctor?
Yeah,
How do they
you know.
establish a doctor-patient relationship under those circumstances?
yeah. Well, what you're really trying to do is, because you all got experiential knowledge right now of what we have seen at the med spas, they just go crazy. Chris and I look at cases all day long, and without naming names, we see the same people 40, 50, 60 clinics, which is the problem. That's why here, Dr. Tibbles, what you're saying is, do we have any precedent? Not really. What we have in OBA is, we did the gold
Gold
designation,
Gold designation.
but otherwise it's complaint different and then at other intervals. But again, here, because it is a new and emerging area, you can set something. Again, you might want to balance. Is 30 days too much if you're 200 miles away? Or do you do it once every 3 months, do it quarterly? But again, you can set the controls here to
I'm
determine.
throwing out once a month as a place to start for reactions.
I agree, and again, I think I take what you're saying, Scott. I understand it, but I there's nobody that does these. Let's just put it on the table. Nobody does these medical directorships for fun. They do it for money. And so if they're getting paid, then we're doing them a favor by letting them know. Listen, you're the medical director. This means that you need to know what the policies and procedures are. You're responsible for them. And you're the responsible for making sure that they know how to intubate. Like the medical director should mean the medical director, because the cases that I hear here, they just like look at me like I'm stupid. When we ask, like, well, do you know what you're supposed to do as a medical director? They're like, well, I had no idea.
We might want to put it back out for comment.
So I think once a month is good. I think that medical directors should be medical directors.
Yeah, but I think we're going to get a lot of people today that were concerned. And
Okay, so the other question is now, a physician, so we're talking about who's actually doing the evaluation, because there were concerns about the intake being done in a loose kind of way. Who's actually going to be doing the intake? How's that going to be overseen? And how often does it need to be done? So for example, if you're going to prescribe opioids to patients, especially using telemedicine, you can do it once with a certain number of refills where you're evaluating the patient with telemedicine, but you physically got to be able to see the patient. I think it's once every 6 months.
The chronic pain rules is you have to either see the patient once every 90 days in person or by two-way audio video conference every 90 days for chronic pain treatment.
Okay.
Either or on that. The in-person takes place of it, or if you were doing telemedicine, it has to be the full two-way audio video every 90 days.
Okay.
Is there ever a condition that requires an inpatient evaluation?
And
In person, sorry.
well, we're diagnosing, of course, I presume depression or PTSD or something like that. I don't know if it has to be done in person. I mean, these are psychiatric conditions. A lot of psychiatric visits already happen by telemedicine.
I'll take a firm stance. There's no reason for this to be in person, and you've got licensed APRN or PA on site and present by definition. What we're talking about, we would be taking a major step backwards to require some in-person component for the medical director.
But are we requiring that the physician be the one who visits the patient, whether it's by telemedicine?
That's fine.
Or not? And how often?
I'm taking a stand on the in-person component, but the two-way
I
AV.
think they should.
I was
think
trying to
they should-
dovetail that with visits to the clinic, but
I think they should have a physician-patient relationship at least once in person.
Well, what if they delegated that to the APRN or PA?
Yeah, we got to be really thoughtful about this. Because now you're getting into some other access concerns, which is now you're gating your mid-levels and requiring every single one of their people to have a two-way visit with a physician, like I don't know, it feels like we're going backwards on access with that. Like we either have.
Well, we've already gone backward on access already. So we're already past that. But I think the point I'm making is, how frequently are we going to ask the patient to see somebody, and who is that somebody?
So does it not, maybe I'm too removed, but like I was just assuming that patients that are getting this level of treatment and we're requiring mid-levels on site would be seeing a mid-level
Yeah.
at these visits.
I understand that, but I'm asking who's, like, for example, somebody has to make the initial diagnosis, and if they're prescribing 6 treatments of ketamine, 6 rounds of it, yeah, there's going to be a PA or an NP there. But what I'm asking is, how often do we ask that the physician or somebody see that patient, evaluate them? I'm not talking about them coming in for their treatment, but evaluate them to decide that they need to continue treatment or whatever it is that they may need. I'm not talking about just coming in for a treatment now.
Yeah.
I guess I would wonder if you mean evaluate like the mid-levels evaluation and treatment plan, or if you mean actually establish in real time a two-way, audiovisual visit from patient to physician.
That goes back to, there's 2 different things I would look at, and that's what I was trying to get at with the medical directorship. Maybe this would, because our we don't really, the rules around medical directorship are just you're responsible. There's no intervals, this or that. A lot of that has to do with billing. A lot of those headaches tend to go around billing, which is not really our concern. But I think that this is where that medical directorship has to mean something. And we're not really prescriptive as a medical board on any other specialty about how that's done, as long as they look over the records and realize that they're responsible for what they're signing off on of their PAs or nurse practitioners.
So if I can make a suggestion, we already have very specific prescriptive rules around chronic pain.
Yeah.
And I think if we want to keep this clean, I would probably suggest that we mimic the rules around chronic pain, prescribing and all that kind of stuff, which involves telemedicine also. That way, I think we're consistent.
I agree with that. I agree with that, because otherwise we're just kind of putting something else out there new and confusing.
So I think we've kind of put a lot of guardrails right now. Am I missing something?
I just would personally reserve the right to review those rules before it sounds right, but I can't spout those off the top of my head. And so I'm just saying.
Well, I think we're kind of going way beyond that right now. We're having a conversation over here as to whether we made changes that go beyond being able to pass it today, or whether it has to actually go out for comment again.
Feels like it. We've done a lot.
Comment.
I would think that we would want to, again, that there are definitely some changes going on here. I think we'd want to at least take a break once we kind of conceptually think, this is the list of all the stuff that we've talked about changing, and maybe give staff time to, I don't know if we want to make the changes so you guys can see it, as Dr. Tibbles said, and then make a decision on whether or not this is kind of meeting the intent of what you guys want. And then we'll have to talk also with whether or not this is substantive enough to require putting this back out for public comment again before final adoption, or if this is within the logical outgrowth exception in the APA to continue forward. So there's some unknowns at this point. But to Dr. Tibble's point, I think we do want to at least put it in writing so you guys can see it.
Yeah.
Yeah.
If anything, that'll give us a chance to get the whole board to familiarize them. So, because some of the caveats we're talking about, some people may not really deal with every day, so that they understand what they're signing up for regarding these caveats.
So what I think you could do is, oops, go ahead, Dr. Jones. I'm sorry.
Oh, no problem. Sorry. This has been a really productive discussion. I'm not sure if we're closer to the answer or further away. I think, there's an effort to kind of meet in the middle here somehow, but it's challenging because, the initial concerns were access, right? And, I still wonder with regard to just the initial draft of this, you know, we're just shifting the chairs around on the deck here. We're giving back CO2, which we had already decided with stakeholders for, you know, a good period of time, that we decided to, you know, remove that. I'm struggling to see kind of where this goes. We're so close to getting over the finish line, just like at the beginning. I almost want to just make a motion and see where it is, just as is, and if it doesn't pass, great, then we move on.
You
So
can.
I'm just going to do it.
You can do
And
it.
feel free to vote how you feel. I'm going to make a
Wait,
motion
Zach,
to.
can you,
Oh, sorry.
can you make, I just need okay, can you make
I'm
very
waiting.
clear what your motion is?
I'm waiting.
No, I just wanted to,
Yeah.
very clear what you were gonna motion.
Sure.
To adopt,
I
I
am
think it
gonna
was
make a
going to be
motion-
drop the rule as published with the minor changes that board staff indicated.
So just what's already in your Laserfish folder.
You would adopt that as the final rule and it'll go into effect in 20 days.
Yeah, none of this other stuff we've talked about. It's just what's
Yes.
was presented to you guys this morning.
I would make one change. I'd make one change. It would go into effect in 180 days.
No, it has to go into effect by the Texas Register 20 days after it's published. If you're talking about the phase in or helping people come in compliance, we will do that internally with notice and publishing the registration forms, et cetera, et cetera.
Okay. I just want to make sure that.
Yeah.
So, yeah. So then let me start over. I'm making a motion to just accept the rules as written, with the small changes that board staff have made that we've all looked at. Do I have a second?
Second.
Second.
Is there any comments, discussion? All right.
No, but
all
I
those
do
in-
suggest we one by one roll call this vote.
Smart idea.
Okay, let me flip. Let me find that. There we go. I've been writing all over stuff.
Yeah. That's
Okay. All right. So we have a motion by Dr.
it.
Jones to
Don't worry.
accept the rules as published, except for the minor changes that were made by staff and that are in your Laserfish folder that you guys have had all day. And it was seconded by Dr. Zaffron. All right, we'll start going down. Dr. Zaffron.
Yes.
All right. Dr. Farmer. Nothing. Mr. Kokonos.
Yes.
Mrs. Barnes.
Yes, if you have all the changes in there.
No. The motion is for what is sitting in Laserfish right now.
We didn't make any change.
And
All
that's
this
a
stuff
yes, if those changes
The
are there.
original document.
yeah, the original
Send the
document.
what we had all day is what you
Yeah.
said.
Yes.
Yeah, if those changes are there, then I'm fine.
Okay.
The original changes.
Yep. All right. Dr. Bhatia.
Okay.
Okay. Mr. Crane. See?
Who's there?
He just turned.
We can't hear you.
Okay, I said yes.
Yes. Okay. Dr. Deloche.
No.
Right. No. All right. Mrs. Del Rosal.
No.
Dr. DeStefano.
Yes.
Dr. Green.
Yes.
Mrs. Herod.
Yes.
Dr. Jones.
Yes.
Dr. Martinez.
Yes.
Okay. Mrs. Morgan.
No.
Dr. Naidu.
Yes.
Dr. Quinones.
Yes.
Dr. Tibbles.
No.
Mrs. Troncoso.
No.
Dr. Vanderwiden.
Yes.
All right. Let's double check our count though. We got
I think 11, wasn't it?
4. I got 12.
Yeah, I got 12.
12 for 1, 2, 3, 4, 5 against, and 2 not voting.
All right, so it passed.
Yeah,
All right.
he was the first yes.
Okay, very good discussion. Thank
Agreed.
you, everyone.
I appreciate everyone talked about it.
All right, back to our agenda. I guess the only issue that we have right now is the consent agenda and open forum for public comment. So is there a motion on the consent agenda?
Quinones motion to accept the consent agenda as written.
Motion by Dr. Quinones. Is there a second?
Second, Green.
Is there any discussion? All those in favor, please say aye.
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 All those opposed? Motion passes. Before I go ahead and adjourn, is there anybody here for public comment?
Let's see. Just want to make sure. hold
Sharif,
on.
we lost you.
Hi,
Camera
one
feed.
second. The boardroom
Oh.
camera just reset or whatever.
Okay.
You can still hear us though?
Yeah,
We
Yeah.
can still hear you.
Yeah, we can hear you.
We can hear you.
All right. Well, we'll have to wait until the video is restored.
All right. Is there anything else that we need to do on the
well,
agenda?
we'll just talk because we're not voting here. All right. So did you already say these other
Sheila
numbers?
Hemphill here.
No. So let me just kind of go over everything. So 21, discussion, recommendation, and
We
Oh,
lost
we
you.
lost you now.
I'll
lost-
message.
we
I'll
lost
message
audio.
1 second.
The audio goes as part of the restart.
IT is telling me it's going to take about 3 minutes to reset the audio video system. I don't want to say to step away just in case they come back quicker than that. But if you need like the fastest potty break in the world, this is the time.
Dr. Zafran is on his laptop too.
hello.
Hello.
We can hear you.
Okay. Hold on. All right. Hold on, guys. Hold on. So you guys can hear me now, correct?
Correct.
Okay.
Nope,
We
we
can't
lost
hear
your
you.
audio again.
We lost you. We can't hear you, Sharif.
Hold on. Hold on. All right. Can you guys hear me now?
Yes.
Okay. All right. We're trying to make this work. Okay. All right. Sorry, our system is down. That's why we're having to deal with this. But I think you guys can see me, right?
Not really.
All right.
Yes,
Can you see
we
me now?
can see you.
Oh, yes, we
Yep.
see you now.
All right. I know I'm not Chris Palazola, but it's me. I'm using
No.
his computer.
No, the public cannot see.
Okay. So I'm just going to go down the rest of the agenda items, and then we're going to go to public comment, and then we'll go from there. So I think 21, discussion, recommendation, possible action regarding proposed rule amendments to 22 TAC. There's nothing there. 23, there's nothing there. 24, there's nothing there. 25, there's nothing there. 26, there's nothing there. And 27, there's nothing there. 29, also nothing there. We have already done the consent agenda. So I am going to go now to public comment. And I see Ms. Hemphill's hand raised. So Ms. Hemphill, we're going to give you 3 minutes 1 second here. There we go. All right. So the floor is yours for 3 minutes.
Okay, I'm unmiked. I cannot find my clock. I'm flipping through.
Well,
the
we can't hear you,
views.
ma'am.
I'm speaking.
We
Hello?
can hear her.
We can hear her.
We can hear her.
We
Okay,
can
the
hear you.
problem is,
Sheila, I see you, and I hear you.
okay,
All right.
we're here now.
Sorry.
But
Maybe on
what I
our
do
end.
not have is my clock.
There we go.
I'm-
Okay.
Uh,
We're
All
ready.
right. There we go.
Wait,
All right.
no.
We're gonna
I
ask
need
you
my
to start for
clock.
3 minutes.
I need my
We're gonna-
clock.
The clock is
The
up.
clock is up.
at 3 minutes.
Well, I can't see it.
Change your
I'm clipping through. I'm clicking through the views. I've seen it in here. I don't see my clock.
The clock
If-
is
Well,
there.
everybody can see the clock, Sheila. Go
Well,
ahead.
not me. It's my 3 minutes. I've had it earlier. I could flip through the views. And no, I don't have a clock. It's been showing up on the slides. I have a right to see the clock.
Well, keep flipping, hon.
Okay.
I am going to
Can
put my
somebody
phone.
tell me what slide it's on? I am on gallery view. And on the side, I've got 10 other people here that are probably all members of staff. This
Can
has
you
been
pin-
I'm not,
Okay.
where can I
Can
get
you-
my
Can
3
you
minutes?
pin Sarah
Can you see?
Johnson?
Can you see my phone?
No.
No. I cannot see. Can somebody pull the clock up and pin it to the gallery view? Or I think gallery views are to each user.
It's on there, ma'am.
Okay, I'm glad I'm filming this because this has been a really disturbing board meeting.
Sheila,
okay,
Sheila,
wait,
Sheila,
we're
we're
about
trying
to-
really hard to
Thank
work with
you.
you here. Can you
Well,
see? Can you see the clock yet?
No, sir, I am on slide 7. I flipped through it. I had it earlier. I know it exists. And I don't want to linger this on anymore. But you know what? There was a reason why I asked for y'all to put on the agenda that citizen comments would not be before 9:30. So we, the public, could come and be heard for what, 3 minutes? And how many you have for comments right now, for public comments? 1, me? And it is nearly 3:30 because there was no consideration for the public to come in and be heard in an expedient manner.
Your time is
Okay.
going, ma'am.
Well, where is it? Somebody
Got
just.
2 minutes, 35 seconds
Okay.
left.
All right. I don't mean to be obstinate. What I'm seeing here and what I saw today, I saw a very fatigued board. I listened through all of it. I didn't hear one time that anybody gave him stats to substantiate what problem you had that you're trying to solve. How many people told me how many people have died from I'm talking about prescribed under clinical, under your particular advanced nurse practitioner, your clinics. How many people have died? How many complaints have come in from the public? Did I miss it? I didn't hear it. This was, who was it? Somebody said moving, I think Zach, I think it was you, shuffling the chairs on the Titanic on making this decision. But I will tell you, I've been attending medical board meetings from 2016. I was a regular for about 4 years and I want to help. And I think Mr. Freshour and Mr. Carlton, you can credit the fact that y'all even have a complaint policy. Because when I started in 16, the medical board never had a complaint policy. That happened July 2nd, 2018. It was a link. There was a tab when you said file a complaint, it was file against the licensee and it had file against the agency. Guess what? With your new website, you know where it is? It's buried under Compact with Texans. Like we, the public, have a clue who Compact with Texans is. Okay. You also had
You have 1 minute.
Thank you. You also had an incredible decision in June of 2020 that gave authority for the physicians. I don't know why I'm echoing. They gave authority to physicians to treat COVID with ozone and any other therapy the physician thought appropriate would be available under our complement and alternative medicine rules. Those links are gone. I know this because legislators are asking me things about the medical board. And y'all don't know me. Some of you don't know me. I end up defending the medical board because I get calls from physicians and I get calls from patients. When we got that, Brent, you'll remember this. We got the first complaint policy. Really? You're gonna let me sit here because y'all didn't have any respect for the public to get me in
Sheila,
earlier.
Sheila, I'm
I'd
going to give
get
you,
out of
I'm
here.
going to give you an additional minute, but that's it.
Thank you. Okay. Look, I'm trying to give you kudos here.
I know, I understand. You got a
Okay.
minute.
Okay, thank you. The medical board never had a complaint policy. The governor appoints the board. There never was a complaint policy with the governor. July 2nd, 2018, the board came out with a complaint policy. I had links to it. We had our first complaint come through in October 2018. And here it went, Brent. Mr. Carlton, you evaluated the physician's complaint and you evaluated your staff works on the files and you found no problem with the procedures that were done. I said, really, how do you expect there to be any integrity in a complaint policy if there's not an independent third-party review of the complaint? And Brent, you said, I couldn't agree with you more, but the legislature has never set it up that way. So you know what happens when doctors start complaining about no oversight of the medical board? I said, you are absolutely right. And it is a horrendous problem that's actually causing doctors not to come to Texas because of the stories that revolve around the medical board. But it's not your fault. I said, it's the legislator's fault. In the aspect that the current rules, and this isn't y'all's fault. It's the legislator's fault. But if y'all don't
Right,
get
ma'am.
behind us to make
Your
rules
time-
to make this kangaroo
your
administrative court not
time
be
is up, Ms.
substantial
Hemphill.
evidence. Thank you.
Thank
Hope
you
to
so
see
much.
you in the Capitol. Sheila
Thank you.
Hemphill, TexasRightToKnow.com.
All right. I
Thank
believe
you.
we have another person with their hand up for comment. Tim Veltz.
You're on mute, sir.
You're on mute. Okay,
Thank
you have 3 minutes.
Thank you for pointing that out. I just wanted to confirm y'all had a very extensive, heartfelt conversation about the ketamine ruling, and I noticed some confusion on what the actual vote was for since so many changes were discussed. Am I understanding correctly that just the original language that was proposed is what was passed?
The motion that was presented on the floor was the original language of the bill with the minor edits that the board staff had placed on. Yes.
So to clarify, some of those changes had to do with like moving the in-title carbon dioxide analyzer to some equipment that needs to be readily available. So there's a few changes like that were made, but
Okay.
by and large, it's the rule that was published.
So physician on site is still required.
That was what was in the vote that they approved. Yes.
Okay, well, I appreciated the discussion from everyone. There was a lot of really fantastic input. Also just a bit confused after the polling and just wanted to make sure all board members understood what they were voting for.
Those who asked were very clearly explained to them and they verbalized understanding of it, but yes.
Thank you.
Anyone else want to raise their hand? Okay, so I am going to ask if there is a motion to adjourn.
I'd like to make a motion that we adjourn Herod.
Second.
All right, Ms. Harrod with a motion to adjourn. Is there a second?
Second.
It's been seconded. All those in favor, please say aye.
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 All those opposed? All right. We are adjourned, and I look forward to seeing everyone here in Austin in June. Thank you, everybody, very much.
We
Thanks,
adjourned
everyone.
at
See everybody.
3:17 p.m.